splinting, and is a very useful concept in such difficult situations. I would agree with you in difficult situations. It's a very good
Something.
Very good product.
Yes. Then there is no hold of the fibula graft. If they pass through the space, maybe they would some hold. But it's very, very unlikely because there was total bogda there. There was nothing. What kind of, what, I agree with you. Thing is, once I have a good construct, very stable construct, as you can see, that's why I've taken a video. We kept on moving, nothing happened. It was absolutely stable. I thought that enemy of good is better. If you try to pass a screw, if that strut breaks, then you have lost whatever stability you have. You need a very good stability. This is third post-op day. That's at 6 weeks, able to lift the leg. At 10 weeks, knee bending started. So whatever movement, I mean, obviously he's not going to have good movement, but by 10th week, he was able to do knee bending. There's 16 weeks. There 28 weeks. Video going to come in? You can see it is consolidated. His partial weight bearing for almost about 10 weeks now. Right, hello? Okay, I'll go further. This is at 11 months. He has a decent knee movement. Now, when you start celebrating, there's a problem. So, if you want to spoil your results, you need a good follow-up. So, this is what happens. He comes with a stress fracture. Now, what do I do? Now, do I fix it? Because I have a good proximal segment, I have a good distal segment. Do I use a plate now, internal fixation? So in fibula, in grafted fibula, this is a good thing. All these fibulas, long fibulas, invariably develop stress fractures, develop callus, and it heals. So don't worry about stress fractures of long fibular struts, whether it is live fibula or non-microvascular fibula. No, they break. It is consolidated at the end. In between they break and they start forming bones. So all these stress fractures, invariably, if you read plastic surgery books or papers where they have done microfibula, the average rate of stress fractures is 1.8. Every case may have up to 2 stress fractures, and then they develop callus and heal. So all these stress fractures like this. This is at 14 months. We send the photographs from village and completely. So these stress fractures, don't worry about. Yes, please. We would have, if we had got a good stable proximal fracture. I will ask you one simple question. If the proximal fibula breaks, what are we going to do?
Plate will take care of the remaining fibula part. No?
Sorry?
Plate is there, no? It will take care of the remaining fibula.
No.
Because you are
The
breathing that
plate
fibula.
will have no hold proximally. I have shown you the photographs. There was no hold in proximal fragment at all.
Anyhow, you are immobilized this patient for 1.5 months to 2 months. You are not started weight bearing immediately.
No, we are not.
Okay.
Are
So
not.
this 1.5 months and 2 months is sufficient part to get a consolidated fibula at that proximal side. So This will give advantage that this stress fracture will not occur in the future.
Absolutely right. My question is, if I do not get good, stable internal fixation, what is the use of putting a plate?
I agree with you.
Correct.
with your
If we are
thoughts, sir.
getting a good,
but-
stable fixation proximally, then there is absolutely, I mean, we started off with that. You see, I put in a medial plate and realized that they were going in total tunnel, total air. In that case, what is our locking screws going to do?
The concept of locking screw in the osteoporotic where we do not have any hole.
Nine.
Because, sir,
Locking screws have to have some hold. You can't say that they can be passed
sir,
in
it
air.
will not- it will have at least 25-30% hold at the proximal fragment.
So
That chances of stress fracture will be minimized. The period of rehabilitation will be minimized.
all long fibulas develop stress fracture, even if they are fixed. That's what I'm trying to say. Even if they are live, long fibular fracture segments or bone graft develop a stress fracture.
The chances of
Even with plate, that's what I'm saying. Even with internal fixation, they develop a fracture. And it is considered to be better because they develop callus. They develop callus. So don't worry about stress fractures of fibula after long fibular struts. They help you. They help you to develop more callus. So that's what I'm saying. If you go through microvascular surgery journals, all of them will show that fibula fracture has occurred and limb has consolidated. The construct has consolidated. So this is considered to be a good thing and not bad thing. And as I said, or otherwise, you need anchorage. It may be little less than conventional plate, but you need anchorage. See, initially all locking plates came in with unicortical screws, thinking that you don't need stability, you don't need anchorage. All of them failed. That is why we have started with bicondylar, rather bicortical locking plates. You need some anchorage. So go, yes, please.
mind complain of any knee pain while walking or while
I can you speak loud?
did he complain any knee pain while walking or
At the moment, no.
no.
At the moment. Maybe he'll need a joint little earlier than others. Agree, absolutely. But at least now we have a decent proximal fragment. By the time he reaches the stage where he needs a joint, this would be completely reformed, except the posterior, of course, shift, which was impossible to correct. So I take you back to this paper, 1990. And in fact, I'm going to stress more and more on this concept. This is 1990 paper published by Dr. Kothari after extensive experimental work. That bone is like air in a tubeless tire. It gives rigidity and shape to the tire. In return, it takes shape of the tire. It is independent. Now, it's a very controversial paper, but I'm sure you would, if you go back to your cases, you'll realize that it is very, very true. The last, fourth thing is very controversial. Nothing is attached to bone, tendon, ligament, articular cartilage, nothing is attached to bone. So, if you have a cavity, a clean, uninfected cavity, and have, last, most important, it fills casing or envelope provided by soft tissues around. So, if you give a good casing, bone will form. And it will take that shape. Not just it will form, it will take the shape of the casing. So if you create an envelope of appropriate size and shape, maintain its shape, and even if you add meniscal bone, it will form bone. Minimal quantity of bone. I'm not saying every time you do that. All I'm trying to say is if you have a good cavity and if you support it, of course, it needs support. Internal, external, bone graft, anything. But the shape has to be maintained. with minuscule quantity of bone, bone will form hypertrophy and take shape of that bone. As I said, controversial, but I'm quite convinced about this. Anyway.
Any
Yep.
questions from audience?
Yes.
दिख रही है?
Can you use some?
वही दिख रहा है मुझे डर यहाँ समुंदर और इधर
See, as I said, I had kept all options open. I had kept all types of plates, everything. But it was the upper fragment, there was nothing. There was nothing. It was only a shell of bone. Laterally, there was practically not even a shell. Medially, I tried to put a plate. We put a screw inside. There was no bone to hold it. There's no bone to hold it. So maybe we could have thought of an arthrodesis. I mean, we consider all those facilities, all those modalities. But arthrodesis, I thought if you can get even 30 degrees, 40 degrees, 50 degrees movement, we have already, now we have a 70-degree movement. Why not? I mean, it was a risk we took. We discussed at length with patients. Must have spent about 2 hours in discussing at various times with various people. That time we said that we will go in with this. Maybe he'll need an arthrodesis. Maybe he'll need something else.
Indeed, a healed, uninfected union is nothing better than that what you can give to a patient. He should be ever grateful to this thing. But just for academic purpose, now he is having 70 or 60, 70 degree range of movement. That is very good and social to be at places like. This will come certainly with experiences for people who do such type of cases. But then eventually giving it a...
Just 1 minute. I'm a little hard of hearing, so if you can speak loud.
Sir, I guess the end result was very gratifying. Had it been given a thought of fusion, maybe probably that would have corrected the subluxation, that would have corrected the infection, that would have corrected the shortening, and probably would have been less cumbersome to the less tedious mentally to the surgeon and the patient. Just thought.
There are many ways to skin the cat. Many ways. There are various ways. The idea of presenting this is A, develop a clean, uninfected cavity. Your first and foremost and even last aim is to create a clean, uninfected cavity. Then you can do whatever you want. What fixation you do is not important. You do a very aggressive debridement, very aggressive, excise whatever infected, peri-infected, sclerotic bone in infected non-union, good flap cover, and then you can do whatever you want. There is no problem. I will not say that whatever I did was the only or best thing. You could have done a plate. I am not saying no. But the first thing was the most important thing. Creating an uninfected cavity with a flap cover. Yes, please.
Please tell the name. Introduce yourself and then ask the question.
Sir, myself, Dr. Anil Dule, applying the same principles in the paper, the bone, the non-union side has been already debrided. So just sir, applying the ring, distracting the knee joint and doing the distal corticotomy and then transporting up, will it help?
It could, provided you have a decent proximal hold. Here, getting a proximal hold in tibia would have been difficult. So you could go above the joint. Try, absolutely possible. As I said, hardware is not important. Software is. I mean, we have been stressing on hardware again and again and again. What we are forgetting is biology. The idea of this controversial case was not to show that hardware is important, but not as important as biology.
So I think 15 minutes is less for Dr. Akash sir to teach the infection. When I used at Hinduja with him, we used to say to the bugs, "Bhag ja bete, you are in Dr. Akash sir's hand." So what we've learned from this case is stress X-ray skill is full. Excise all the scar, have plastic surgery backup, aim for good vascular thick cover or the non-union site, have your plan ABC ready on table, and it's a team work in a complex cases, and jam the canal with small pieces like a jigsaw puzzle. So with this, I would like to call Dr. Aditya Menon, very good friend of mine, consultant at Hinduja Hospital, orthopedic infection consultant. Dr. Aditya, over to you.
Dr. Abhishek. To this case, I would request, I think there are some PGs here, want your active participation. There's no right or wrong. I think from the first case, you realize that no orthopedic surgeons will agree with each other. We'll all keep arguing and fighting, but ultimately you want the best outcome. So please be active. Give your opinions, right or wrong, doesn't matter here. And before I go ahead, even in the previous case, as a team, we felt that arthrodesis is a very, very good option in this case because salvaging this would be more of a challenge surgically. But the patient and his father were very, very keen on having some mobility. They said, sir, 20 degree aayega to bhi chalega, lekin paao seedha karke mat chodo zindagi. So that was the idea, to give him some movement, and ultimately he'll require a joint replacement at some stage to delay that joint replacement and hope for the best. That was how he went ahead. Coming on to this case, I hope I'm audible. Yeah. This is an infection following a short PFM nailing. So this is a 76-year-old gentleman presented to us 2 years after a nail done for a right IT fracture. He operated elsewhere, united well. There were some surplus wires as well. He was hypertensive, non-diabetic. Nail was done, and he had pain and swelling 2 months before coming to us. And almost a year and a half, 2 years after the primary surgery. He was uneventful till then. Discharging sinus for a month. Had taken a lot of antibiotics, but the infection continued. This was the clinical picture, scar with a sinus, and the X-ray showed a nail inside. So at this stage, I would want to open it out for a discussion. These are the options. Antibiotic, do we continue the antibiotic? Do we increase class of antibiotic, give him higher antibiotics with maybe intravenous? Or we just do a soft tissue dissection, remove that sinus, scrape that sinus, close him, because doing an implant removal with either whether nail or surplus in this case, with a 2-year-old fracture with so much bone is going to be challenging. So opinions from the delegates from senior faculty. Option C. So that's one option that we've got, remove the nail. The labs were, WBC was normal, ESR was, okay, so just go in, do a standard implant removal and leave the sinus. Okay, so that's option E. So option E is you remove the nail and put an antibiotic. If you find that there is medullary pus, you put an antibiotic rod inside. So here, CRP was elevated, ESR was elevated, but WBC was normal. He had not severe pain, he would get pain on and off. So it started with pain, the minute I think sinus the pain settles. It close for a few days.
So my option is option D. Because wires can be act as a source of infection, so I have to remove the wires also. After that, I have to do the material for culture sensitivity, and according to culture sensitivity, I have to give the antibiotic for minimum 6 weeks.
Absolutely.
For that patient, as the fracture is already united, try to keep that implant as a source of infection.
Correct. So what is
I
suggesting
can
is
ask
to remove the nails, remove the wires, send for cultures, start targeted antibiotics. So what about the right ahead, we'll go ahead with this bit of flappy lateral position. Now, sorry, one slide is here.
So Aditya, if I can ask you a question.
Yeah.
So that type of exuberant granulation at one point, would you infer something on that?
Would I infer?
Would you infer something on that present?
That florid infection would suggest that there is something going on inside. It's not just a subcutaneous infection. Coming from somewhere within the medullary canal and the implant, since this is an implant inside. So the sinus itself happens over a period of time. This doesn't happen overnight. It suggests that there is a medullary infection and we must preempt that medullary infection and plan ahead. Yes, sir.
Do you think of doing a sinogram in this patient to know where the sinus is taking you?
Absolutely, sir. Absolutely. So sinogram is an extremely useful tool. It's done with an X-ray or a you can inject the dial a day prior. That sinus tract will lead to wherever the source of infection is, and that gives us an idea about where the infection is. And we can see a lot of surgeons even now use methylene to inject in the sinus. So the minute we see it, that is where the infection. I think we all agree with this. You're seeing only the tip of the iceberg. What is actually there is deep inside. So following the sinus tract, accessing the sinus tract is when we actually lead into the original site of infection. So this was the position given floppy lateral. You see the incision, a long elliptical incision, excising the scar and the sinus. Now the idea is not to incise and not to go scar. Because what happens is the infection comes from within and the scar underneath of the scar is also infected. So you must go around the scars, make sure that whenever we are dissecting, we are reaching clean soft tissue. The minute we see the soft tissue which is being left behind is also infected, increase the width of the scar, especially in thigh. It's so supple that closure is generally not an issue. Make a wide incision, go wider if you feel that the surrounding tissue is also necrotic, but try and remove it in one big bulk like you would do for tumor surgeries. So we see tumor surgeons going in, they go through clean tissues, they go through clear margins. So this is abnormal, they would say maybe take 1.5 centimeters more. That is what we should do for infected cases as well. So you can see instruments holding both sides, going from either side, going deep up to the femur. Expose the implant before attempting any removal. The distance to the head. So all of this will be both the head screw and first coming out. Head screw is obviously going to the head, that means there is so much pressure is actually coming out. So it's not just about implant, more than that. So straight ahead, the implants are practically used at the side, remove the nail. Now, like correctly suggested, the wire should also be removed. What happens to the surgical wire is, so it becomes extremely difficult. Spend some time, use a C-arm intraoperatively, pick out the bone using osteotomes, nibbler, cutters, find those wires and remove them, because any wire can be a source of infection. Very difficult to whether the infection is communicated with the wire. Assume that everything is infected in this way. Try and remove all the implants if possible. Again, I would want to know after discussion, is there anything else that you should do? Implant now. Perfect.
So how much you will be?
Only up to the tip of the nail. The whole femur should be removed. The whole femur should be removed. That's the next perfect step. Anything else? Antibiotics, maybe we can wait for a few days or put empirical to cover positive, negative. When we ream, correctly suggested we must use entire canal and more than the size of the nail. Where did the reaming material come? Absolutely. That's the one take home apart from the other things in this case is make a distal window.
Sir, Mike.
Yeah, which is not that much a big window is not necessary. You can just make a small vent. The just vent is for what? To prevent pulmonary embolism, not to drain out this. This window is going to be a problematic for the fracture. He may develop a
Absolutely. So pathological fracture.
don't give any.
Second is already holes of nail is there. No? Entry point of the PFN is already there. It is a big one. If you see the size of the proximal part, it is around 11 to 12. You can pass a reamer through that easily and put a negative suction from that reamer. That's entry point only. You can remove all the medullary cavity material. Then that to the cultural sensitivity and upper, depending upon the cultural sensitivity, will take care of the infections.
We agree. We understand that distal hole is a big stress fracture. That is one stress to us also. What we realize is, although we have a screw hole at the distal locking site and the entry point, the infected material is actually a biofilm. It is not pus that will come out through a vented hole. One small screw hole will not let the biofilm come out because the medullary canal is completely covered with thick membrane. That is the source of infection. That thick membrane, when with suction, sometimes doesn't come out. It actually has to be grabbed and pulled out.
What the book says that you just create the raw area at that particular site to get a good circulation at that particular site for the penetration of the antibiotic. If you are doing a reaming with a bigger size, you are creating a raw area part for that particular biofilm area. So it will allow the blood to circulate there. It allowed the antibiotic to penetrate at that area. So it will take care of all the things. Instead of doing a distal or making a chances of pathological fracture in future, again that patient will come to you and trouble you. So instead of that, you can do a minimized things with a good result, I think.
I agree. But what you rightly said is, once we ream, that area becomes raw. What about the tissue that has come off from that area and is going to stay distal?
That won't come out with the suction.
It's thick tissue, right? All of that. It's so thick tissue, whatever comes out is just 20-30% of what is actually there. It's thick. We actually had a whole cup full, vati full of membrane which has come out from the window.
So the distal window tissue was sent separately for culture.
So we send the one sample and the medullary reaming which is actually used to papers from the distal window to pull it from separate sample. Now whether it goes to different bacteria, that's irrelevant. The message was, yes, pathological fracture is a big stress for us. as surgeons, we also don't want a patient has come with an infection for an implant. We don't want him to have a pathological sign. But we had cases where we've not made the window and we had a case of a distal ankle, septic ankle following a arthrodesis, where we didn't want to make a window. So there we had to read from calculation. We didn't want to make a window because it would get fracture blocked. The reaming material went inside because it would obviously go inside. Pull it out, but ultimately that causes.
Dr. Dhure sir want to ask question.
Holding long endoscope forceps. We can also use for this purpose instead of making
We need 38, 36 size gravity. We have them. If somebody can make it and we can actually visualize it, fantastic. That is something I think we should. So revision hips. Yes. So Chandler sir, I think already has that.
Yes.
And I think those are things that we should get, but we have to ensure that we remove the entire tissue from inside. That was the message. Whether we use. Yeah, and for osteomyelitis also we make bigger cavity. So we make large windows, almost 22 centimeter size for osteomyelitis. They should be oval, not square, no sharp edges, and they consolidate over time. So stress fracture happens with sharp edges, square windows, and it's not oval enough. Otherwise, they do consolidate. Yes, they have to be non-weight bearing and partial weight bearing with support and avoid excessive torsional movement. Those are things that they have to be careful about. But the message here was whether we use long grabbers, whether we use a window, the literally biofilm has to come out. We cannot leave it inside because that does cause secondary infection. We had that in a few cases where we try to avoid a secondary infection. Popular distal window. Non-weight bearing or partial weight bearing.
Thank you, Aditya. Any questions from the audience? Okay. So with this, we move on to next presenter, Dr. Chandak sir. I would like to invite a renowned orthopedic surgeon from Nagpur. He will present his case. Aditya's case, what we have take home message is remember to excise all the scars, thoroughly ream the canal, put the antibiotics bed throughout the canal, and keep your revision hip sets, longer scoops, longer disc forceps ready to debride thoroughly.
morning, everyone. Presenting an interesting case. Just to comment on the previous case about the windows. From the engineering principles, if you take a cylinder and section in the cylinder is less than 1/10, it never loses the integrity of that cylinder. And as you said, the edges are smooth. It is not sharp edge, as is one of the end of the bone. Very less chance of developing a pathological fracture unless a significant trauma happens. Like even texture and person who has classification of osteomyelitis common. Classification of osteomyelitis. Surgery Medal. He and Kevin Testor has published a paper on debridement in osteomyelitis. That exceptionally good paper, and they say that up to 20% you can eat. There's no problem at all. They have done CT scans and realized that up to 20% is no problem at all. And please use that paper. So presenting this case, it was a well-healed fractured distal femur, had a floating knee injury in a 35-year-old male, and he had flexion from 0 to 40 degree, as commonly happens in a floating knee injury. The knee movements are restricted, and most of these patients, being young, would desire a further knee flexion. That was his desire. He fractured tibia and femur healed. This was post-op 3 years. No pain. He was working in a vehicle factory and wanted implant removal. Went to the first surgeon, the surgeon who operated him, and he wanted more flexion. So at this point of time, any opinions whether implant removal at this point of time would lead to more flexion? As many times we may promise them 5 to 10 degrees may improve, or are there any other options to do that?
Was there a bony block or it was just a...
The clinical examination, as I saw him, was absolutely normal, non-painful, only 0 to 40 degree. The patella was mobile, but however, the quadriceps muscles, as externally seen, were possibly shortened or stuck up to the femur. That was the presentation. No extra bony swelling, no extra obstructive thing in the joint per se. That was the clinical finding. So, as it all looked healed, he was working normally. The first surgeon removed the implant. And these are the X-ray after implant removal. Being an insurance case, he took X-rays also post-operatively and allowed him around 6 weeks of rest. At that time, he went to his factory doctor who issued a certificate that he is fit to join duties. So even that had a medical, legal, clinical implication. When do we allow a person to join back duties? So he joined back. Any opinions here on this X-ray? Yes, absolutely. So there was a possibility of a stress fracture, and anything which could have prevented that. So at this, not to remove implant would be your choice. So assess complete union process is one. Never remove that implant. Yes, sir. A very good suggestion. Certain, yeah. A complex situation, multiple plates, orthogonal plates. It is a good suggestion to remove implant in stages, that so that the bone matures further. I think it's a good suggestion. Yes, sir. You want?
Sir, if at all you are surprised on table that you have done an implant removal and now you realize that there's some vent or window, there's some weak point that is left at that point of time. The bone, whatever range of movement you could improve, that's a different part. But then at hand, will you give it a thought that you can fill that void with a cement block over there? Just put some bone cement so that will augment that bone and the possibility of a stress fracture still reduces. What thought can you give to this?
So that is a possibility when you have a large void and you are required to remove implant for some other reason than union and just implant removal. It could be an implant removal for infection. Possibly inadequate. Don't have in my own clinical experience any situation where I did it, but I may invite opinions on that.
Sir, one more.
Yeah, Akash sir is saying, and then.
Yeah, my question, do you have a clinical picture? They are totally adherent or was reasonably adherent to the plate?
Yeah, after this I will be just showing this card.
Because unless you have a good soft tissue cover,
The soft tissue was good.
soft tissue
Was very good.
the,
Very good.
the bone is extremely sclerotic. So I would definitely not try and remove the. Yes. That is one. Now that it has already occurred, at this stage, honestly, I don't think there is anything that can actually prevent. Prevent the pathological factor. Possibly, I would put a plate, but
Possibly.
I would avoid removal of implant with sclerotic bone.
So very good point. Whenever there is a sclerotic union with a long segment of sclerotic union seen, implant removal should be very cautiously done or at least warn the patient. Yes, you were suggesting.
Sir,
Yes, please, please.
or we can protect it with intramedullary titanium nails, flexible nails. We can remove larger plates and can be protected with intramedullary
so if you-
flexible elastic nails to prevent stress fracture.
If you go back to the union process,
It is all
medullary
sclerotic. There is no
canal is
medullary.
sclerotic and there was no medullary canal as such. So that would have been quite a difficult thing.
So, was there any history of bisphosphonate used for healing or prolonged bisphosphonate?
No, he was just 32 years old.
So, I mean, there is a tendency to still give bisphosphonates.
No, this patient never had bisphosphonate. Never had bisphosphonate.
I mean, we've seen cases
So-
where for union bisphosphonates have been effective.
Bisphosphonate, I think, in a 32 years old male, a factory worker, I think, was not a possibility. Okay. Any other point? Yes, you were. Yeah. Yeah, go ahead, sir. This
Problem is that
value
once you open it out for removal of implant, and you come under situation, the bone, you can see the cavity is there in front of you when you open it out. So that time you decide not to use the implant. The bone is sclerotic, so the biology has been totally gone. It is not likely to grow any more bone. So in that case, whether you retain the implant and do bone grafting to cover up that area, just marginal sclerosis you have to remove and do bone grafting, which is the biological, and may give rise to a little bit better like that. Whether it's
and I would agree, good suggestion. And therefore, in our implant removal consent, we take a consent. We may not remove the implant if we find inadequate process of bone filling. That's a good suggestion. I think. So I'll go ahead with the case. So this was the implant removal was executed. He started working again, joined back, and during working got pain in the thigh. The tibia did not have any trouble. This was the X-ray after the implant removal. So this was tibia and this was femur. And suddenly developed pain, developed a stress fracture. So looking at this process of union for a distal femur, between a choice for a distal femur plate and an intramedullary implant, I think intramedullary implant scores because it gives you a zone of wider union. So that would be a choice retrospectively in this case. So the questions to the previous surgeon were, should he have not removed the implant? And now what next? All investigations for infection were normal. Clinical examination, there was nothing. He was otherwise hale and hearty, except for this stress fracture. The bone metabolism also was normal as per normal calcium, phosphorus, and alkaline phosphatase. CRP, ESR was also normal except for the small rise because of the fracture itself. So this is the now analyzing how it went ahead. This was the X-ray, a segmental fracture. You can see the long segment of bone, and there was some intercondylar element as well. The fracture was a simpler fracture. So was this a zone with a lot of vascularity? Was the question in mind? This was the lateral view. This is what the fixation was. Fixation is at this point of time 6 months. Assess the process of union. So this was the picture. This is at 1 year, patient walking, no pain. This was healing phase, uneventful except restriction of the range of motion. And I would agree with most of us thinking nowadays thinking that a fixation of plate should have been longer, more flexible fixation, plastic fixation to give more callus. But that was what was done. Presentation to me, investigation all normal. Now what to do? How to manage this patient? One suggestion was reapply the plate, additional bone graft at the fracture zone. So any other suggestions? Yeah, please.
So I would like to take out that necrotic, the segmental, which was initially, which you thought it, and even I think of that, that is the avascular bone. So that has to be come out to have the good union, and then take a transport or a bone graft.
So taking out a avascular segment of bone, if not infected, would be your choice, because then you are removing a large segment of bone and then putting patient to a long period of rehabilitation. So
yeah, because the pathological fracture is happened because of that hypertrophic.
There was no absolute infection, no granulation, nothing. This was a stress fracture because he joined back duties at 6 weeks while working. He developed this fracture. So the history was very classical of a stress fracture in a zone which had a healing of a sclerotic bone. Please pass on the mic. आपको किसी को एक्टिव रहना होगा माइक देने के लिए.
For the intramedullary nailing with the bone graft. The second option we should keep as on the table that long plate with bone graft.
So a choice between a plate and intramedullary.
First choice will be the intramedullary nail.
Yeah. And the problem and difficulties were,
So
as you can look at this zone.
so if I can add a point.
This was absolutely sclerotic, and here also totally blocked because of the fragment inside, and absolutely sclerotic bone. Yeah, please. You just make it on.
Open reduction at the right side. Reaming, hold the femur upper end and lower end, and do an intermediate nailing with the refreshing the backside at the stretch fracture plus bone grafting would have been an option in this case as per my opinion.
Absolutely agreed. So you have to provide fixation. His suggestion is intramedullary nailing and bone grafting to achieve union. I accept totally.
So should we keep a
Proximal fragment and distal fragment to avoid any heterogenic complication during the surgery. If it is not possible, then you have to keep the long plate ready with the bone grafting.
Yes, agreed. So reaming a difficult canal, you have to develop those skills to have a sharp reamer, somehow put a guide wire, and then ream it. I think that's a valid suggestion, and that was what was done in this case. So this was the result. This is the skin condition. The skin condition is quite normal. He had a long incision on the lateral side. Now, this was a open nailing, open plate fixation initially. This is the skin condition. Intraoperatively, so as was suggested, From the fracture side, we gradually created with a sharp reamer by hand. And then once the guide wire was passed, so we had to go in with inching guide wire technique. So small guide wire being forwarded, then remounted, then again forward because the guide wire was not passing as the whole medullary canal was blocked. So a gradual inching technique, and then that was managed with intramedullary nailing, bone grafting, as well as a derotation augmentation stage with unicortical screws, and that patient went uneventful. The lessons I learned in this case was, even after implant removal, ideally take X-ray. In the nowadays world, in previous era, we were never taking X-rays after implant removal. In nowadays world, because of all this litigation moving around our head, I always now take X-rays. Even after a Colles fracture, I have removed a plate, I would take a X-ray whenever it is removed. Number two, when they are joining back duties, on the footnote, you would give them certain precautions so that there are no litigations on that part in the factory doctor. Number three, sclerotic bone healing to prevent possibly the medullary flexible intramedullary splinting as a choice in difficult such cases is what the lessons I would have learned in this patient. Thank you very much.
Thank you. A tea and coffee is ready. You can have a tea coffee break. And next is Dr.
Yes, sir. No. This was a fresh fracture. This was a fresh fracture. Absolutely. Clinically, it was a fresh fracture. So could be. I think I must have done overdue. But whenever there is a fractured distal and femur at the stomach zone, at the metaphyseal zone, near the metaphyseal zone, it is my standard policy to provide both intramedullary as well as extramedullary fixation as one stop go. And I too agree, if we would have given only intramedullary good fixation, it could have worked. It could have definitely worked. But from head and cavity, there are reports that out of 18 cases, still 2 went into non-union. So I think this is what I chose, but I would agree that yes, we can have an intramedullary.
Especially in these cases and non-union cases, you will need absolute stability. You need to prevent even 1 degree of rotational movement, and you must have a plate. That unicortical is adequate for prevention of rotation, but at least that has to be done.
One important advantage I notice always in these patients, they have no pain, they have a greater control on their knee power, and they mobilize to their fullest possible. As in this case, we did a parapatellar release, and he developed more of around 25 to 30 degrees more of flexion. And they come down walking early without any support at 6 weeks. When they come down walking, we even forget that this was a patient of a non-union. So that strong is the equation, is what my perception is.
The rotation plate. If we are going to put a plate, then this interlocking bolts, they hardly they matter whether we put or don't put. The splintage is given by the nail, and derotation is provided by the plate. So that can be also done.
Yes,
Even in
multiple options. As we started in 80s with a derotation plate, then interlock nail came. But
yes, sir.
But my observation is, if you don't lock and only derotation plate is there, the nail may migrate up or down.
Yes.
In some patients, so always lock it. Yes.
All those four screws will certainly help in early weight bearing because they will be sharing some.
Totally agree with you. Totally agree with you. Thank you so much.
Thank you, sir. Now I would like to call Dr. Santapure, sir, for his tea and coffee. We'll take a tea and coffee break, and then we'll have a next session, remaining session.
Hello. Hello, check. Hello. Hello, check. Hello. Check.
Chief. Hold.
Hello, check. Hello. Hello, check.
check. Hello, check.
Hello, Talwa. Devre sir, all delegates please assemble in the hall. All delegates please assemble in the hall. Dr. Vikas Agai says is going to present is a very interesting case. And we'll have a very good class. And I am also going to present one case where I have done so many mistakes and how to rectify our mistakes. So please join in the hall for a clinical case discussion.
So we are starting remaining clinical case discussion. Hello. Dr. Santapure sir. I would like to call all the faculties and organizing team from Aurangabad Orthopedic Association to have a group photograph. Yeah. Photo. एक photo घेऊन टाकू. Faculty and organizing team. Gade sir. All delegates also can join and have a group photo, and then we'll take a, please, all of you. Thank you. Yes, sir. Yes. So, Dr. Santapure, sir.
So, good afternoon and welcome all of you to this wonderful event. So, this is where I practice. So, before I show my case, the actual case, so what are the things which we used to do in the past and we are not doing in the current situation? So, what is in and what is out? So, in last 20 years, the conventional for treating a compound fracture, the conventional teaching was to debride and fix with the external fixator and wait for further improvement of the soft tissue and then do further reconstruction. So probably what is out is Ilizaro, orthofix, external fixator, bone transport. Then there used to be a lot of residual infection leading to prolonged treatment, leading to stiffness, and ultimately a poor outcome. And what is new? What is so in our current day practice, what we are trying to do is early internal fixation, even in clean grade 3 compound fracture. Day 1 definitive fixation, aggressive debridement, and treatment with vancomycin spacer. We are trying to induce the masculate membrane. And then in many of our cases, we are using vascular fibula with iliacrous bone graft. We are advocating early quadricephaly to have a better knee function. So this reduces the treatment period and we are able to get good outcomes compared to what it used to be 10 years, 20 years back. So I begin with my case. Though there are many cases, I will show only one case, this first case. So this is a 18-year-old male. This is the proximal fragment of the shaft diaphysis of the femur, which was jetting out from the anteromedial aspect of the thigh. So I will give you the orientation. This is his knee joint, and this is the lower end of the proximal fragment, and this is whole of his anteromedial aspect of his thigh. So these are his probably this is the anteromedial interval, the muscular interval. Probably it is in front of the medial intermuscular septum, and this is a 18-year-old male, grade 3 compound fracture at the junction of lower third, middle third. Presented to us at the end of 24 hours after the injury. So this bone was outside the wound and was contaminated for 24 hours. So I'll take a short break here, and maybe faculties and all of you can share your opinion at this stage. Vascularity was good, no neurovascular deficit. His calf was good, there was no compartment syndrome, vessels were good. Sir.
So what I would do in this case is debride thoroughly, wash, lavage, that would be there. I'll take 4 corner retraction of the soft tissues, reduce the bone, and then suitable X-fix and antibiotic loaded cement to prevent infection, as this is 24 hours case, old case. Put it back at around 6 weeks when the soft tissues are fine. Then I will do a definitive internal fixing. That would be my philosophy in this patient. And I would preserve that bone segment as the proximal continuity of bone is maintained.
Sir, the periosteum is all stripped. The soft tissue attachment looks somewhere here, but this bone is all, to me it looked contaminated, devascularized and dead.
Still, at 24 hours, I would like to take a chance.
Yes,
and
sir.
since I am putting antibiotic loaded cement all around this as an envelope, I would possibly ensure or make it more certain that infection does not happen in this case. Take a chance at 6 weeks. If that doesn't survive or still infection happens, then I would excise in a secondary case.
Agache, sir. Yes, yes, sir, I'm sure. Agache sir wants to say that. Sir.
Excellent.
So this was the lower fourth, intraarticular extension, and the wound was all the way from here till here. Mike, sir.
My ideas are little crazy, too aggressive, but I'm quite concerned about preserving that segment. A, because it is 24 hours.
Sir.
B, it is contaminated,
Yes.
and it is devoid of the
Soft tissue.
soft tissue. I would prefer an uninfected, non-union, bad X-ray on day 1,
Sure.
rather than having a good X-ray on day 1 with the possibility of infection. So I would excise that.
Where do we excise?
It totally depends. I'm quite sure I like possibly I'll have to excise up here because the contamination would be here. So I will start from here and then go up. Because very often so I will start, I will not excise everything in one go, but I will excise up to here and then bit by bit I will excise.
And you will check the vascularity
I
of
check
the cut end.
Of the cut end. Okay. And when I have a reasonable vascularity, then I will put a spanning external fixator. Besides the distal end for sure, because this also doesn't improve. And depending on contamination, as you said, it is contaminated. I will not here for 3 4 days. But as soon as I have a decent wound, I will try and do minimal internal fixation and then continue with I will like to change over to internal fixation as early as possible.
What you will do to the gap which is going to be created on day 1? About 3-4 inches of gap, maybe 3 inches of gap.
Yes.
Sir.
Day 1 I will not do anything. When I am closing, then that is the time, and when I am doing an internal fixation, that is the time I'll put
Sure.
to be
Sure. So similar where on the similar lines, we were thinking, we were worried about the infection. So this is what we did. We did not cut this in one go, as you suggested, sir. It was resected in 2 steps. Yes, we were, to begin with, we were conservative, but then we have to resect about 1 inch more. And then, though this wound looks oval, this was a linear wound, and we could close it primarily. The anteromedial wound was closed primarily over a drain. So this is on day 1. Wound closed on the medial side and a gap of about 3 to 4 inches. So now, how do we proceed at this stage? So now, there is no fear of infection. Soft tissue has been taken care. There is no vascular injury. So compound fracture being converted to a closed fracture. Sir, Chandak sir, you want to say anything?
Now it is large bone defect filling.
Sir.
So distal femur locking plate
Sir.
with a fibula strut, and I would use rear bone graft, or as a stage 1 mascule, good cement envelope, a whole tube of cement spacer, and around 3 weeks down the line, then converting to rear bone graft, or if that is not available, 2 fibulas side by side, and the medullary electrous bone graft in the center. So this would be my philosophy.
Kulkarni sir.
I think it's too radical for this day 1. I think we should believe in nature to revascularize a part of it. Not some sort of stripping or something, but it will revascularize, not that. So it is, I wouldn't do this too radical on day 1. So I would stabilize it with the external fixator and put some Orthopaedic beads and close the wound, put a vac on that, and wait to nature to give some signs of non-healing or healing bone. And once that is shown that this is not revascularized or giving more infection, then I would go for that. So I think for the PG, they should not take away the message that every bone comes out within 24 hours. If patient is coming in India, 24 hours is also good, fastest way to do it. Otherwise, we don't get after 3-4 days.
So no resection, or your
So
resection,
no
would have
day
been
one.
a
No
smaller
resection at day
resection,
1,
shorter
no
resection?
I am not saying that you should not debride it. Debride the wound completely with a vac on something, and but excise that much. If it is severely contaminated, you just excise it. But don't excise that much at day 1.
But how do we assess the vascularity on table? Sir,
It will revascularize. You are not. That's what I'm telling you.
every dead cortical
Not-
bone
it's not
won't
dead.
revascularize.
So how do you know it is dead?
Santapure sir, you and me were there in the residency. When we do a tibial nil, segmental nil, some fragment come outside the wound. We keep that fragment as it is and we revascularize in fracturing.
But
like
we
that.
have seen
But
lingering
as
infections for
as-
months and years.
No, there is no in
The
all cases. there
Infection
will-
story will never stop.
No,
It
no, no, no.
it
In
goes on.
all cases, but nobody will give guarantee that this will prevent the infection in future. As the Menon sir says, there is a biofilm is there, which is there. At what level that biofilm is there, nobody knows.
No, biofilm is around metal. Biofilm
No,
cannot
you are
form
going
on
to
day
put,
1.
You are going to put the metals. No, not nobody sees the micro viruses or microbacteria there which are growing inside. We are not able to see that. When that infection will be exacerbate, nobody will guarantee.
Yes,
But as Sunil sir said, we have to do a radical on day 1. Give us some chance. Wait for 3 to 4 weeks.
Yes.
If infection is there, X-ray suggests that fragment is devascularized. At that time, you do a radical surgery and do whatever fibular graft or iliacal transport.
The idea behind doing this was to convert a open contaminated fracture into a closed environment. That was the idea.
Your idea is good, but it
Yes,
is
sir.
little radical at
Yes,
this stage. I think.
we gave thought either way, and then we ultimately resected it. Sir, Kotadia sir.
I think this being a concentric bone, all around you get a very good soft tissue sleeve. Even
Sir.
if it's periosteal, sweeping initially. Yeah, if it is if this is a concentric bone, and initially you may think the whole periosteal is stripped off. But because of the peripheral vascularity, some part of the bone definitely will survive. I will continue with the Dr.
Yes.
Sunil sir.
Yes.
So I think we should not be so aggressive initially to debride it. whatever bone which is contaminated, as he said, can be excised and you can use them. You can put a vac and you can revisit the same situation at the end of 48 hours and see what happens.
So, let me come to that stage. Let me come to that. So this is day one.
So you are excising the live bone, which you are not sure of whether it is live or dead.
Yes, sir.
And you are definitely putting a dead bone from taking from the fibula and putting in the fibula.
Sir.
So the rationale is to
Yes.
wait and then go ahead.
Yes, sir. Yes. Yes, sir.
Then the rest.
Thank you, sir.
So if I may add one point here. So here,
Aditya.
I think as surgeons, depending on the stage of career we are in, we're always scared of excising. The idea should be if we think it is infected or contaminated or avascular, if we're at the beginning of our career, we don't have enough backup, we are scared to excise that because what do we do with that defect? I think that is the one thing that we must take out of our mind. If it's looking dead, we have a doubt. Day one is the only time that we have to excise everything, because if we don't excise because of that fear and the patient comes back, then we are even more scared to excise more because we already had one surgery where we failed. I think we need to, whenever faced with this, if you're not completed enough, either call somebody to help us with this case, then we can plan for that defect. But keeping it because we are not competent enough to fill that defect would be the wrong way to go ahead. I think that's no, I understand. Exactly. Exactly. Correct. Correct. So absolutely.
Okay, we are all are here to agree to disagree. So continue, sir.
So
We are publishing Surgeries with the Ganga. It's fallen outside. In the fallen outside dust loaded fragment. We washed it and put it back. And that has healed, which is published in Surgeries. So don't think that it is damaged and it is continuity with the bone, it is completely dead. So it is, of course, surgeon's choice to do it, but it is.
sir, but every contaminated devascularized bone cannot it cannot be made aseptic and it cannot revascularize.
I'm not saying that.
Sir, yes.
Nobody is guaranteed, but day one it is too aggressive. That's what I'm saying. If
Yeah.
you get day 10, that condition I would agree, but not day one.
Yes.
On the first sitting when we are
Resection,
debriding, so what is the cutoff point of debridement? One thing.
Yeah.
That's more than 50%, like punctate bleeding starts once you start debriding.
Sir, understand.
Paprika sign, as you suggest, I would use when I am excising a necrotic dead bone in an infected scenario, infected non-union. But that I would not use as a weapon on day one in such a fracture, because bone is continuous Haversian system. And nowadays we have a lot of other good things to take care of infection. Why we are worried? There are a lot of bones which are devascularized. Say you are doing a long segment non-union femur which is overlapped for 6 inches. Now what you do open reduction. You remove all those soft tissues for almost 3-4 inches, both sides. Then you do an interlock and these fractures heal. So I would be taking care of infection by other means like good debridement, take out everything, put wax, then have a masculine membrane, have bone cement spacer. This is now a piece of bone without vascularity at that moment, but we ensure no infection. And then attempt at healing is one strategy. This is another beautiful strategy. Long bone segment can be reconstructed, but they have a problem. The long bone reconstruction takes more time, is not certain, is with multiple stages, morbidities, stuck up tissues. So day one reconstruction with a maintained length at times is also a philosophy. So in two philosophies, you will have to choose. How do you choose? There are multiple other things apart from simple photograph. On day one, yes, he thought, I think it is appropriate, is a good decision. But for discussion, the other strategies also can work. Choose what you want on that day.
So on day 10, we opened it by lateral approach. So this is bone was stabilized with a long locking plate. The intercondylar fracture was taken care. The intraarticular, we could reduce the intraarticular fracture. A long locking plate and a segment of vancomycin, gentamicin, and cefuroxime spacer was inserted there. So this is what we did on day 1, and this is done through a different incision. The wound was on the medial side. We opened it with a lateral approach, usual approach which we take for femur. That was excised from the wound, medial side. The wound was on the medial side. Vascular fibula. And you can see there is a lot of callus here, already new bone formation.
Not used as a weapon on day 1.
Vascular fibula is into the masculate membrane. And you can see union, there is already callus at both the ends. No, same plate. We continued with the same plate. Sir. We were worried about the varus bending of the plate, varus collapse of the plate, and so that's why we wanted to create a V shape here. So we deliberately tried to bring it to the medial femoral condyle. Double column fixation, a medial fibula and a lateral plate. Sure. Sir, so this is a closer look. You can see lot of bone here. Bone, a live fibula inside, and bone encapsulating the fibula, live fibula. And you can see continuity of this bone all the way. And this is done 3 years back, and this fibula kept on hypertrophy. Sir, during your first case, we were discussing about the stress fracture of the fibula. But sir, we have done many vascular fibula and we have not seen a single case of stress fracture. Probably it is a phenomena when we use a free fibula. Further consolidation continued. And you can see this is his medial wound healed nicely. This is a lateral wound, a new incision. And this was about 60 degrees of knee flexion at that point of time. And he is happy with his overall function.
Excellent.
Thank you, sir.
Thank you, sir.
Thank you.
Now I would like to.
No, I think this is last X-ray, but this we have done 3 years back. Not in this presentation, but he is in contact with me. So we do the same technique for tumors, distal femoral tumors, proximal tibial tumors. These fibulas, they continue to hypertrophy for years. And maybe they become of the same width. Ultimately, this fibula the width should be of the native femur. This is hypertrophied, sir. Yes. Yes, sir. So no further procedure on him. Infection free. He enjoys an infection free life, no limb length discrepancy, and a reasonable knee function. Today, sir, you want weight bearing after the fibula, partial weight bearing, and then this fibula was done at 6 weeks. Fibula was done at 6 weeks. By that time, it had
but still
One more question, not regarding infection, but when you are routinely doing this for tumors. So when you are putting a plate, there is a long plate with length, which is without screw. So do unicortical screw, if we put there in a locking mode, whether they prevent the stress riser at the plate holes? No, I'm asking in between. There is a whole length of plate which is not supported by bone. Okay. And you are doing fibula. Am I right? So fibula is a shorter bone completely. And you're not fixing the fibula at every level. So whether to avoid bending of plate, is it okay if we put a unicortical screws? Is there any article or something on that? I'm asking about plate, bending or breaking of the plate, because the span is big enough. So like we use for tomofix, they use a unicortical screws, okay, to avoid that plate. Yeah. So something like that can be used.
You want to block the holes.
Absolutely.
Yeah.
So is it biomechanically stable compared to this?
Done that.
No, I mean anyone knows or any article or something like that, because
there are very high chances of failure of plate. I'm not asking about the fibula, but plate.
The summary was good planning on day one. Vanco spacer induced masculate membrane, and then use of a vascular fibula. No external fixator at any point of time during the treatment. So this was the strategy followed in this case, and we follow this strategy in most of our cases. Thank you so much.
Okay. Thank you. Now I would. Hello. Hello. I'm audible. Hello. Yeah. So good afternoon, all of you. Presenting my case, being an orthopedic arthroscopy surgeon, I got a call from my intern saying that there is a 35-year-old male who had a knee pain and MRI was suggestive of some medial meniscus pathology, and patient was scoped by me, and intraoperatively or scopically there was not much of finding. Means there was no any meniscus tear, nothing, no any instability, but the patient was still having pain, and with this video of yeah. Okay, so with this, clinically I have not examined the patient before putting the scope, but with this the patient came to my OPD. The patient is definitely having lurch. Okay, there is a shortening, and so to start with the patient, digging the actual history, he had a femur fracture, which is about 1 year back, and he was operated with probably a open reduction and internal fixation seen on the sequential X-ray. So this was his X-ray to begin with. Sorry. So this was his X-ray to begin with. It was like mid-shaft segmental, not segmental, spiral oblique fracture with a fragment. So he was nailed with intramedullary nailing. So any comment about fixation? This was done on day one. It was operated by a primary surgeon, the other surgeon. So maybe because of difficulty of reduction or difficulty of this thing, he might have opened it and to put the cerclage wire and nailed it.
Thicker nail could have been used. One thing.
Right.
Second thing, the femur looks straight on lateral view. The natural bow has been lost.
Yes. Yes. Exactly.
And maybe you could have used one more cerclage. The cerclage is at the lower end of that fragment. So I would have gone for a thicker nail.
Right.
That could have probably restored his.
Any
curvature.
comment about the bow of the anterolateral bow of the nail bow
bow has been lost.
Lost. Yes.
Did you use the opposite side nail?
Yeah. So
Okay.
that was the
Opposite side.
The opposite side nail, and the anterolateral bow was not matched, was correctly pointed out by Dr. Santapure sir.
Distal screw only one. He has put only one screw.
Yeah. So patient, which correctly pointed out the anterolateral bow was lost. At 6 month post-op, patient was consistently having pain, and you can consistently at pain at fracture site and even at the knee side.
So even at the this was at 9 months. Yeah.
Which type of nail it is?
It's a recon nail.
It is a universal proximal femur nail because we are seeing some holes in the up above also.
So this was done by the other surgeon. So
But,
which company nail or which company nail, but this probably looks like a universal femoral nail.
But then you said it was for the opposite length, opposite side.
No. For the same limb. For the same limb, he was operated for the same limb. For the same side, he had a femur fracture, and then the same knee. For the same side, he has a knee pain, and that's why the scopy was done.
Why the nail is straight? The nail should have the anatomical
That's why
nail.
the bow of the nail was not matched. While putting the nail, the bow of the nail was not matched.
Matching, or it is
How do we
supplied by
match it?
how can you match bow of the nail with the bow of the femur?
No, the anterolateral bow, the nail. Usually,
You are doing locking from lateral to middle. It ultimately says that bow is maintained. No? We are
Yes.
not doing locking from anterior to posterior or like that. He is doing locking from lateral to medial. So ultimately bow is maintained because any.
yeah. No, but this. Okay.
It could be.
Yeah.
It could be the Cyrus nail, which he must have used the opposite side nail, right, left. It comes in the different size, right and left.
So that we don't know. In
That
drop, what was
the reason
done.
for mismatch of the bow.
So in drop, what was done, that was not known. So this was at 9-month post-op, and implant removal was done by primary surgeon. And with this scanogram, with this picture, he presented to me. So now the patient is having shortening, one, varus deformity at fracture site, femur shortening, hypertrophic non-union probably, and query infection.
But why was the nail removed when he was not sure about the union?
The primary surgeon took a decision of removing the nail early.
Then probably it was removed for infection.
Yeah. So at this stage, he presented to me. Whether this was removed because of infection or because of consistent pain, but there was no discharging sinus, nothing. But the only complaint was consistent pain, and he was not able to bear even after 1 year of nailing.
So now we have to go back, go inside, explore everything, remove the cavities, and if it looks clean, it can be refixed again with a nail and bone graft.
Right. No, we can see. As of now, we have to put the bone graft, as sir said. The plan was yes, to have the additional the stability and a proper fixation.
Regarding that deformity, as it is a non-union on table with fracture, we can correct that with manually. After putting a nail, we can correct that if it is correctable.
Yes. So what suggested, the blood investigation was within normal limits. There was no any signs of infection. CRP and ESR was normal. And what was the pre-operative planning? So we planned in lateral position, reaming, obviously a bone graft, and as sir suggested, with a larger diameter nail. So this was the one slide is missing. This was the post-op X-ray as sir suggested. We put a larger diameter nail, and we put iliac crest stud graft, and which was fixed with 3.5 cortical screw at the fracture site. So it is not a cancellous graft. It was a tricortical with corticocancellous graft. So
He used that strut as a plate.
But do you
It's a
recommend,
biological
do you recommend in hypertrophic non-Indian bone graft and putting a screw at the fracture site?
It is not recommended, but once he has decided to use a bone graft, it was a large, I suppose it was a
Larger
chunk of
diameter
bone,
nail, yeah.
and rather than keeping it floating, the idea was to fix it to the bone.
What is the
Right.
use, what is the aim behind putting a strut graft at the fracture site?
So it was a corticocancellous graft to have the additional, like while putting the extra plate, unicortical plate, rather than putting an extra unicortical plate, I put a corticocancellous graft with the screw.
Was there any suspicion of infection?
No suspicion of any infection. So this was his function.
Excellent.
Video. So need to know the proper history before doing any case, proper preoperative planning, check your implant intraoperatively and avoid improper fixation and early removal of implant. Thank you. Now next is the presenter is from Dr. Lingayat's team, Dr. Abdullah.
Good afternoon, everyone. Myself. I would like to call Dr. Aman to present his case.
Good afternoon, all of you. Myself, Dr. Aman, junior resident from GMCH Aurangabad, under the guidance of Dr. Lingayat sir, head of department, GMCH Aurangabad. I am presenting a case, 85-year-old male with history of self-fall at home, 10 months back, for which he was consulted at nearby hospital and he was diagnosed with transcervical neck of femur fracture, and he was admitted in the hospital and posted for hemiarthroplasty. But unfortunately, outcome of that operation was this girdle stone. It was atherogenic intra shaft femur fracture. Respected dignitaries, what could be the reason for this atherogenic fracture?
The fracture ends it looks to be hitched into each other. Probably it was a subcapital fracture. Before he could disengage the fracture, he tried to rotate it, internally rotate it. Probably that could have led to the spiral fracture of the proximal femur. What I would do, I cut the neck at a desired length and then derotate it. Yes, probably the fracture ends were entangled, and then
I guess the film is flipped on the right side. But in any case, if at all you see, probably while inserting the stem, the processes was put into a lot of virus, and hammering it has probably caused this fracture. This is one of the most potential cause. Secondly, the wiring has been done in an odd fashion. If at all you see, there is an overriding of the fragments of around 2 centimeters. So the neck which was initially cut for the calcar to sit, or the calcar which was supposed to be made there, so the GT has come down with the lateral fragment which was supposed to be on the higher side, maybe around 2 centimeters of shortening has been there because of the wires over there. And I guess it is the virus placement and hammering. It can happen to anyone, but probably I guess that could have been the reason if at all we cannot make out any fracture on day one.
Thank you, sir. Then the patient was kept for 3 months on skeletal fraction. And this is the X-ray. The patient came to our OPD 3 months later. And this is the fresh X-ray at our OPD. What could have been the treatment options for this patient at this age and after 3 months of this surgery? Respected dignitaries.
One, if possible, if the patient was medically fit after that fracture has happened, obviously the long stem processes would be required because the proximal metaphyseal stem will not work. So we need to calculate the diameter at the lowermost point of the fracture site, go to lengths above that, and that's the length of long stem. So that stem obviously would not be available on day one, but you can explain to the relatives and do the surgery in the same admission would have been ideal. Maybe a week apart also is fine. But by now it's 3 months, the soft tissues have contracted. The challenges have increased, and probably the canal has now become more narrow proximally. The challenges are going to be soft tissue release, exposure, getting the length. Maybe think of an adductor tenotomy as well. Pull it out to length, see on table whatever we get, and then remove those circulage wires, open the canals, we get a good space to ream, and then use the long stem, whether cemented or uncemented, that's up to the surgeon.
Yes, sir. As the patients were willing for operation, because the patient was bedridden since 3 months, they were asking for early mobilization. So we have planned for long stem total hip replacement and uncemented total hip replacement, and a preoperative assessment has been done. ESR and CRP and routine blood workup was done, and ultrasonography of hip was done. There was no any collection, and then we have planned for uncemented total hip replacement, and we have taken the traction X-ray also. We have done the posterolateral incision, and we have removed the callus formation which was there at the fracture site, and removed the encirclage wires, and then we have reduced the fracture and did encirclage at 3 sides, and we have prepared the canal serial reaming by 8 and 9 mm, and then we have inserted the 9 mm and 23 centimeter prosthesis, and we have inserted a distal locking for additional stability, and patient was mobilized on day 3. Patient was taught static quadriceps and ankle exercises, and bedside knee range of movements have been started, and patient was made to walk with the help of walker from day 3 onwards. And this is the follow-up X-ray after 6 months. Patient is doing all his activities of daily living and walking without support, and is also able to climb upstairs. This was 6 months post-op. Patient is walking. There is no limping, and limb length discrepancy was also not there. And modified Harris-Hip score is 95. Post-op 95. Thank you, sir.
lunch is being served. So we'll take one more case. Dr. Ahmed.
Good afternoon, everyone. Good afternoon, everyone. So, my case for today is closed total talar dislocation, which was presented in our casualty in GMCH Aurangabad. So, it is a very rare case, a closed total talar dislocation, which means that talus has all three joints that talus makes with the navicular, with the calcaneum, and its ankle joint. All three joints are dislocated at the same time. So it's a very rare case. So a 42-year-old male patient who received a severe impact on his left lower limb because of a road traffic accident was brought to our emergency on tertiary level trauma center. On arrival, he was hemodynamically stable, conscious oriented. So we sent him for radiological examination. So here's the picture what we saw on his X-ray, AP lateral, and here's a 3D CT. So we can see that talus has medially rotated in its space, dislocating ankle and subtalar joint, and also we can see here that talonavicular joint has also been dislocated. So what would be the management? So continue forward. Patient also had a D12 wedge compression fracture, but his neurology was normal. So here's the options for the management. So close reduction, direct by traction and plantar flexion, and by applying plantar flexion and traction, we can closely reduce the fracture. Or use a K-wire as joystick to reduce the fracture, or open reduction. But the dilemma with the open reduction is that we have all due to its total dislocation of the talus, there is already compromised blood supply to the talus. So by open reduction, we are already compromising the blood supply. We are further compromising the blood supply of the talus. So here's we took the patient in our OT. So patient was very lucky. We were able to reduce the fracture by simple joysticking the talus, and we applied a external fixator, ankle spanning external fixator. So here's the X-ray on after 3 months, we removed the external fixator, and here's our X-ray, AP lateral, showing no avian changes on the talus. So here's an MRI. We have performed an MRI after 3 months after removing the external fixator, which showed no avian changes. So we started the patient on weight bearing, and he has already he got his dorsiflexion was quite restricted, but and plantar flexion was around 20 degrees. So thank you.
So with this, I conclude the sessions, meet the masters, and lunch is being served. You can have a lunch and then come back and start our next section.
contradiction now is there. Good afternoon and greetings to all. Respected teachers, seniors, colleagues and friends. It is honor to stand in front of this august gathering today. With folded hands, we the organizing team of this Pathshala thank and welcome you all for registering and attending this Pathshala on nailing an infection under the aegis of Indian Orthopaedic Association, Maharashtra Orthopaedic Association and Aurangabad Orthopaedic Association. I am indeed grateful to each one of you here. A unique conceptual idea by our dynamic president of MOA, Dr. Gadegone sir, with course director Dr. Agashi sir, with studded star faculty coming from all corners of Maharashtra, who have traveled all this weekend to enlighten us. Learning is an unending process, and the numbers of registration and attendance itself is a that how eager all of us are here to learn and seek knowledge. It is indeed my privilege to introduce you all to our esteemed faculty. Dr. Gadegone sir, who happens to be the president of Maharashtra Orthopaedic Association, is known to each and every one of us over here. May I request Dr. Gade sir to please present a small rose to Gadegone sir. Thank you, sir. Gadegone sir is a perfectionist in his game of trauma. He is known to every orthopod in central India. A professor HOD at Chandrapur Medical College, past president of NAILS, present president of Maharashtra Orthopaedic Association, past president of Vidarbha Orthopaedic Association. He is a humble man, down to earth, and is always eager to impart his knowledge to teach us tips and tricks in complicated trauma. Thank you, sir. Thank you for being with us. Dr. Agashe, sir, I guess there's hardly anyone out over here who doesn't know this man. We have been hearing him since last 20 years related to infection only since our residency days in Mumbai. Thank you, sir, for traveling all the way from US. He had been, just 3 days ago, he was in US, and for all, he had been flying all this way. In spite of jet lag and his commitments, he has stood to his commitment and traveled for us over here. Thank you, sir. May I request Dr. Linga, sir, to please welcome Dr. Agashi, sir. Thank you, sir. For those who do not know, Dr. Agashi, sir, had been awarded the Golden Jubilee Oration at IOCON 2009. He is also a chairperson of Trauma Subcommittee of Indian Orthopaedic Association 2019 and 20, an advisor to Infection Subcommittee of Indian Orthopaedic Association 2021, and of Bombay Orthopaedic Society. People like Agashi, sir, are the stars, and they add feather to the society we come from. Thank you, sir. Thank you for being with us today. Dr. Gawale, sir, we are expecting him anytime. For Dr. Sangeet Gawale, all of you know, is an immediate past president of Bombay Orthopaedic Society. He had been our teacher, our HOD and unit head over there. Those who do not know, he is an astute teacher, doesn't settle for anything short of perfect. A perfectionist, we call him, and we used to be very scared of him this day. Once he is here, I'll further take the liberty to introduce him. Dr. R.M. Chandak, sir, thank you for being with us today. May I invite Dr. Dhule, sir, who is Secretary Aurangabad Orthopaedic Association, to please welcome Dr. Chandak, sir. It was for the first time, sir. Chinda, sir, could you please welcome Gawade, sir? Welcome, Sangeet, sir. Thank you. For the first time in India, Reamer irrigation aspirator was being used by Dr. Chandak sir. He has published books on preoperative planning of instruments. Also, he has published a handbook of stages of fracture healing for the beginners, youngsters, and students. He has presented various papers in international and national conferences. An astute teacher who has also designed a patellar suture needle with lot of interest in hydrodebridement. His expertise in complicated trauma, and we all know that we have to at 1 in the morning. If at all we have to see him in his leisure time in the opening. Thank you, sir. Thank you for traveling all the way out over here. Dr. Aditya Menon, who also happens to come from Mumbai, is also a star faculty with us. He has traveled all the way with Agashi sir, and he is working with Agashi sir over there. Presently, he is Honorary Secretary of Infection Section of Asia Pacific Orthopaedic Association and had been doing his fellowship in bone, joint, and soft tissue infections. Presently, he is stationed at PD Hinduja Hospital and had been a faculty at international and national and regional conferences. Had also been publications, has his publications in trauma, orthoplasty, and osteoarticular infections. We have just seen a glimpse in the morning. Welcome, Dr. Aditya sir. May I please ask Dr. Gade sir? Not there. Dr. Shinde sir. Please welcome Dr. Aditya Menon. Dr. Sunil Kulkarni sir. Those all of us had been to TraumaCon. He's a very familiar person. All of the best part of Dr. Sunil Kulkarni sir I like is very approachable. Thank you sir. Thank you for traveling all the way over here. A teacher who had been at Swasthi Yog Pratishthan, and they have been practicing orthopedics since last 30 years out over there. Those who are indulged into trauma and who want to study the notions and the nicks and tips, past president of NAILS, and it also had been he is associated with TraumaCon since the very first conference. He is one of the leaders and pioneers in starting that. Dr. Sunil Kulkarni sir, may I please invite Dr. Santpuri sir. Please welcome Dr. Kulkarni sir. President Trauma Society of India, NAILS, AO Trauma Council member. He has done all his AO courses as a faculty as well. He has organized many trauma meetings and faculties. Has been a fellow, has been AO fellowship. Yes, she's yet to come with us over here. We'll be happy to have her with us in the evening because her session starts in the evening today. She's a consultant division of infectious diseases and is head of fellowship infectious diseases at National Board of Examinations. She's presently working at PD Hinduja Hospital. She's also co-author of a textbook on HIV medicine. She's a co-author of ICMR National Treatment Guidelines for Antimicrobial Uses and a member of Scientific Steering Committee for the Indian COVID Guidelines Group. On behalf of AOA, MOA, I extend a warm welcome to all the faculties over here. Thank you, gentlemen. The most dynamic amongst all the respected esteemed members sitting here, Dr. N.J. Karne sir, who is also Secretary of Maharashtra Orthopaedic Association, has traveled in the morning, and we are lucky to have him with us today here because otherwise you are supposed to attend a meeting tomorrow at Delhi, but we are happy and lucky to have him with us today evening. Dr. N.J. Karne sir had been practicing at Pune over 25 years at Hadap sir, and those in POS and Western Maharashtra are familiar with this figure. One of the most dynamic person who is involved with Pune Orthopaedic Society is the president of Pune Orthopaedic Society, secretary of Maharashtra Orthopaedic Association, and we see him and look up to him to scale and bring more laurels and honors to Maharashtra Orthopedic Association. Thank you, sir. May I please request Dr. Abdullah? Please welcome Dr. Karne, sir. Once again, on behalf of the entire organizing team, I extend a warm welcome to all of you over here. We are lagging by almost 30 minutes and we'll try to make up the time. May I please request, we'll start with the sessions immediately. I'll request Dr. Abdullah to come over here and take over the session.
Thank you very much, Dr. Sarang sir. Myself, Dr. Abdullah. I welcome you all in our next session of advanced nailing. Intramedullary nailing is a very frequently done surgery in our day-to-day practice. So let's start our lecture. But before doing nailing, consent is something which we take, and there many things are important. So I request Dr. N.J. Karne sir to please tell us what is an ideal consent.
Good afternoon, friends. First of all, I thank Aurangabad Orthopaedic Association and the IOA and MOA for giving me opportunity to have an interaction with our august audience like you. Well, every lecture has to start with the consent, and every procedure has to start with the consent. So this is a little bit off the track topic, but it's very important for all of us in our day-to-day life. It is a really a test for audience as well as for the speaker to start the lecture immediately post lunch session. So I hope that I'll be keeping you awake. Well, one cannot see ahead without looking back at the past. We are still in search of what should be the perfect consent. What we should see from what we can derive is in previous judgments, the doctor was held guilty, and that also for the lacking in the consent. Rather, consent is the most important part for which more than 50% of the cases have gone against the doctor in spite of the excellent medical treatment in the either a consumer court or in the other courts. First of all, we'll see what is medical negligence. It's the wrongful actions or the omissions of professionals in the field of medicine in pursuit of their profession while dealing with patient. Means whatever you are doing while giving the treatment to the patient, if there is anything which is wrongful action or even lack of the action, that is medical negligence. All of us are masters in orthopedics. We attend so many conferences, get all the knowledge in the science of orthopedics. What is required is a basic knowledge of how judicial forums they deal with the medical legal cases relating to the medical negligence, and that is also has become absolutely necessary for the doctors, because every day we are finding one or two judgments all over India which are going against the doctors now. The need for such knowledge is more now than before, in light of more importance being placed by judicial forum on the value of human life and suffering. What judiciary wants, actually, once upon a time, judiciary was almost in favor of doctors, but last 4 or 5 years, we are seeing the trend is changing now. But what they see, they also claim that while seeking to identify wrongdoers and wrongdoing in the case of medical negligence, they actually aim at striking a careful balance between autonomy of the doctor to make judgment, but the rights of the patient to be dealt with fairly. They expect only minimum standard below which the patient cannot be dealt with. Judicial forums have also signaled an increased need of the doctors to engage with the patient during treatment, especially when their line of treatment is contested and chosen treatment has serious side effects when alternative treatment they do exist. So alternative treatment is also important when caring to the patient. In the process of judgment, the judicial forum tend to give sufficient leeway to doctors as well as they do recognize that human body is complex, the medical science is not perfect, the inherent subjectivity of the process, and some judges also accept that there can be error of judgment while doing the treatment, and as well as there is they give importance to the autonomy of the doctors. But the law doesn't prescribe the limits of the high standard that can be adopted. We don't know what is the really standard. But what is important, which we emphasize again and again, is impeccable documentation may be lack, and second thing is the flawless consent. These are the two things that are most important, which are not taught in our curriculum, not given in any textbook, and which decide the whole life of the doctor. What is consent? Consent is important to protect a medical practitioner from liability for harm to the patient arising out of a procedure. Consent occurs when one person voluntarily agrees to proposal or desires of another. There are different types of consent. We won't go into the details of all those things. What we'll see is that what is important for us is informed consent. Informed consent is before the patient can give binding consent, a doctor must explain the significant risk of a procedure or medication. It might change the patient's mind about whether to proceed or not to further that treatment. The doctor does not explain any risk that subsequently occurs, then it is considered as a negligence, because you are telling him about 7 or 8 complications can occur, but if the complication, if you have mentioned in the consent and not mentioned in the consent, if that complication occurs, the case has gone against the doctor because you have not mentioned that particular complication in the consent. This is the rarest of rare complication, but still that should be mentioned in the consent. So after giving all available information, we should allow the patient to decide whether they are ready to take the risk involved in the procedure. The consent which is taken just few hours before or 1 hour or 2 hours before the procedure is not accepted anymore now. That if it's a procedure which is a scheduled procedure, then we have to be at least 1 to 2 days before that. Let the patient think over that, and then you can take consent again half an hour before that. Okay, I'm ready with the procedure. And it has to be in the patient's mother tongue or comprehensible to him, means in his own language. Now time has come to have a 3 or 4 pages consent rather than short one, which were routine in the past. Orthopedic surgeons do routinely take informed consent prior to surgery, but they don't give much importance. The main surgeon never sees what consent has been taken. It is taken either by the office people or by the assistants because they are busy with other work. And in most of the places, there is a blanket printed form with the fill in the blanks. Now, one of the cases gone against only for this purpose, that you have taken a signature on the printed format, okay, which was approved by the local organization, but still that is not acceptable. Then signature on the blank paper. Rather, if you take a signature on blank paper and if you found out it is a criminal negligence, actually it is a crime. So that was a practice in our initial phase. I am 36 years in the practice now. Initially, we are taking the apart from the 2 or 3 lines of the consent, we are taking one signature on the blank paper. Okay, to adjust later on. But now the patient knows this is a serious offense. Then you have to have witness on that, as well as you should have a patient signature. One of the case has gone against the doctor because the patient was in ICU, terminal patient, a 74-year-old lady. She died. Relative sued for the medical negligence, but nothing was found in the medical negligence. But only because the consent of that lady was not taken, the case went against them. After that particular case, I started taking consent of every patient, because what we were thinking before that patient is not in a mental or a physical state to give the consent, and so we are taking the consent of the close relative or the blood relative. But after that case, I started taking consent of the patient also. And as I said, just before taking to surgery, we have to take, but at the same time, it has to be on 1 or 2 days prior to that. Then about explanation. Now, rather sometimes, especially for a spine surgery, we say that we have to spend more time with explaining the patient rather than doing the surgery. But that is necessary because there are certain areas in orthopedics where there are high chances of medical legal litigation. One is the spine, second is the replacement, and third comes to the arthroscopy. Then this is legally inadequate consent. This is again a dilemma. What is really inadequate consent? That is a problem right now. That's why we are working on that. Another part is that overwriting or adding later on that consent without having additional approving signature, again, it is a crime. Rather, if that consent is seen by the judge, immediately the case will go against you, because that means you are, it is a immediately prima facie evidence that you are making some changes in whatever was done in the previous one. So whenever you want to make any changes later on, see that you take a signature of the persons who had already signed there on that. Now, what is legal adequacy? Generally, a state decides the required standard of the infant format, but it's not in our country. Now, here, if they say this is theoretical, that there is acceptable subjective standard, a personal patient, a reasonable patient standard, and the reasonable patient standard. Surgical standard is what would this patient need to know and understand to make the informed decision. Reasonable patient standard is what would the average patient need to know to be an informed participant in decision. And reasonable physician standard is what would a typical physician say about the procedure. That those things should be at least that in the consent. Now there are certain exceptions. We won't go much in detail in that. If the patient incapacitated or in life-threatening emergency, or sometimes these are again all technical issues. Voluntary waived consent also can be considered, but these are legal parts. Now, what is important that what we have seen, what is the importance of the consent or what the judiciary wants in the consent. Now we will see what are the formats of a given consent. First of all, there should be name of the hospital with logo. If a singly owned hospital, name of the doctor with MCI recognized degree. Remember, in the consent you should write MCI recognized degree, not the other degree. Then better to have a local authority registration number of the hospital also, because these days a hospital also taken as a party to the negligence. And that's why now we are saying don't take only the indemnity of the doctor, but take the indemnity of the hospital also. These two indemnities are totally different. You can be sued for as a doctor as well as your hospital also can be sued. Then patient's details, basic details, all. But apart from that, the identification mark and some ID proof of the patient is required, and hospital registration number, as I said. Then and patient's number. Every patient should have his own hospital registration number. That is generally not in periphery. That the papers are not kept properly, the numbers are not given properly. It is not only for now income tax purpose, it is for your medical legal purpose also. Now, in the format of consent, the name of the operation, side of the limb, all these things we take. Indication for the procedure or diagnosis. Procedure in short, sometimes if the patient is too much, we should rather, these days when the patient enters the OPD, what we see first, where this patient is going to land up with some problem rather than what is the diagnosis. And if I'm practicing in Pune and Sadashipet is very close to me. So we have to see all these things with that, and then we decide how we have to change the consent. If the patient comes from periphery, it's something different. So whether to write a procedure there or not, it depends upon the patient in front of you. So first you analyze the patient from that point of view, what is his nuisance value? Short-term nuisance as well as long-term nuisance. Short-term is like a violence, bills and all those in short-term, and long-term is a litigation. The name of the primary surgeon is qualified assistants and their degrees. If it is Ayush, you mention that is Ayush. Ayush is legally acceptable. Ayush is not accepted by MMC. MMC is a different part. Law is a different part. By law, there are MS orthopedic Ayush also who can operate. We can take them as an assistant from the law point of view. Then better to write registration number. Now this is again a big issue now these days. Whether you are taking registration in one state and now practicing another state, that is still a dilemma. And for visiting doctors, there has to be a footnote if somebody else is operating. That please be aware that a surgeon other than the consultant, but with the adequate training and supervision, may perform your operation. Because if it is found later on that I have not operated and you have not mentioned the consent, the case will go against you. Now you have to mention all the alternative procedures, the names which are whatever is available, including there is a non-operative management also. Explain the pros and the cons of all the procedures in short. You can mention, if I want to regain as much physical activity as possible, some of the above alternatives are not appropriate. That all these words should come in the consent. And I have discussed all possibilities with my treating doctor. These are as far as those disclaimers are concerned. Now, as far as implants are concerned, you should explain everything to the patient about implants. What are the implants available in your area? They may be available at Delhi, maybe abroad, but what is available in your area? Then what are the advantages and disadvantages of every implant? Right from, you can say, for fracture fixation, whether it's Indian or imported one, you are going to use the stainless steel or titanium one. Because it can happen later on that he gets the knowledge, because these days patients are this digital media and the Google has made a revolution, so they know everything about the implant. So you should tell them when you are using the stainless steel that I'm using this. In the knee replacement also, the people are these days crazy for the gold knee, but you have to explain them what kind of implant you are using and what are alternatives available. Again, for hip arthroplasty, you know, cemented, uncemented, all those surfaces, varying surfaces, they are different, because you have to give idea. The cost is this and the implant is like this. In arthroscopy, again, what kind of screw you are going to use, whether absorbable, titanium or SS. Even for immobilization material, that patient can claim later on, why you have not told me that there is some imported cast or fiber cast or something this kind. See, whatever I'm telling you is nothing theoretical into that. I get at least 2 or 3 phone calls per day from all over India about the problems which they have landed up. And all this, my lecture has come out of that experience of the other people. And some of them are from my own experience also, because I practiced in the rural area of Fulton for 3-4 years, in suburban area, semi-rural area of Vadapur, and then in the heart of Pune city. So I have gone through all these things. Now let the patient choose the implant and material, give him the plus and minus points. And duration, you have to mention that partial weight bearing, non-weight bearing, that you have to specifically mention in the document you are giving to the patient. Because the patient starts early weight bearing, and if he tells that doctor na मला लवकर चालायला सांगितलं म्हटल्यानंतर then will be in problem. Then about the procedure complications. As with all procedures, you have to write this carries some risk and complications. What is the anesthesia? What is the procedure? What are alternative anesthesia you want to give? What are the complications of that anesthesia? Thus, as a pause, when I went to Germany for in a long time in a fellowship, I found they had a consent form of almost 4 or 5 pages. And I laughed at that because we were taking consent hardly over 4 or 5 pages. I said, why it is required for to take so much consent? But now the time has come in India that we have to also follow their 2 lines and have such all these things were mentioned in that consent. What are possible intraoperative complications? What are possible postoperative complications? What is the delayed infection also one has to mention into that. Then there are 3 categories like this. One is common with a percentage of 2.5 and detail of that common. Second, less common, and third is rare. And death, we mentioned every consent of close reduction also because this has happened in Pune itself. A patient, 28-year-old boy, having elbow dislocation, and he died in the general anesthesia. Okay, which takes hardly fraction of, you can say, few seconds to reduce, but he has died in this. If this data was not mentioned in his consent, then doctor is seriously in a trouble. So this rare complication can occur because any of the above complications you have to mention. At this also we mention every time that death can occur during anesthesia, during surgery, or even post-op period also. Sometimes our replacement or old patients, they succumb, say 3-4 days later after post-op period, but that should also mention. And about anesthesia, as I said, short explanation of all these anesthesia and various blocks. What are the alternative anesthesia which are available? Then additional anesthesia. Sometimes you have to change from the regional block to general anesthesia, but that has to mention in the consent. Then again, name of the degree and the primary anesthetist as well as assistants also. Better always to write down the name, degree, and the registration number. The risk and the complications, as I said, as in the surgery also, here also you should mention less common, less common or rare. And again, same about the death. Now, surgical complications. These are generally common complications, unexpected excessive bleeding, fracture during any procedure, neurovascular injury, cement complications, change of plan during surgery, and authorization. That is, the change of plan is required. I authorize doctor to take that particular decision. In the post-operative, all of you know all these things one has to mention. Remember to mention metal allergy, which is extremely rare, but if that can occur, it should be mentioned in consent. About implant surgery, you have to mention about possibility of removal of implant in future, or sometimes, and this is additional surgery with additional expenditure, because sometimes they think everything is a package deal. You have to mention that sometimes if the after fracture is united, or if the pain during the weather or airport security, sometimes you have to remove the implant. And then complications of the implant that all of you must be taking in consent, like breakage, loosening, migration, and again allergic reactions. Abandoning surgery is another important part. Sometimes you have to abandon the surgery because any kind of reason like unexpected bleeding or unforeseen intraoperative complication, and sometimes these days because of certain problems in the hospital, the generator doesn't work, the drill doesn't work, the CM doesn't work. There are so many things into that. And one of the cases has in Mumbai itself has gone in against doctor because he was doing pedicular fixation and CM stopped working. And then he have to abandon the surgery, but the case went against him because it was not mentioned in the consent. The next is the non-medical accident during operation. Like, as I said just now, failure of the breaking down of equipment, especially arthroscopy, because you can't have an alternative for arthroscopy equipment. Then machines like gunset, OT light, OT table, suction machine, anesthesia workstation. And again, this any mishap to operating surgeon. I think last month itself, one surgeon in Hyderabad died. But he died between 2 surgeries, spinal surgery, not during surgery. But then that is another part which can happen, especially to the elderly persons like us. Now, further information, possibility of injury to the patient inadvertently during transfer to wards. One of the cases has come directly to me from Bangalore because they were asking all those things. The seizure was done, and while transferring patient from the operation table to the trolley, the patient fell down, was a heavy one, and she had internal bleeding and she died. And the doctors did not explain properly to the relatives, and then there was a problem in postmortem. Everything had come up. So this also can happen. Rarely, it happens rarely, but for that particular doctor, this one rare incident can harm his life. Then possibility of keeping in the ICU with chance of increasing bills. This has to be mentioned there. Possibility of shifting to the higher centers, especially for all small nursing homes. I tell you right this at the end that you may have to be shifted to higher center in case of unexpected complication or situation. and mention that if you have any complaints about your treatment or your care, you are always encouraged to discuss them with your surgical team. Then confirmation, this is at the end. I have read all these sentences should come into that. I understand another surgeon other than my consultant may perform the operation. They will have adequate training and supervision. I understand that I will have opportunity to discuss the details of anesthesia with anesthetic before the procedure. All these are sort of disclaimer you have to take from the patient. And I understand that any procedure in addition to those described on this form will be carried out to save my life or to prevent serious harm to my health. And at the end of the consent, as I said, patient and two witnesses, and mainly preferably first degree relatives. In the initial days of my practice, this happened. I was doing a spine surgery for a quad iguana, and we had taken a signature, and that quad iguana did not recover after that. And then the chaos started. I said, I have written everything on the consent that I'm going to just decompress and it may not recover. But the person who signed that was his business partner. That I did not see. So they say, business partner, you have came together and you have done all these things. So all these things has to be mentioned that he has to be closely relative. And if the now what we are doing is a computerized consent. It is a sort of a printed consent, but not a blanket printed consent. You can print the name of that particular patient in that, and when the consent comes out of the printer, the patient's name is there already printed. So it is patient-specific consent. So that is allowed. Then second confirmation, as I said, just few hours before surgery. Again, name of surgeon, signature, and designation, especially to the multi-specialty hospital. Now there are other consents which you don't do. These are not medico-legal consent because they come in the national registry. There are certain samples for the THR, for example. As I said initially, first all the names and everything. Then operation, totally to replacement. Then procedure in short. This is a short procedure. Then alternative procedures. What are other alternatives other than the total hip replacement? Then what are the risks? As I said, common risk 2 to 5%. Blood clot in their own language. You have tried that bleeding, pain, and the loosening or the wear. All these things, altered leg length. Many doctors have to pay huge amounts in US because the leg was 1 inch smaller and shorter, and they did not mention the consent. Then joint dislocation, then less common. All this for that particular procedure you should write. Rare complication like nerve damage or altered healing, bone damage, blood vessel damage, and lastly the death. This rare complication can occur from any of the above complications, and patient can die during anesthesia, during surgery, and post-op period. And a confirmation of the consent. There's 2 times you have to do that. And lastly, the name of the surgeon. So this is the one format of the consent which are done. Same thing for femoral nailing. Here, this is about the only thing is about the details of the procedure. If the patient is from Sadash Beta or the irritating patient, it's always better to do all these things. This is a big, almost operative note one has to write. And at the end, please be aware that a surgeon other than the consultant, but with adequate training or supervision, may perform the operation. So take-home message is situation has changed drastically. Anybody can get into the medical issues anytime, irrespective of his age, his reputation or experience. Can happen with anybody, as I said, even with your close friends or relatives also, your business partner, anybody. Then not to worry, but what I say, don't worry about this. Don't get scared at the beginning of the conference. Don't get stressed out. Once you accept this is a part and parcel of our profession, you become more alert and get everything known. We are studying such a complicated all procedures and everything. This takes hardly some time, but we don't pay much attention to this. Just follow everything, follow the documentation properly, and there is nothing to get worried about. Spend more time with the patient. That is important. Communication and counseling of the patient is the key to avoid medical legal litigation. Then keep all records properly. As I said, documentation and consent. And these days, now they are coming up with from the IOA to form a uniform consent all over India for a given procedure. That's what we are coming up so that in court of law, it should not happen that this has remained and this has not remained, because this is the consent which is accepted by the National Association, and that job has been given to me. So this is the take-home message. Thank you very much.
Dr. Karne sir, I have requested him to write a chapter on this thing, how to take a consent. And we are now bringing out from Maharashtra Orthopaedic Association on behalf. OT is my temple book. And now he will write a very good article on this thing so that everything will be clear. And Dr. Karne sir, I request you as early as possible you finish your article.
Thank you, sir. I now request our next speaker, Dr. Sangeet Gawale, sir, to please proceed towards the stage. The topic is principles and indication of intramedullary nailing.
Simple topic to begin the webinar, to begin the seminar. Indication and principles of intramedullary nailing. Over the years, nailing has been the standard treatment for long bone, diaphyseal, and selected metaphyseal fractures, providing sufficient stability with limited soft tissue dissection. As regards the indications, these are the areas where you can nail the fractures: the proximal humerus, the metaphyseals, the proximal femur, the distal femur, the proximal tibia, the distal tibia, apart from the diaphyseal humerus, femur, and tibia. What are you going to achieve by nailing these fractures, which are particularly at the junctional zone? These are the foremost three principles which you must follow. Restore the length of the limb, restore the weight bearing axis, avoid malrotation like this. And if you are successful, your healing will be with the callus because of the elasticity of the nail. It is always a secondary healing what you get in a nailed femur or a tibia or a humerus. The static and the dynamic interlocking nail, they have their own indications. The static interlocking is used when there are severe fractures, comminuted fractures, segmental fractures like this, where you are concerned about the rotational and the longitudinal instability. So these are the indications of using that static type of nail. Whereas the dynamic one, you can use whenever the fracture is stable, like a short oblique or a transverse fracture of the tibia or femur. Dynamic interlocking, one bolt only is used in the proximal and distal to get a longitudinal stability. In the dynamic hole, you use it in a elliptical slot. When the patient bears weight, it allows some longitudinal compression, and that gives better stability in these type of fractures. Whether reaming is required or not is a controversy which is going on since ages. But as regards the stability of these fractures are concerned, when you ream the medullary canal, it increases the nail bone contact. So that gives you a better stability. It allows you to use a thicker nail and your construct becomes very stable. So rim nail will have a much larger contact area it will have a better working length of the nail. The construct is more stable. It allows you to use a thicker nail so that the chances of deformation of the nail when the patient starts weight bearing are little. It has a high union rate and has a shorter healing time as compared to the unrimmed nail. So you can see here, this was a complex fracture and it has a thin nail has been used without reaming. So even though there is no rotation, significant rotational element, the length of the femur is achieved, but you can see the angular valgus deformity which has resulted along with the proximal deformation at the first hole. So if you just exchange it with a thicker size nail and of appropriate length, the deformity is corrected and you achieve a better stability. You ignore the comminution in the diaphysis, the fracture is going to heal in expected time. When the nail of the same size is used as a of the reamer, the amount of contact area is less, but if you increase the reaming size by 1 millimeter, the contact area increases by 38. If you increase by 2 millimeter more, so it goes on increasing like that. Reaming significantly increases the vascular perfusion of the surrounding muscles and the deep soft tissues. The effect lasts usually for 12 weeks after reaming. It also helps in internal bone grafting. It stimulates the blood flow. It activates greater cellular humoral response. It enhances the fracture healing. You can see here that has helped by exchange dynamic nail in this case, a non-union, just a plain exchange nail wherein only distal screws were used and the fracture has healed in 4 months' time. So goal of fixation with intramedullary nail is to achieve stable fixation, resulting in indirect fracture healing with callus. So these are the 6 steps which are necessary to mention. I'm mentioning this. It will be discussed in the workshops also and by the individual speakers who are discussing particular fractures. The biomechanics of the nail are assumed to, it is assumed to bear the most of the load initially, and then gradually as the fracture consolidates, the bone takes part in the load bearing. Larger diameter nails are both stiffer and stronger as compared to small diameter nails. Here is a case where presuming the fracture was in diaphysis, only one single screw was used proximally and distally to stabilize it, but in about 6 months' time, the nail broke, there is a non-union, and the screw has also broken. So that was exchanged by a nail which has multiple holes distally. This has 4 holes with 4 bolts distally to give stability in the distal femur. Whenever you have a junctional fracture, the nail doesn't have a contact with the bone here. So you need to augment these junctional fractures in the distal third or the proximal third with an additional plate, or using the longest available nail going in the subchondral, either using polar screw or adding multiple screws to the distal fragment. Whether to use a hollow or solid nails, hollow nails are designed either in an open cross section or which are slotted, or a closed section. The purpose of a slot is an intramedullary nail is to allow radial compression upon nail insertion, thereby accommodating minor bone or nail geometric mismatch. The solid circular nail, the bending rigidity is proportional to the third power, and the torsional rigidity is proportional to the fourth power of the nail diameter. Whether to use a titanium or steel nail, the ultimate strength of the titanium is approximately 1.6 times that of the stainless steel, whereas its modulus of elasticity is approximately half and therefore closer to the modulus of the cortical bone. if you have to address biology in certain situations where you have so much of comminution, so if you have achieved a good stability, like in this situation where the contact of the nail is good in both the fragments, both proximal and distals have adequate locking screws, it will go ahead. We can see even the fragment is reversed over the time. Just because the nail is stable, it has healed very well. The fragment which is reversed, there is no contact with the nail. You can see that has healed beautifully. Or in certain situations like this, where just addition of a cerclage wire, where close reduction is difficult, by limited opening and using a cerclage wire, whenever you're using, don't use it as a single loop, use it in a double loop that does not allow the wire to slide proximally or distally, and you can get a minimum compression required to approximate that fragment without disturbing its soft tissue attachment. And that is how it has healed. That is this range of movement. A weaker construct like this, fragment doesn't contribute to the healing. The nail is thin, and in such situation where the contact between the nail and the bone is poor, there are higher stresses on the nail. Either it will break at the non-union site or at the screw hole site. So this is instability which is evident by a fracture subsequently. And this has to be revised by a thicker size nail with more number of screws proximally and distally, and that goes on to a healing very well. That is this range of movement. So whenever you're using nail, like how you consider the principles of construct stability, similar situation is with the nail. If your construct stability is poor, that nail is not going to work. By construct stability, I mean a good contact between the nail and the bone. If you don't have that good construct, you can add an additional plate or other situations, polar screws, more number of screws, or a nail which has multiple holes, a nail which goes at the subchondral bone in the center of the distal femur and the tibia. So these are the various ways by which you can improve the construct stability in the nail as well to achieve a good union in expected time. The drawbacks in the intramedullary nail is a lack of accurate knowledge about the ideal mechanism or the mechanical environment that promotes healing. And as I said, the foremost is the construct stability in the nail also. So there are developments or we have to develop engineering tools in the field and more profound, which will understand the relationship between the biology and the mechanics. And if you have a choice between two, it is the mechanics which plays a significant role as far as nailing is concerned in these fractures. Future prospects, these are the things which are coming up where implant sensor technology can be used, where a sensor can be implanted at the fracture site in the nail, and that will give you a judgment of how much is the healing going on, and you can take a decision if it is not adequate. Surface coating technology, which is already there, even either antibiotics or growth factors or BMP have been coated to enhance the healing in these difficult fractures. Even a magnet remote activated chip implanted along the nail in the fracture area gives you a non-invasive information. It's a non-invasive whether there is adequate compression occurring at the fracture site. To aid the assessment of the fracture healing, allow the early detection of a non-union, and to contribute to early intervention are the future prospects which are happening. And very soon we will have research in this direction and useful information which we can transfer as a surgeon to our patients. So that was all about the indication and the principle of nailing. Any questions related to that, or you take it at the end? What is working length? The controversy is most of the books and everywhere, that is what is mentioned. So that means if you use a 36 size nail for a comminuted fracture, for a transverse fracture, for an oblique fracture, the working length, irrespective of the fracture, will remain same. Am I right? Unlike a plate, which will vary, which is in your hands, to whether you keep it closer to the fracture or you keep it away to get a bridge effect or to give a compression. So the same is not applicable to the nail, but all the literature, all the books describes the working length as the distance between the two screws near the fracture. But I fail to understand if your nail size is 40, 42, it will be constant for all the type of fractures. So to me, working length is how good is the nail bone contact. Now, we have a distal third femur where the nail doesn't have any contact. It is in the center. So that is a poor construct. So you can increase the stability or improve the working length by adding polar screws, by using a nail which has 3 or 4 screws distally going through the nail, or keep the nail as close to the subchondral bone as possible. So that improves the working length indirectly of the that unstable fragment. In a yes, both static. That is what is recommended for unstable. For a stable, it doesn't make a difference. For an unstable, it has to be a long nail, static nail, whether it is a intertrochanteric, subtrochanteric, or intertrochanteric, subtrochanteric, or ipsilateral fractures. So it has to be statically locked nail.
Thank you, sir. I now request our next speaker, Dr. R.M. Chandak, sir, to update us about the reaming techniques in intramedullary nailing.
Good afternoon. Intramedullary reaming is one of the most common mechanobiological technique we use in orthopedic technique. If the medullary canal is narrow, it may be necessary to enlarge the canal. All of us would do that. And the reaming allows the insertion of a larger diameter nail, which would provide sufficient strength for our patient to mobilize early. Reaming also increases the length of contact between the nail and the endosteal surface of the bone, and that is our judgment which size nail to use in a given patient with lot of comminution. Although reaming may damage the endosteal blood flow, actually in practice the periosteal blood flow is still sufficient for fracture healing, and during the period perioperative phase the endosteal blood flow also improves. Before reaming, we would always like to open the canal, and that is a very important judgment in a given patient, what technique you are going to open the canal, whether in tibial plateau or during the femur nailing. And the instrument used to open the canal could be most commonly used is a awl or a drill bit or a cannulated cutter. Find out what works best. To me, whether patient has an adult tough bone or elderly osteoporotic bone, on that depends your drilling entry point. So when the ends of bone are closed as in a non-union, you may have to use a drill to open the canal, as was done in this case. And when you use drilling or reaming, both actually create a hollow. But drilling is conspicuous that it draws out the material of bone, and in reaming, you don't draw out the material of bone, you are enlarging the hole. So you may have to use them judiciously. Improvising the instrument inventory for entry is really very important. And to me, the best entry out is from the AO, which has these serrated edges, and you are able to create an entry point as well as the entry path so that your guide wire takes the path you want to take. Reaming, opening the canal and guide wire insertion is our next task. And then before that, you must evaluate the canal in toto, what way your guide wire is going to take shape. Coming to certain principles in reaming, olive tip guide wire is what usually we were starting, so that if the reamer breaks or some part breaks, you are able to drag it by back slapping. However, currently I use all separate reamers on a corded bend guide wire. Reaming should never be done without a guide wire. Occasionally, say in tibia, if you directly insert a reamer and ream, one, it wobbles inside and you may break the reamer or you may spoil the reamer. Also remember, thermal heat is generated. So after every reamer I take out, my hand would palpate the tip of the reamer, whether it has become hot. If it has become hot, run a story, talk to your person assisting you, talk to ward boys, spend some time before you take up the next step of reaming. That is very crucial, because if you burn the bone, the healing is affected and people have suffered with a segmental necrotic loss, as was reported in this paper. And I have seen 3 patients in my life where the whole anterior part of tibial skin around the reaming segment got necrotic. Before reaming, always assess your canal and develop perception what type, what size nail you are going to use. Like in this patient, one of the surgeons failed to assess that there is a blocked canal. He kept on struggling with the reaming for a long time and had a failed nailing supposition. Evaluate the whole medullary canal before reaming is essential. All of us would do that and is what is important. Avoid hitting the medial cortex, and if stuck in advancing the guide wire, so you have to need to have guide wire diverter, or you can use a fossa finder. During reaming for tibia, never use the tourniquet, or during that process, release the tourniquet. The guide wire can be usually central, but you can use your guide wire to your trajectory utilizing whatever principle you are using. Use tissue protector. Tissue protector also needs to be modified according to the need, and moderate power and speed should be used. Use high torque, low rotational speed, and incremental reaming is always better. However, you in an elderly wide canal, you can jump on 2 class also. Never drill too long in same position to prevent overrotting. What I do is, for spending this time, look at your trolley, look at something else, go to Siam and spend time. Don't ream continuously so that heat is not generated much. Guide wire centralization is crucial before reaming, and a small corded bend at the tip is useful. You may have to exchange this to a straight guide wire if you want to ream till the end of the bone, because on this part the guide wire can get stuck up. The correct placement of guide wire is an art, and there are some specific ways you can centralize the guide wire by 3 turns and 3 half turns. Try to obtain desired guide wire position and then start reaming. The position of the reamer can be checked intermittently under X-ray control, that is Siam control, and guide wire should be tapped at the end of, once you put it, just tap it with hammer that locks it into the subchondral bone. Occasionally it tries to come out. Then there is a device in the AO set which has a guide wire pusher with a black handle that you can reinsert the guide wire, tap it again so that you don't lose the traction. If guide wire is not placed centrally, this is what would happen, as was in this case, and then that required revision. Certain instrumentation which are useful. Thin rim is the commonly used from AO. There is no requirement for reaming rod exchange, and you can use it on a olive wire. But this is what my suggestion is, to use a good sentinel reamer and good striker reamer. They are single piece. That helps you a lot, because every guide wire, every reamer is a separate reamer. You can have from size 5, but usually you require from size 8 up to 14. And a good power tool is what is important. This is front and side cutting reamer. So always have one very sharp front cutting reamer. At times the reamer doesn't initiate reaming. So at that point you need a front cutting reamer. So always have one very good front cutting reamer, or you can use a side cutting and front cutting both. Power equipment is very useful. A low torque machine is not a very useful thing, and initially few low price drills gave us a lot of trouble, but if a good power drill is there, that is very useful. The flexible reamers should always be used only forward. They should not be rotated back. If you want to take out, never go reverse, because reverse may lead to uncoiling. Never do that. And then the AO flexible reamers come into various forms. Usually there are 3 shafts, and they are very useful for reaming. They may have detachable reamer heads, or we may have a common separate reamer. There are various types of reamer shafts. It could be a coiled one. It could be a nitinol. So nitinol is a very good, because it has good flexibility and it doesn't usually damage. A coiled spring you can't rotate back. Occasionally you are stuck up, the reamer doesn't come out. The trick is push it forward again, and then at a high speed drilling speed you take it out. That way it can come out. What are the qualities of a good reamer? These are the ideal qualities, but they are not found in every reamer. So you have to mix and match your reamer inventory. So these are the various sizes available in the world, from 0.5 mm to 18.5. In India, we very rarely require 18.5. Maximum usually is between 8 to 13.8. Certain reaming pearls, always use the reamer rod with olive tip when you have separate reamer head. Cut the initial pathway with a 8.5 mm cutting reamer head. Make subsequent passes with reamer heads in 0.5 increments. That's a good practice. But in a patient who has fat embolism syndrome, I would use minimum passes and use the most appropriate size you are going to use. Certain methodologies. So this is what a reamer reaming when you use. So use on a good tool and look for the reamer chatter. As soon as you get a reamer chatter, this is the time you need to hold the thigh. So don't allow the middle fragment to spin continuously. Hold, somebody should hold it, and then go on exchanging with the reamer sizes. A good reaming done for a shaft mid-shaft would lead to this picture on day 8. So you do see reaming all around the fracture site. This you would not see in a non-union scenario, but in a fresh case, these reamings are very useful. Support the thigh if you have a reaming chatter. So I would ask person to have 2 sponges in both the hands and hold and clamp to the thigh so that the spinning does not happen. What are the effects of reaming? It is mechanical effect. The small diameter changes and enlarges. More reaming is required in non-union, exchange nailing, allograft bone harvesting, and infected non-union. There are certain contraindications to reaming as well. Polytrauma patients, we have to have minimum reaming. Open tibia fractures, it is controversial, and in presence of acute infection, you don't ream. Obviously, in tumors, you don't ream. Some complications which are really dangerous and can happen sometime in life is fat embolism syndrome. Fat embolism happens practically in every patient, but the fat embolism syndrome is conspicuous, that affects very few patients. So we have to identify those subset of patients where it can happen, and it can happen in any case, and you have to prevent further damage in those patients. In those patients, I would use a reamer. These are the complications which can happen. What happens, even a reaming rod insertion can lead to fat embolism syndrome because it pressurizes the medullary cavity, and with the Pascal's law all around the bone. And in the experiments, when you put a tight reamer, the fat can be seen emerging out from the bone holes. So fat embolism syndrome, this is what the world literature says. And if we have a ARDS, that is very disastrous. These are the common contraindication. A bleeding disorder, we will not do a reaming. Blocked canal with a metabolic bone diseases, and active metabolic metastatic disease are contraindications. Certain advancements or certain additional things I would do for my patient. Look at the adult femur available, femur length is only up to this point, and this much amount remains outside to connect to the bone. So for this purpose, I specifically got a 580 mm. Manman helped me out in getting this. So what are the shortcomings of a conventional reamer? Difficulty in reaming distally. This goes up to this point. So we can do, and that in that case, only a shorter nail could pass in a tough bone. So we can use a long reamer. So this is what the long reamer goes, 580 mm. Our routine length is 480 mm. So this can go up to the tip. And for going up to the tip, you don't use a quad bend, you use a straight reamer and exchange it so that we can use. So these are certain cases where we need reaming right up to the tip of the bone. And there I would use a long reamer, 580 mm, and then nail can reach just up onward so that you get an adequate purchase onto the bone. And this was really with a long reamer. So there are certain cases where reaming is really tough and difficult. So look at this patient. Initially to me looked like a pathological fracture, and it is a pathological fracture, but biopsy came negative for malignancy, and it required a lot of workup before fixation was attempted. Biopsy suggested paraproteinemia along with all tests, and then we were not able to ream this on table. So I had to use hand reamers. So this was the patient, and this was a typical clinical presentation of the paraproteinemia. Look at this canal. There is hardly any medullary cavity. There's no, even the guide wire just could not pass even when we opened the fracture site, and that had a tough. So there, a hand reamer is a very useful tool. The tip of a hand reamer is more sharper than the conventional flexible reamer. So that is where a flexible reamer set of hand reaming is very useful, and that also was going only on one side. So tough time reaming that for almost 2 hours, and then we were able to nail that. There are certain different canals which are really difficult, like in osteopetrosis. The trick in osteopetrosis would be to use sharp multiple drill bits, use irrigation copiously, clear the flutes. So unless you clear the flute, it generates it and keeps on rotating. May use hardware drill bits, and at times we have to use abandon and select plate fixation. How to manage difficult reaming? So this is another patient where this patient had 35 years back fracture of the shaft femur, which was K-nailed at that time. The nail was removed, but now she had a second fracture after 35 years, another trauma. And look at this entry point. Here the end of the bone is totally blocked at the fracture junction. So getting this close was difficult. So we were able to pass the guide wire up to that junction, but not beyond. So we had to have hand reaming again. So hand reamers are again useful. And then with the hand reamer, that end was, and you need to have a long hand reamer. And then that was done. In non-union, proximal part needs more reaming. So you also need efficient reaming and widen so that the broken part can be removed. Remember, ream a properly reduced fracture. So always before reaming, take all the measures to keep the fracture longitudinally reduced, and then the reduction will be proper. Reaming also makes your nail removal easier. So if you have adequate ream +1 +2, the nail removal at the end also is difficult. So in this cloverleaf nail, this is especially important. Reaming is a boon to us for fixing the fractures adequately with good purchase onto the bone, and we can use a good size nail. Thank you very much. Any questions? I'll just like that. So do this practice. Take a guide. So you take a guide wire which is gently curved. Your entry point is piriformis fossa for a nail, or the trochanteric medial entry, whatever you take, and then practice this. What happens? So I always like to do this. The quad bend is at the tip. So you pass the reamer. When you pass this reamer straight, it goes to the mid shaft, and then it tucks. That is the first place where it's stuck. At this point, half turn. Then you go on further. It goes to the distal third of femur. then again half turn back, it comes into the center. So try this. It is not an exact technique, but it helps you localize the distal part of the nail quite easily. So usually this is 3 turn and 1 half turn. That is how it helps in centralizing the guide wire. Of course, image is a useful thing when you want to use it.
Chandak sir, I have one query. Suppose while doing the reaming and if the patient goes into the shock and hypotension, in that situation, whether you continue doing reaming and everything, let it be with the anesthetic, or you stop doing this?
So you have to identify 2 different situations. Whether patient is going for a fat embolism and hypoxia, or a patient is going for hypotension. If he is going for hypotension, that means you have done a rapid reaming, you need to do a volume replacement. If it is hypoxia which is happening, I would immediately stop in that patient, either use whatever small size nail come out, or just then do a X-fix, which would be a damage control orthopedics in that situation. It did happen in one of the cases where we just started putting the guide wire and tibia and patient went into hypoxia. So we had to stop. Anesthetist tried to resuscitate, we intubated the patient, put a X-fix, came out, patient required ventilation for a day or 2. That was a massive fat embolism syndrome, but he came out after that. So this would be my strategy.
So that is very important. One is tachycardia and hypotension and hypoxia. These are the 3 things which have to be looked while doing the reaming. If you have a hypoxia and tachycardia, probably the patient is going for a pulmonary embolism. And if there is only tachycardia and hypotension, then probably he is going into a hypovolemic shock. So these are the 2 things which has to be differentiated, and it should be told to the anesthetist, please inform. So that in one condition, you may not require to stop this reaming, but you can continue the procedure after completing your hypovolemia. But in a hypoxic patient, you have to stop.
Thank you, sir.
So these are minor cases of fat embolism syndrome, not advancing to a major thing. Keep a close watch. Give them good adequate respiratory care. Always I would do nebulization, spirometry. Most of these patients come up. Keep a watch. My critical care physician advises albumin, and I have found very good result with that. So give albumin. Alba is what he prescribes. Hydrate them adequately. Don't allow them to go for dehydration, and also thromboembolism prophylaxis. If you are able to manage hypoxia daily improving, keep on that situation. Warn them that he may require assisted ventilation.
So one of the most important signs, especially in the wards, in the preoperative phase, is a tachypnea, respiration rate. Rather, we have made it a protocol to see the respiration rate of all the major bone fracture. We have found out the fat embolism tibia as well as humerus also. So if that goes more than 28, patient is completely comfortable. Patient doesn't have any symptoms. But then, because we can't put the pulse oximeter to every patient in the ward, so if we, but we make a chart of this TPRBP. So if respiration was more than 28, we have found one such patient that was completely comfortable, but the respiration was 36, and then PO2 was 84, and then further. Because fat embolism is the one thing, if you detect earlier, you can treat even in your own hospital. The delay in the fat embolism, then it is a disastrous. So first thing to see in the ward is respiration rate.
Perfectly said. Absolutely very important clinical tool. Yes, Sanjay.
Do you recommend prophylactic drilling a hole in the distal canal to reduce the intramedullary pressure?
So
in those situations,
so
4 situations,
yeah,
metastatic tumor, and I think, so does that help? Or in those who have high cholesterol, those who are obese, whom we suspect, they can go for ARDS.
The unfortunate
So is
thing
it
is
helpful?
when we don't suspect it happens. But fortunately, I have reamers, so I would use reamer irrigator aspirator reamer so that it does suction and irrigation both simultaneously.
Sunil was nodding his head. Any comments, Sunil?
If you see while reaming in especially closed cavity, with those who want to do like implant removal also, after removing implant, we see once your locking bolt is removed, to remove the biofilm, especially the infected non-indentations. That time, the pressure, the springs out, the material outside once you start it. To have a vent, there is a paper available there. You can see it. Okay. One last question, sir. What is the incidence of the incidence of this fat embolism is more? Either a hand reamer or a flexible reamer?
I possibly do not know the exact answer from literature, but if somebody has the knowledge, Sandeep, you can please.
There are two things. Your flexible reamers or hand reamers, if they are old, they are bound to increase the heat, they are bound to increase more pressure. But second, he also mentioned the force with which you are pushing it inside the canal. And third, it was hand reamer, because you don't know what force you are using. So it will be always more in hand reamers as compared to flexible reamers.
Answer that the biomechanics does not change according to newcomer or
Is he married or unmarried? Is he likely to be married?
Yeah. We always use a flexible reamer because your bow is always important to have, because the flexible reamers, those who are doing manually, it will be difficult to remove it if it is stuck and it can break. So it is not recommended to use a unreamed or that solid reamer, because solid reamer can break inside. So always use a flexible reamer. And if Indians are available, not necessarily we should have an imported one, but we should have a flexible reamer. And that to a pneumatic system. Those who are doing the power reamer, that is more dangerous. See, our medullary cavities are very small and it is very expensive. Buds are very expensive. So one synthesis bud of the reamer head costs about 65,000 rupees. So we tend to use more and more and more and get, sir, I said that hitting. And hitting has offers the change and the sharpness also loses. And we can't change every 6 months. So it is better to use a proper reamer with the pneumatic system. So AO recommends with the pneumatic system, not with the power reamer. Those who go, they give attachments of reamer with the power reamer, but it is not recommended.
To go on building up the inventory is the best.
That's right.
The problem. See, the problem was what we have purchased 10 years back from Synthes is obsolete now. Right. So they have come up with a different one, but still any imported one is a good option. That is why I said good father-in-law is required. But usually what happens is once we purchase, we tend to forget about it and we presume all are sharp, all will be helpful. Out of that, the commonest one are 9, 10 and 11. So at least these three you keep on changing. So maybe 3-4 years, depending on what volume of surgery you have.
Given a choice in TBI, it's not a big problem. A young 25-year-old male patient, femur is a problem. So you will aim for 2 size big, 1 size big.
1.5.
So it depends. I assess the canal very carefully. If the canal has more bend, you need to rim at least 2 more. For a PFN, I would rim even 2.5 more, because PFN, if you see, a long PFN doesn't pass easily. A long reamer nail pass easily, even if you are rimming 1+. So it depends. At least 1+ is mandatory.
That will increase by 28% the bone contact.
Yes, that is.
Also depends upon the metallurgy you are using of the nail also. More elastic the nail is, you have to get more in the range, because you are not supposed to hammer the nail. You are supposed to push the nail inside. Once you start hammering, there is a chance of fracture. So you have to get proper nail passage. So that's the reason you have to push the nail till the end, not the hammer.
So we
Sir,
welcome Dr.
sir,
Sunil
there is
to
another
talk.
question.
So you said that before you start the reaming, in every case you said that you release tourniquet. I want to know from the faculty, how many of you people are agreeing with him that every time you ream, you release the tourniquet? How many of you are agreeing to this point?
I do agree.
Do you release, Sunil sir?
I don't put any tourniquet for tibia nailing anyway. Never do that. We don't put tourniquet for tibia nailing.
So to give a mid-path answer to your question, not mandatory in every case, because in case the medullary cavity is wide, you are putting a 9 mm nail and you hardly are required one reaming. Do it slowly, gently at a low torque, or it sometimes just pass little, then wait. The aim is only one. You don't overheat the reaming. So that is what is the crux. So if you manage with your efficiency, fine. Ideally, recommendation is to not use tourniquet during the reaming procedure. If you are, say, for example, you are using in a sickler, I would not recommend a tourniquet otherwise also. And in this patient, the reaming is very hard. So in that patient, I will release the tourniquet. And in case you require to inflate the tourniquet, tibia nailing, otherwise also there is nothing coming out much blood. So you may do it without tourniquet. So the choice is with you. If maybe it may not be.
Well, I never remove the tourniquet for the tibia nailing after reaming. I'm on the
Thank you,
other
sir.
side of the table. One important thing I want to tell you of the tip of the one tip, that when you are reaming, what I do is the first initial 2 to 3 inches I ream with the hand and go up to 12 to 13. After that, once the 8 mm reamer is passed, we suck the femoral canal. I have got a long tip, suction tip, and we suck all the femoral canal and we go on irrigating it till the oil stops coming. You will find that if you start reaming, oil comes out of that. Even from the irrigation, oil comes out of that. The moment oil stops coming, then we start further reaming. So that is one of the way to reduce the fat load in the femoral medullary canal. And then the possibility of embolism, irrigation, and then once fat stops, then further reaming.
Okay.
This is a course. Each and everybody is requested to clarify your doubts, because probably you may get delayed by half an hour. It does not matter very much. It's not a conference. It's a question and answer and learning something. And there are very stalwart people are there. Some differences of opinion are always there. And it is a subject which is a very controversial subject, and we have to try to come to a conclusion. Therefore, don't be sitting. Just try to ask the question, whatever it may be. Okay, thank you very much.
Okay. Thank you, Aurangabad Orthopaedic Association and the Guardian Minister Akash sir for giving me this. I'm sharing this for the first time. I am working on this talk, which I am really see that we get a good delivery, and where should we use this combination of nail and plate. A lot of things have been tried. We have also tried, not necessarily everybody should agree what I am doing here on these cases. So the concept is where it is indicated, what is the stability which nail and plate gives, how it works, and is there any studies which need to do. So what nail acts as an axial stability, which usually gives a relative stability of the plate, which gives both axial and rotational slightly, which try to give most of the, we use plate for absolute stability, relative stability once a comminuted fragment. So once it is used in combination of both, will give a absolute stability. This is a new concept which Koji Kodima from Brazil has given this. It has not been studied properly, but it is coming up with the many times. So I don't want to confuse anything, but just giving this little bit experience what we have tried. In fresh fractures, if you use this judiciously, I'm using a word very judiciously. If you use this, will give excellent results. But in non-unions, this really works very well. So all these based on this, I'm trying to give you. So what is it is useful, where it is useful. The tibial start fractures extending inside the joint, either it is proximal or distal. The femur, the mostly I use in the femur, the unstable proximal fragment, which
I regularly use it. The stroke fractures, I regularly use it, and any metafacial-diapicial fractures, which you need to study it, because the highest failures, what we have seen in many of the best of the hands, is a reverse oblique fracture and in distal femur fracture, because nobody knows what is the things happen to the properly done distal femur fracture. It fails and fantastically works in non-union. So it's a super construct once you want to use it in absolute stability and may cause delayed unions in plate fractures and non-unions work in awesome way. So again, we will go into the details. So I have in this case with 26 years male with the road traffic accident. These are his X-rays. Now, if there is a multiple fragment fracture, and everybody will agree that it is a intra-articular fracture. And see the CT scan. The CT scan will show you how the ghastly nature of the injury it is. Whatever you want to do, you cannot reduce all these fractures, all these fragments. So your intention of here is to fix with the relative stability. So for the relative stability, because you can't put a latch screws on these each and every fragment. So if you try to do anything silly, you get into a non-union. And this is the 2D picture, how the void has created. So how to treat this is to have now the distal femur fractures, we have shifted from 1 implant to 2 implants. That means a combo, maybe a nail plus nail, with a nail was a small ender nail, a big nail with a big plate, a big nail or a small plate, lots of combinations. Whichever the combination works well, we have to come out with the study. And that is the way we are treating these kind of fractures, whether to on the medial side. These two small titanium elastic nails will give you elastic fixation on the medial side, which we propose that it always prevents the collapse. The commonest cause of non-union and distal femur is the medial void and a medial collapse. So you need to do a buttress, something on the medial side. So some people are doing a plating, some people are doing a nailing plus plate, some people are doing the intramedullary DFN, and then they'll lock it and put a plate outside. I have also started doing that, but we are in evolved position. But by far, in such fractures, this method has helped us very well. So it is solidly united, and that's the reason I was talking about when the morning there was a case Dr. Chandak showed of the implant removal. The distal femur is united here, but if you see the anterior void which is given by the fracture geometry, the gravity has pulled down all the fragments, and that is the reason the fracture has united, but there is a void. If I remove this implant, this patient may land up in a fracture. So this implant, till we put a graft or something to reconstruct that anterior cortex, we will not be able to remove the implant. So it is completely solidly united, and this is the function, the patient gets it. Now this comes to this a simple looking fracture. Then this is a CT scan of the fracture, and there is a fracture there on the Hoffa on the medial side. So this combination of a nail and the buttress plate on the medial side, which works very well, because the buttress plate is a very small plate, not that giving a big stability on it's the buttress plate. So it is not giving some sort of absolute stability. So you must realize and your thinking invention that what is to be done, where exactly, and how the principles work. Principles does not change. Any intra-articular fracture needs absolute stability, and which plates acts at, and the short femur give you a relative stability. So works on very well. Now coming to the subtrochanteric fracture, this is one of the most troublesome fracture to the orthopedic world. Everywhere, worldwide, there are many things. Many people have tried plate, the angle plate, the locking plate, the newer femoral plate, the long PFN. Everybody has shown lots of, about 28% of the failure rate worldwide. The best of the implants and the best of the surgeons have shown this. Because once we get the CT scan of all this will show you the all column fractures. So all column fractures with one implant, which is not enough to tackle. That's the reason the alone plate, alone nail will not give you enough stability till that the fracture heals. So once this is done, especially in younger patients, you need to give some additional, because once it is failed, it is the onus will come on the surgeon, not on the patient. The patient has come to a faith that you will do a better job. So once you do this, so we fix this with the multi-column fracture with the plate, and this plate is anterior. Remember, this is the anterior bridge plate, which prevents your, so it will not give you absolute stability, but it is called an absolute stability, and that it gives a superb union of around callus formation. So once it is absolute, you don't see a callus. Once you see the abundance of callus, and this way the fracture unites, and patient has sent, because of the corona it did not come, so he sent me the photograph what I wanted. So he has got full functional working. Now coming back to the tibia, the compound tibia fractures and the high velocity fractures injury comes with this. So we have to treat these intra-articular fractures. Then coming with he came with this external fixator on, treated by somebody else with the debridement and fixation. And then this was after getting this proximal tibial fracture, and there is a short femur fracture. We could have used now the long plates as a absolute stability, but nowadays we started shifting this to a plate and a nail combination, which gives you a support on all along the global fracture fixation, and so that the patient will have a reasonably good movement. And he has also sent the pictures from his home. So it gives a better result in stability point of view. But you must understand where you want to put a plate and where do you want to put a nail. So this is the case again, a small similar patient with the distal femur, distal proximal tibia and a plate and nail combination. Now coming back to the distal tibia, again the distal tibia in osteoporotic bones, especially the ladies, you get a cracking of the, where while doing also nailing, you may get a secondary fracture. So in that, so this is a case with the, see the void. I have CT scan here, and actually I forgot to put a 2D CT will tell you the void, the big void there. So alone nail will not be a good, so that you can pass a small buttress plate on the medial side, a small buttress plate, which will give you a better result and the stability. You don't have to open it, just to take small stab incisions and pass this locking buttress plate and give excellent healing. Now the role of this combination, especially in the non-unions. The non-unions, this is a real boon for all. So those who have got a lot of non-unions, they can start using this, because that requires absolute stability. This is the case, our case only. So one of my lecturers did this. This is the way we should, the mistake to me is he has used the short nail, and we've done what we have started doing this a buttress plate and nail combo till it has failed and broken. So non-union is very common, or that's the reason I have stopped using the short PFN, because reverse obliques will give you a lot of pain and the patient will come up with the breaking of the implant. So I use this a long PFN and a long plate. You see this is a combination of plates. So this is a percutaneous way of doing it. And you see the stability, there is nothing disturbed down there, only one screw on the down. And the plate is long enough to give you an excellent union, excellent stability, and excellent fixation and excellent function after that. So that, but absolutely, you have to be very careful in choosing these implants, which you require to have a proper training and proper use of your principles wherever you want to use. This is the infected non-union. Again a ghastly type of get, till we get a K nail in that, and infection, and we treat with the antibiotic coated nail with Elizaro on, so that you give rotational stability, and the intramural infection
is taken care by the antibiotic coated nail. And once this is nail, we remove, and then we put this combination of a plate, a small plate, and the long nail, which works very well in absolute stability. So there is still infection, but the fracture has started showing excellent union. And eventually the fracture has united well and is a good function. Patient is sending the photograph from his house so that he can do it. Another common way of doing it is a plate, small plate bending into a virus, broke, and then we use this osteotomy and fix the nail with the plate down and upstairs. So gives a absolute stability on this, and then eventually the fracture is united in the downstairs. Now the coming problem is with the fresh fracture. If you try to impose the same principle on the fresh fractures, then you have a lots of problems. The real problems comes here. This is a patient. I would have used the olden way of my doing it, a locking plate on the lateral side and the medial ender nail. But Dr. Dinarayan from Ganga Hospital has started doing the intramedullary nail and the plate combination. So we shifted to this kind of fixation. This is the CT scan of that same patient, which is a intra-articular fracture. So we treated with this a nail and the plate. Okay, it looks good. Patient starts walking next day. It's very stable, and till the 6 months there is no callus. This is after 8 months. Still there is a small callus. The patient has no pain. Patient is coming, but on X-rays it is showing less callus. So why it is so? Because it is a super construct now. It has stopped. There is no activity at all at the fracture site. So the fracture requires some sort of axial mobility, micromotion, and especially the comminuted fragments, where you require really a relative stability rather than an absolute stability. So we want to try to, because we have burnt our fingers with the ender nail also, we have plate, nail. So all these combinations have not been. So one of our students has done these cases. He has given a small nail and a long plate. So that works very well. So nail is functioning as an axial and the plate is, so it gives a combo of principles. But this is really a very absolute, because the plate through the locking bolt going through the nail also, that gives, there is no micromotion at all. So sometimes I am fear that it may fail. So that is the reason you should be very careful in choosing this kind of fracture. Another patient with the floating knee, we tried, this is CT scan. We could have treated with the just DFN, but we treated this because we thought that the stability is not enough. Still showing the patient has no pain, but even after 6 months, there is no callus form. That means the stability is more, but the biology is not functioning properly. So eventually, so we have to be very careful this kind of combination using for a fresh fracture. So for conclusion, so fresh fractures, nail plate, absolute may be a still controversial. I can't say just treating 4 or 5 patients, I cannot just change my opinion or I cannot impose any opinion. But definitely a small nail and the big plate has given good results everywhere. A big nail plus small plate, which also works very well in all metaphyseal areas. A big lock nail and a big plate becomes very rigid, almost like a super construct, so that it is extremely difficult for the patients to get showing some sort of callus, because we are also happy to see the callus there. It is not that it may not be a non-union, maybe a delayed union, but it will heal. That is the reason, because everything is lipo, there is nothing is disturbed, but still there is no micromotion happening at the comminuted fracture site, and that is the reason we should be very careful while doing this in a fresh fracture. But for the non-unions, it is really, really working very well. So whatever this combination is there. So take-home message is a metatarsal fracture, femur, a proximal femur is a big nail, the long nail, and a small plate. For distal femur, a big plate and a small nail, or an unlocked nail. I would say unlock, those who want to still use a DFN,
they can use a small nail with no locking. So don't lock at the proximal end. Just let it be there so that whatever the axial stability is given, but the plate will take care of the, so both combo will help you in an absolute way. So tibia for both proximal and distal, a big nail and a small plate. And non-Indians, it's a big plate and a big nail, maybe a good answer for a absolute stability. I thank you for, and I request all to register for this MOA Con 22 in Goa. There is a patch convention. There will be a workshop, and there will be a lot of newer things in MOA Con this year. So I request everybody to register.
Thank you, sir.
Sir,
Any
sir,
questions?
Sir, one question. Sir, excellent presentation. Thank you. Congratulations. Sir, what is the logic? Because both the sides are metaphyseal, like proximal femur and distal femoral. What is the logic that in proximal femur, you put a small plate and a big nail, and in the distal, a small nail and a very big plate? Because the plate goes from distal to proximal, like, yeah.
Correct. So that is the that was the contention that to give, both have failed in many times. In many of the times, both have failed. But our success rate with the nail in the proximal femur is very good. And distal, it is not good. So we have tried Ender's nail on the medial side, medial plating, then intramedullary nail, nail plus plate, dual plate, everything. So that's what I am very much scared, and now I don't want to recommend the long plate on the distal femur, from distal femur, and a long nail. I would use a small nail to give axial and a long plate which go up to the lesser trochanter. That is my but so I don't recommend a distal femur, a bigger plate and a bigger nail. Those who have seen 2-3 cases, but still they are under experimental. So I don't want to impose anything. I just wanted to have a combination. And why it works very well on the proximal femur, because the rotational stable nail in the Cyrus nail or a PFN, long PFN, gives excellent results on the medial side. So medial varus collapse is to be prevented, and the lateral wall reconstruction is done by the plate. So nail and a small plate works very well everywhere. That's what our contention.
Can I ask? Dr. Gade, see, distal femur has a metaphysis. Proximal femur has a cortical bone which takes a longer time to heal. Right? Now, the principle would be different. What he's trying to say is the principle is compression when you're using a more stable fixation in the proximal femur. So that means you require a smaller plate. Distal femur, you require little elasticity. So a bridge plate that is why a long plate. And nail, as he say, a short nail is what is required. But if you do the exactly opposite, so there proximally there will be too much of elasticity and distally too much of rigidity, which is not required. That is why he is recommending that.
Sir, when we are putting a distal,
Am I right, Sunil?
Yeah, absolutely.
So when we are putting a distal femoral nail along with the plate, should we aim that the screw from the plate should pass and go to the static or dynamic this thing, whether that will increase the biomechanical stability?
That is the crux, that you should not do that. That will give you more rigidity. That's what I'm saying, that from the plate, nail, distal locking bolt, I mean proximal locking, and then that pass through, it is not recommended. So don't do it.
In that case, you mean to justify that the intramedullary unlock nail is just to prevent the medial collapse?
No. The axial support, the midline support is required. Why alone plate fails? Because of the varus collapse. Okay. So either you have to put something on the medial side or in a central side.
The plate is as it is going to hold the fracture very rigidly. So unlock
No.
nail in a transverse fracture and unlock nail in a communicated or maybe a oblique fracture. The two geometries would be absolutely different situations.
But it has failed. The the alone plate, best of the plates have failed. Because of even in spite of median, there is no void. Still there is a failure. There is a varus collapse. So nowadays, it is now world going towards the dual implant. So dual implants may be anything. That intramedullary nail and the plate. What I have used it Ender's nail on the medial side, which has worked very well. Very well. I have done almost now 90 cases of distal femur, comminuted distal femur, which we already sent for publication. There will be a multicentric study also on Dr. Solapur, doctors, everybody is doing it now. From Chandigarh also we have cases. So the multicentric study is showing the distal plate and the medullary, the tense nail gives excellent results on the medial side. But Dr. Dina Dayalan just showed me they have started doing intramedullary nailing for the distal femur and the plate. Same thing he is also doing the nail for the proximal femur and the locking plate. They have reversed it. They have used a nail, unlocked nail. There is no lock in the proximal femur. And the proximal femur plate they have put like that. So how it works, I don't know. Okay.
Thank you, sir. I now like to invite our next speaker, Professor and Head Dr. M.B. Lingayat, sir. The topic is nailing in segmental fractures.
जी.
करून ठेवा तुमचं प्रेझेंटेशन डॉक्टर गाडेकर.
Good afternoon, everyone. Good afternoon, everyone. After forming session on reaming, non-reaming, how to nail the long bones, I have given a topic to give a tips and tricks of reduction, nailing, and reaming. So I try to explain it in the smaller way. You all know that the segmental fractures are challenging for most of the surgeons. They have a difficulty in reduction and giving a good result. They are known for many complications such as severe soft tissue damage, compartment syndrome, delayed union, non-union, varus and valgus malalignment. Before starting the tips of the reductions, before that I give some clues for reduction of the segmental fractures. First is the position. You all know that positions are different for the femur and different for the tibia, and positions depend upon the preference and the experience of the surgeon. In the figure, they show that the position for the tibia, some may use the position and hanging at the edge of the table or bending the knee more than 90 degrees on the table. So our practice, we keep the leg by the side of the table and bend around, approximately around 100 degrees. This is the position for the femur. Most of us are doing the femur in the fracture table or in a lateral position. Our practice is to do the femur nailing in the lateral position. Approaches, you all know that for the tibia, approaches are medial, palpebral or central. Nowadays, our MOA president developed separate approach, that is suprapatellar nailing for the tibial fractures. Entry point is very crucial for the tibia as well as the femur. You know that depending upon the level of the fracture, for example, if the tibial fracture at the level of the middle third, lower third, your entry should be in the center area. If the segmental fracture in the tibia, it is in the upper third, so your entry should be slightly lateral and slightly higher. Opening the medullary cavity as another trick. Your reamer should be perpendicular to the plateau of the tibia, so that you can't do any malalignment at the fracture site, typically in the proximal 1/3 of the tibia. Guide wire insertion is another technique which is useful to get a good reduction in the segmental fractures. The figure itself explains that how to put a guide wire. For example, in the tibia, if you are dealing with a segmental fracture, which is including the upper 1/3 of the tibia, so your entry should be slightly higher and lateral. Uniplanar external fixator, chance pins, plating, assisted nailing. These are some of the example of manual nail. How to do a manual reduction? You all know. Most of the surgeons are doing this manual reduction for the tibia as well as the femur. So manual pressures with the help of the manual manipulations and with the help of wrap, we can reduce the fracture femur as well as fracture tibia. Fracture reduction tool, that is F tool. Most of the surgeons initial days they use the F tool. For fresh fracture, doesn't require the F tool. They easily come, but in a older fracture, for example, 10 days, 15 days, the F tool may require. Percutaneous reduction clamp. This is another technique to reduce the fracture site, but this is useful in the tibia, not in the femur, because if the femur has lots of musculature around it, so clamp will not work. So for the tibia, it will be useful, but try to careful that before putting a clamp, it should not damage the other vital structure. Distractor, most of the time they are used for the plating. They rarely use for the nailing purpose. Unilateral external fixator, if you are finding difficulty in reducing the fracture, for example, a femur, you can put a unilateral external fixator and pass a nail and then remove that fixator and do your interlocking. Joystick technique, another useful technique, most of the time useful in the fracture femur, not needed in the tibia most of the time. They are useful. You can manipulate the distal fragment, middle fragment with the help of the chance skills and everything, and you achieve the reduction. The fragment with the help of the joystick or any other manual. How to prevent the complication in the segmental fracture? Compartment syndrome is the most common complication which is seen in the segmental fracture, that too in tibia, not in femur. So how to prevent it? Give a limb elevations, ice fermentation, manual fracture reduction and apply attractions, proteolytic enzyme tablets, and maximum dressing timely. If required, fasciectomy is needed to prevent the compartment syndrome in cases of tibia. Infections. How to prevent the infection in segmental fracture? Adequate debridement is needed, wound wash is needed, and proper antibiotic is needed after cultural sensitivity. VAC application. Plastic surgeon involvement is needed to prevent the infection or to take care of the infection. And infectious disease specialist opinion, like Nenusar is there with us. Other complication of non-inane segmental fractures is non-inane. So how will prevent the non-inane in the segmental fracture? Good anatomical reduction, prevent the soft tissue damage during the surgery. That's why we remove the whole advice to remove the proximal fragment, not the whole of the segment. Preserve the fracture hematoma as possible as adequate fracture stabilization is needed to prevent the non-inanes in the segmental fracture. For example, if you are doing a dynamized locking, it is not recommended in segmental fractures. You do the static locking, and if sometime needed, apply a plate as Kulkarni says. How to prevent the malalignment in the segmental fractures? You can use the polar screw or a pin to prevent the malalignment. What are the malalignments which are common in the segmental fractures? That is varus, valgus, recurvatum, and precurvatum, and can be managed with the placement of the polar screw or the spin pin. Intraoperative images and tips for the tibia fractures I tried to show in this in the slide. This is the proximal 1/3 segmental fracture. So see the entry point, which is showing that it is central and slightly lateral as compared to the other fracture side. Put entry of the reamer, it should be in the center of the canal in the proximal fragment. Your position of the guide wire is also important. To put a position guide wire in the center part of the all fracture fragment, and you have to check under the C-arm. After that, only you can put a nail over the guide wire. Here are some examples. This is a segmental tibia fracture fixed with the universal proximal tibial nail having a good unit. This is a case to another segmental tibial fracture. Then the static interlocking nails having a good result. These are other examples of the cases, that is segmental fracture femur fixed with the static intramedullary nailing having a good result. Double segmental fracture again the tibia fixed with the intramedullary nailing with the static locking having a good result. So what is the take-home message in the segmental nailing? So good preoperative planning is needed. Take proper precaution to prevent the compartment syndrome. Proper entry points. Minimal reaming of the only proximal fragment. Good anatomical reduction. Less soft tissue stripping. Timely intervention for delayed union or non-union.
Thank you, sir.
Thank you.
Sir, I have a question. Should we rim these fractures or should we not rim these fractures?
So I recommend for the fresh fractures, I recommend only reaming of the proximal fragment. Many of the salvage will agree with me or not, but we have an experience of so many cases in the JMC. So we will ream only the proximal fragment in cases of fresh fractures. In cases of non-inane, in cases of special condition, we advise to ream the distal fragment also.
Thank you, sir. Any other questions?
Indications of lateral entry. You take a lateral entry. How does it work?
So lateral entry in the femur is recommended for the PFN and tibia. Tibia. You know that the proximal tibial fracture. Proximal tibial fracture. try to put the central guide wire, the reduction will be difficult. You know that the center of the tibia is slightly lateral, not in the center. So it is slightly lateral. To get a good reduction for the proximal 1/3 of the tibia, your entry should be slightly lateral and slightly higher up. Otherwise, your proximal fragment go anteriorly. Otherwise, your proximal fragment go anteriorly. Second, you have to take assisted by the polar screw also if needed. If it is going above. Entry is very important. Your Reaming placement is very important in cases of proximal 1/3 of the tibia.
Proximal only, lateral entry you recommend.
Lateral entry.
That is the only one indication.
Yeah, only indication.
Thank you, sir. I now like to invite our next speaker, Dr. Girish Gadekar, sir. Topic is nailing in not so indicated places.
Good afternoon, everybody. So, the topic today is planing place of nailing in not so indicated places, forearm. So, I'm sure it may not sound as interesting as the previous lectures had. And yeah. So, the radius and ulna in concert with the proximal and the distal radial ulnar joint constitute a complex articulation which permits supination of the forearm. As with all articular structures, restoration of the exact morphology is essential as a platform for full functional recovery. The ulna is relatively straight, has stable articulation with the distal humerus at the elbow. The radius is bowed along its length. In the treatment of fracture of forearm, the radial bow and the proper interosseous space must be maintained for normal motion to be achieved. The prognosis of adults with fracture of radius and ulna depends on many factors. However, the factors under the surgeon's control include the choice of treatment method, timing of internal fixation in open fractures, soft tissue handling, and restoration of the osseous anatomy. The preferred treatment method for adult forearm fracture has always been plate osteosynthesis, and it is still the gold standard. Rotational stability and inability to maintain the radial bow has been a long factor which has gone against the use of nail in adult forearm fractures. In skeletally immature patients, the pediatric age group, there is always a potential for remodeling, especially along the movement of the distal joint. And for this reason, flexible intramedullary nailing of pediatric forearm fractures is widely accepted. So most of the surgeons here, I'm sure, in our careers and initial days and even now, we have used this nail, the Talwalkar square nail, and it was designed and propagated by Dr. A.K. Talwalkar. It came into two types. One was for the radius square nail, and other was the ulnar square nail. The radius, the ulnar nails, they had a trocar tip, whereas the radius nail had a beveled end, so that we can pass it through the radius along the shaft of the radius. And we have used this technique for a long time, but then it always came with its set of complications. The most common complications were non-union, malunion, and infection. Also, there were instances of nerve palsy, and most common was the joint stiffness, which particularly affected the rotations of the forearm. As I said previously, the inability to maintain the radial bow, because in this nail was relatively stiff and could not give that stability, the rotational stability, as well as the segment stability. Jamming of the nail and splitting of the shaft. So it's always a nightmare when a patient comes to you who has undergone a square nail, ulnar nailing, maybe a few years back, and he comes to you. Many times the bone has overgrown the nail and the nail is too jammed in the bone inside. So it's absolutely very difficult to remove the nail, and nor can we assure the patient that the nail can be removed definitely. In recent times, some developments have taken place, some new designs had come in the market. One of them was the TrueFlex nail. It was star-shaped in cross section, and it had a proximal locking bolt, which prevented the rotational instability of this nail and gave the length was also maintained. Other nail was the foresight nail, which was more like a interlocking nail of the radius and ulna. Both these nails had a distinct advantage that they prevented shortening in the metaphyseal comminuted and segmental diphyseal forearm fractures. But unfortunately, we never really could hear about these nails. They didn't come in market for whatever reasons, and there was less acceptance among these nails. So we never really looked into these nails. Then our very own Dr. Gadegone sir, who's here, he invented the screw intramedullary nail. And he also, his article on the same was published in the IGO in September-October 2012 edition. I'm thankful to Gadegone sir for providing a few slides for this presentation. So the principle of the screw intramedullary nail was it used the 3-point fixation technique of the elastic nail. And the second principle was the Kunscher's principle for filling up the canal. The radial bow was also significantly taken care of with this nail. And this bowing of the radius can be achieved. So the nail was previously contoured while putting in the nail. And this maintained once the radial bow was maintained, this maintained the normal rotation and of the radius and the ulna. I would request Dr. Gadegone sir to enlighten us if you could in 1 or 2 minutes about this nail, because we couldn't get much of. So these were some of the excellent results sir had got with this nail, and restoration of the radial bow and the length was very well maintained. Then there was another nail, Ahmed Kose, alternative treatment for forearm double fractures, a new design in intramedullary nail. So there were two different types of nail again for used in his technique. The radial nail had a dual angulation. At the distal part, there was about 13 degrees of angulation with a static locking screw. And proximally, again, there was a small bend in the proximal part of the nail. Both these nails were, the radial nail was passed from the radial styloid, and they were titanium. The ulna nail was relatively simple, but it was passed from the radial styloid, and a very interesting design, if you could see here again. So there were a different static locking hole in the proximal ulna. That bolt could be passed proximally, and as you tighten that bolt, depending upon how you have locked the nail distally, you would get a gradual compression. You can see that as this bolt here is gradually tightened, you can see that there is a gradual, once we have put the distal locking bolts, there is a gradual compression across the fracture sides. So this led to almost a good no gap between the fracture ends, and a good amount of stability as well as correction of the fragments, and very good results too. But again, as with most of this, we never saw these nails coming to India, and we never came across. I don't know if the seniors here might have done such nails, but we don't have any experience with that. So coming to that, so I would say that the most popular indication for forearm nailing, IM nailing, will be for the pediatric cases. As I said before, doing a plating for the adults is still the gold standard, unfortunately, because all of us would like to be in a situation like, we had a topic of nailing of long bones. We like a situation where the incision would be minimum and just passing the nail, doing minimal damage to disturbing the minimal damage of the local geometry. But unfortunately, we have not so far come across a nail which would fit into all the criteria which we want which we see in those femoral or tibial or to some extent the humerus interlocking nail. So the incidences of one of the most common pediatric fractures of almost 40% of all pediatric fractures are the both bone forearms, more in females than in male. 14% anatomical location, 14% diaphyseal, 60% distal physis, 14% distal physis, 60% distal metaphysis, 20% midshaft, and 4% in the proximal part of the bone. The common injury is, as the kids do have, fall from the height or some sporting event, playground equipment injury. Associated conditions, usually you get these bones with a floating elbow, which the ipsilateral supracondylar fractures may be affected, also fractured, and hence you have a floating elbow injury, and also associated nerve injury, the median nerve being the most common amongst those. Fracture types are incomplete green stick fractures, torus fractures, plastic deformations. Obviously, you do not need to fix these fractures. Most of them can be treated conservatively with close reduction and castings. So fracture location and pattern, should be identified. They can be the proximal third, middle third, distal third. Acceptable criteria for these fractures, since the pediatric bone, they have a good reduction potential from 0 to 10 years, we may accept an angulation of about up to 15 degrees, mal rotation up to 45 degrees, and bayonet opposition up to 1 centimeters. So these are the acceptable criteria for less than 10 years. But beyond 10 years, these criteria slightly increase. We may have a decreased angle of about less than 10 degrees and less than 30 degrees of mal rotation. So treatment can be, as I said, close reduction and casting for the majority of fractures. Surgical intervention is indicated for significantly displaced or angulated fractures in patients approaching skeletal maturity. Non-operative close reduction casting, and in operative we can have a percutaneous or an open reduction and intramedullary nailing, and open reduction and intramedullary fixation, internal fixation. ESIN, the elastic stable intramedullary nailing, or also the elastic nail, has been become a very popular treatment. And although there are several small series reporting results, few have prospectively assessed the functional outcome. Intramedullary nail definitely have a shorter operating time and better cosmesis. Plating will, as it's an open procedure, it's under vision, and we do correct the anatomical bow, and the function is better in case. But again, the location of this bow correlates with the rotation of the forehand, and functional deficit can only be restored by anatomical reduction and plating when the displacement more in these fractures. The largest prospective study assessing forearm rotation in English literature and highlights that ESIN in pediatric fractures of the forearm produces good to excellent results in about 84% of cases. I'll quickly run through the technique for forearm flexible nailing. So this is usually the fracture, how the fractures will present in the pediatric age group. So identifying the exact location of the fracture, how much angulation, the bowing, and then you can do the planning of the process. So determining the location, the shaft of the fracture, how much, whether there is combination, whether it is open or closed. and then to determine the appropriate size at the narrowest part of the diaphysis. The nail should fill the 2/3 of the canal. So a standard OT setup, which I think most of us would have. For the ulnar nail placement, the nail should not be passed from the olecranon process as we do in adults. We should bypass the epiphysis, and it should be slightly distal and lateral to the on the aspect of the ulna. The nail contour, as ulna is a straight border, no real contouring is needed. Alternately, the smooth Steinmann pin also can be passed in the nail. Advance the nail through the proximal ulna and under the C-arm guidance, confirm the placements in both AP and the lateral view. So once the nail has reached the proximal side, you reduce the ulna by giving a longitudinal traction or doing a manual compression. So if after 2 or 3 attempts you're not able to get the reduction, you may open the fracture slightly, and by putting your fingers, you may just approximate the bones and pass the nail. Care is to be taken that you should not do it more than 3 times, because there are high chances of compartmental syndrome. And also, if you're holding the edges of these arms, like, you may damage the physis if your manipulation is not too gentle. So once after you've passed the nail, cut the nail at the appropriate length, and just so that it is just palpable subcutaneously, and but not too prominent. For the radial nail placement, the distal radial approach is used. Identify the entry point for the radius nail. Usually there are 2 entries. One is the lateral entry and the other is the dorsal entry. The lateral entry is between the first and second dorsal compartment, whereas the dorsal entry is just interval between the second and third dorsal compartment, which is near the proximal base of the tubercle of Lister. So these are the entry points, the lateral and the dorsal ones. Once you have identified you make the skin incision. Care is to be taken that you do not disturb the superficial branch of the radial nerve. So you can use a awl or a drill to make the entry hole, and you can just, once the entry is made, the hole may be circular, so you can make it oval by using a tip ronger. So once you've passed your elastic nail, you can slightly bend it distally and curve it, contour it so that it takes the smooth bend of the radial bow. And with slight left and rotational movements, you can pass the nail up to the fracture site. And once the fracture
Sir, can I ask a question?
Yes, sir. Yes,
so the question is,
yes.
All of us are doing nailing and plating.
Yes, yes.
The problem comes when most of these injuries are high velocity injury. If it is, then the displacement of radius and ulna is much. You get a good reduction. Now the question starts from here. You see on table that distal radio-ulnar joint is disturbed. In that case, how do you handle it? And you are done with the procedure.
Okay.
After 3 months, when the patient starts doing rotational exercise, you find that DURJ is not functioning properly. How do you handle this situation later on? So these 2 questions.
So you're in pediatric age group or adult? Adult. Yes, I think. I'll be happy if sir can take that.
Then मी काय म्हणायचं तुम्हाला म्हणजे inferior
Sir, the question, set of question are two. On table, you have got a good reduction. Nail is inside. You found that there is a distal radio-ulnar joint injury. If you fix it, what are the points you take care of on table? Day one. And after 2 months or 3 months, you come to know there is a DURJ injury, distal radio-ulnar joint injury. What precautions you are going to take, and how are you going to convince that patient that we need to fix this also, if at all it has been done?
Actually, DRU injury along with the fracture both bone forearm, it is a most unstable type of injury. Generally, in a diphygeal fracture of the forearm, it does not occur unless there is a intraosseous membrane rupture. So, when you have a preoperative, also you can judge whether the inferior radioulnar joint is disturbed, not because of the length of the both radius and ulnar, that you have a, then on table, if you do an anatomical reduction and still there is a subluxation after your nailing, then you give the cast in supination. So that what will happen, whether it is reduced or not. If it is not reduced, then probably you have to go down and do a open reduction, something like that, but I have never done it in my life. And in that case, in supination, you just pass a ulnoradial K-wire for near about 3 weeks, remove it again, and then again you give a slap for 3 weeks, probably everything heals around in 1 and
While fixing this ulnoradial, do you press distal part of the ulna so as to get the good reduction, or you just pass it through?
No, you have to reduce it. See under image intensifier, and without changing the position of that arm, you have to pass the ulnoradial. Otherwise, what will happen if you do it like this and do a pass? It nothing is because it is already dislocated. So it has to be reduced, and then you pass the ulnoradial wires, see the stability, and then probably everything heals that joint.
And now
in,
the second,
in spite of all these things, suppose there is a subluxation and dislocation even after 6 weeks, this can even happen in the plating also. So it becomes a very entirely a different set of injury. So it's a complex injury that you must keep in mind that there may be a associated inferior radioulnar joint subluxation or dislocation that has to be looked when you do plating or nailing in fracture both bone.
Without wasting any time, I will go ahead. The difficult fractures of the distal tibia, whether to nail or a plate, it's a big question whether it is a pilon fracture or whether it is just a distal tibial fracture. But nailing can be done because nailing is much preferred for the distal tibia extra-articular fractures, not for pilon fractures. Because pilon you need to have a lot of things. You need to wait till the soft tissue heals, and then you have to rotationally stable implant should be given and also associated with fibula, and the soft tissues are the most important to whether to decide. So most of the time, if you decide to do a plating, you should be very careful about soft tissue because you are passing through the already comminuted fragments. So reduction, maintenance of the reduction, rotationally stable fixation, polo screws and fibular fixation. So nailing on the distal third is not much of a soft tissue dissection. Its advantage, biggest disadvantage, not the advantage is that you need not do any soft tissue dissection. You just have to pass the nail. First requires a proper nail. Sometimes you have to plan it so that sometimes the people get only 3-hole screws. You need to cut that nail and then use 2 holes of the distal, and then rest of the you can use either a small plate at the derotation or a polo screws. But for that, before that, you must do a CT scan to rule out whether it is extra-articular or an intra-articular extension, because most of the X-rays don't show any intra-articular extension. So you have to convert those extra-articular, intra-articular into extra-articular, and so that you can plan it. So the massive soft tissue problem is the crux and distal tibia, which is there, which will dictate you. So you have to wait and watch till the wrinkle sign, and whether the hemorrhagic blisters or it is just a serous discharge blisters, that depends upon the injury. You should be able to wait till the wrinkle sign, and you can sometimes you have to use sometimes a standing external fixator if the massive injury is there. So the methods of reduction, that is very important. Anybody can nail it, but that maintenance and the reduction of the fracture, you need to learn this technique. Every conference we see here that they put a nail, they put a plate, but the reduction is the crux of the success. Those who really try to reduce those fractures are getting success. Putting a nail and a screw is not a big thing. Carpenter also puts a screw everywhere. So you have to be a gardener so that you take care of the soft tissue and then reduce it. So there are two methods. One is direct method and indirect method. But the reduction is in what is called a footprint concept. What is a footprint concept is you have to reduce the fracture without damaging the periosteum of the already precarious blood supply of the distal tibia. You know, the distal tibia is very superficial. There is a skin and the bone directly. And there is injury plus the fracture has created a periosteal rupture. Also the soft tissues around whatever the blood supply is there. So you, wherever you are trying to reduce these, you must use those sharp reduction forceps. You must have those sharp reduction forceps, which will give you a minimal damage to the soft tissues and keep it reduced till you last locking bolt is put. Don't, after remove, just don't remove it. Now this is a case, this is a compound case, injury, and if you see how distal it is, can I have the pointer? So distally, so anybody would opt for the plate because this is up to the here, it is fracture is here. So, but anybody would, but the soft tissues were not that good to have a plate. It was compound, so I decided to put a nail, which was very extremely difficult, but not impossible. So on the reduction, so debrided, then this reduction clamp reduces this. You can use a temporary K wires and keep this clamp throughout the procedure. Don't remove it. Once you reduce it, don't remove it. So you have to plan in such a way, we have to use two clamps sometimes, one anterior posterior and one medial lateral also sometimes. So you have to use this clamp as a latch screw. So like a latch screw, you can put this clamp and keep it reduced that way. So that means how much is injured, this much only, not that damage to the stripping. Like a big bone holding forceps is not necessary to use it here. It's just a footprint of the bone, it is damaged, so that you will get a reduction, and then you throw out the nail, you pass it, then you can do it, lock it, and eventually the fracture is united with the. So as much as distal you can go, you can have a union of the fracture because you are not disturbed the soft tissues around in the distal fragment. So planning is very important. Is get the full length X-rays from the tibia, both ends of the tibia, correct length and diameter, because distally you have no choice. Because once sometimes your screw can be in the fracture side, and that is a disaster because that can break because you can't lock it. So sometimes you have to cut the nail and then the next day you can post it. So keep all the size and length available because it's a magnification which you have. So CT is very useful. Those who don't have a CT, it's okay. But those who have CT, they can have a magnification and they can exactly with the software, you can collect and they see the diameter of the nail also can be seen on the software. So the flat nail end can be used because the nozzle, the nail, the tip of the nail, which should not pierce inside the joint. Usually for distal tibial extra, as you go down, you must use this flat end tibia. So guide wire must be in the center. That's very important, that whenever there is a reaming, everything, it should be as distal as possible in the. So sometimes you require a femoral distractor to keep it distracted, not necessarily external fixator, but also keep the locking plate ready, because if sometimes the nail passing the nail, or sometimes the secondary fracture can occur, so that you can keep the plate locking plate ready for those fractures. So if the fracture is extending inside the joint, then you must convert those intra-articular into extra-articular by using a latch screws, and then reduction clamps are very useful in doing this. So polar screws plays a very important role, especially in these metaphyseal fractures of proximal tibia and the distal tibia. So where it is used, how it works. So the concept is to avoid malalignment. And believe me, you must learn how to put a polar screw. Without that, you can't do a nailing in any distal metaphyseal fracture unless you know the technique. It is not a rocket science, something which is out of the world. You must learn with the first K wires and then replace the K wires with the polar screw. Not necessarily every time you should use a screw and then change it. So that this is the really good method which been given by okay. So this is the polar screw when there is a varus, then you have to put polar screw more medially and the distal screw more laterally. That way you can do it. This is the case. We put a polar screw on the lateral side and then got excellent union. Whenever there is a valgus, then you have this screw can be adjusted accordingly. So there is a valgus position, you can do a good position of the locking screws. And when there is a not possible to put, there is a central or a direct impact, whether it is not possible, you can put two polar screws side by side nail. So they will not allow your nail to divert anywhere, valgus or varus. So that way, this is the patient, how distal fragment is crushed. And then you can use these two central polar screws so that the nail remains center, both AP and lateral view. And then it gives excellent stability on X-ray. Same thing can be used for the segmental also. You can use again the polar screws, which gives you a very good stability on the lateral side. So converting intra-articular into extra-articular also is a art. You must, for that, you need to have a CT scan. This is a patient, which here X-ray, you don't see much of the intra-articular. But if you see, there is a intra-articular extension here. See this, there is a posteriorly going. Everywhere there is a plafond fractures are there. So you must convert those into, before you take an entry point, you must convert those into it, and then you have excellent fixation of the fracture. The function. I have published this in 2015, the treatment of spiral and tibial fractures in the distal Journal of Orthopedic Surgery. So in conclusion, the distal third, if you go on oblique fractures, it's a soft tissue friendly. Basic, very important is the distal tibia, which is very precarious blood supply and the skin is very thin. So it is much more preferred if you are able to pass a nail, the nailing always preferred. Of course, it gives excellent stability with the addition of polar screws. It also gives a space. Also, they don't allow your valgus or a late valgus, there is a comminuted fragments. There is less chance. I'm not saying the 100%, nothing is 100% in medicine, but less chance of going into a deformity once patient starts walking. Because unless you allow tibia to walk, that will not heal. That's very important. The polar screw must be used and to prevent any malreduction or a malposition can be avoided by using this polar screw. So take home message is you have to have a 3D CT to rule out any intra-articular extension. Plan the nailing. That's very important. Yes, everybody has a nail inside, but you need to plan it where you will be, screw will be, obliquity of the screw, and whether the screw will, your locking bolt will come in your fracture site or not. All these are things. Then how will you reduce it? That's very important. And placement of the polar screw, you must learn the technique of polar screw. It is not difficult at all. Thank you very much for your kind attention.
Thank you, sir. There is a short announcement. A car is parked in the parking area, number MH23009. The owner of the car is requested to please move this car in the parking lot. Governor's visit is there. So because of protocol purpose, we need to move this car. I repeat the number MH23009.
Sunil sir, my question is पूछ रहा हूँ. Sunil sir, you have done both the thing, plating as well as nailing. For distal tibia, extreme distal tibial nailing and plating. What is more these surgeons and patients friendly? Nail. But how difficult it is to execute, because if you do it in a 90-90 position or in any figure of 8 position or figure of 4 position. So it is how to judge that in some extreme distal tibial fracture, the rotational malalignment, one, we have to look for. And second is, if the nail is of not a proper size, at least we must pass 3 screws, including polar, excluding polar screw in a distal. And if you use a polar screw, that may be. So 3 screws are possible. Suppose if you are not able to pass 3 screws, then what about the stability of the fixation?
You have to put an additional plate. What I do is, I plan it properly, because the distal tibia you require, sometimes you have to cut the nail also. So we have hexa to cut it and then convert that. We have to check it on the computer. We have to make the exact length. And distal fragment, if it is more than 3.5 centimeters, then the distal tibial nail, all Indian nails have got almost 4 centimeters from the tip. So between 2 to 4 centimeters to 3.5 centimeters, you can very well nail it. So if this is slight more distal, then you have to cut into that 2 screws, if at all you are planning to nail it. But I keep the locking plate ready, because that is the area which we have to be very careful. But reduction I use a wooden triangle, because sometimes I have to nail the fibula also. On fracture table, I can't put a nail on the fibula. So I'm using a wooden triangle, so that we can get a resolution, and also it gives on table you can reduction forceps can be used very easily.
The second question, when you do a locking, do you do a proximal locking first or a distal locking first?
Distal locking first, always distal locking, because that is a very important. I also don't use back slaps. Sometimes back slaps can create a fracture there in a distal fragment, which is very small. So if it is, I put that, there is no need to put a black. You can just give a compression and then lock it. And I use a static locking. I don't use any dynamic locking.
Question, whether you want to do a fibular fixation. If at all, if you want to do it, what are the indications of fibular fixation in a extreme distal tibial fracture? And what is your preference, whether nail or plate, and whether you do it for the first fibular fixation and then go for nailing, or vice versa?
If the fibula is 8 centimeters, then I always fix it. Preferably nail. If it is like a near 4 centimeters, I put a MIPO plate. And if not required, I put always preferred a nail for the fibula, because I will allow patient to walk as early as possible for the any tibia. You need to stabilize fibula as well. Fibula is also very important pillar of the stability. And if it is midway, which is very rare, the distal tibia fracture is there, and mid shaft of the fibula, which is very rare. So usually tibia fibula are in the same level. If you see the cases, most of the cases are nailed, or if it is not possible, we can put a plate. If the fibula is also terminated, then better to prevent shortening, you plate first. And I always keep the fibula first, and I reduce the tibia with the clamp, keep it, nail it, fibula, and then fix the tibia later.
Again, last question. Even after, in spite of doing all these things, the valgus deformity is a much more common after nailing than the varus deformity. Our varus is almost negligible. And if you find that there is a plafond of the tibia is in slightly valgus, will you revise it, or will continue?
In valgus, I don't revise much. If it is less than 5-degree valgus, I don't revise it. Because whatever you do, even if you after reduction, if it is going into valgus, is no issue at all. The varus is not acceptable because the talus will not tolerate the varus force.
What is your take, Dr. Gawale sir, on a valgus of the ankle after kneeling? Mike.
More than 5 degrees. Less than 5 degrees.
But by and large, at the ankle, valgus is not an acceptable deformity. Whereas they are not so painful as the valgus. Symptomatically, I'm talking. Don't mix up. Syndesmotic is a different injury. That has nothing to do with the virus. That doesn't alter the long axis. That is a different issue. But what is more symptomatic, varus or valgus? If you ask, valgus is more symptomatic. They are more painful.
So it is better if you see in the end, if there is a valgus deformity, then probably you can go again, remove the interlocking bolts, use a puller screw to correct the deformity and then redo it. So it is possible. So less than 5 degrees is acceptable, literature says, but if you are so accurate in doing all these things, you can revise on table so that the patient may not suffer with the painful ankle arthritis, though it is a subjective. I have not seen with the valgus also the painful arthritis. What is your
Valgus cases are because of shortening of fibula. If the fibula is shortened, then there is more likely to be valgus. In that case, you'll have to pull out the fibula to length, and then the valgus gets corrected. So if there is comminuted fibula, then it is better to put a plate or jam the canal so that the fibula is brought to length, and then nail the fibula.
Sunil sir, my question is that you have so many discussion of where to put a plate and where to put a nail. My simple question is that what is your criteria to put a plate, simple plate in the distal tibia fractures? When to put a double fixation, that is plate plus nail for tibia?
Fibula I always
for fibula, for tibia.
for tibia.
Yeah.
If there is a severe osteoporosis, and in spite of putting a nail, there is maybe sometimes there is a secondary fracture which we are not seeing, or the hole comes at the fracture site. Though in spite of planning, if the hole comes in that planning, then we have to reduce your stress. So I just put a plate. The more the comminution on the medial side, I use a nail and a plate. Small.
Can a medial locking plate is suffix for that fractures?
No, locking plate is a big thing. We have to put a big incision and pass it
The
up
MIPO,
high.
by MIPO.
Yeah, of course.
So it is not
Skin-
suffix. Instead of
It can
doing
be-
both.
It can be. I'm not saying that plating is not to be done. My topic is that the nailing in distal, and in certain situations, you need to have a augmented once you are not sure about the stability of the distal tibia because of the osteoporosis, because of the lack of crushing, there is a bone crush, and there is also loss of reduction on table. So that time we have to augment that.
So my question to Gadegone sir, he has asked two questions there. When to do a proximal locking first and distal locking first. Gadegone sir, what is the advantage of doing a proximal locking first? You asked the question. No?
Then if you are doing it in a 90 degree, so what happen if you do a extension for a distal locking, there is a jig is pressing against the patella, and it's very difficult. So we have to make it a 90 degree. And therefore, suppose if there is a stable fixation and good reduction, if you do a proximal locking, remove the jig, and do a distal locking on a plane surface. So
Is
that
it-
is one of the
Is
examples.
there chances of the nail going eccentric either medially or laterally by doing a distal locking in the second
No,
part?
that can be managed with the polar screw or polar pin manipulation. That is not the issue. But if you do it, but I nowadays do a supra-patellar nailing approach for a distal tibial fracture.
Thank you, sir.
Okay, thank you very much, sir.
Is
So,
there
and the question of yours, Ligat sir, when you use a small plate, if obliquity of the fracture and apex of the that particular superior part is on more on medial side, and it is not exactly touching to the distal cortex, that is an unstable construct, and in that case, apex stabilization small plate is required in a more and more oblique fracture.
You learn in the past, sir. So tibia is the bone which require weight bearing micromotion to get a union.
So that is
It is a basic principle in any tibial fractures. If there's a weight bearing micromotion at the fracture size which is needed. If you're fixing the distal tibia with the plate and the nail, is the micromotion possible at the distal?
No, a micromotion will not be possible. It will be absolutely stability. Because we want a stable fixation.
But tibia, the book says and the literature says the weight bearing is a stimulus for the union. Micromotion is a stimulus for the union.
How can you, an oblique fracture will give you stability after weight bearing? Transverse fracture in a dynamic mode will give you stability after walking. Suppose if you bear on an oblique fracture and where the apex is little medial side, it will never give, and it will be added instability and probably it will go for non. आया इथंच आहे आता त्या टेबलवर आहे मिस करू द्या ठीक आहे fracture is the mid-clavicular fracture. We must study the deforming forces because why they are important. It is for the reduction purpose. Sternocleidomastoid muscle pulls the medial fragment upward. Weight of the limb pulls the distal fragment downward. Trapezius and pectoralis major helps for overriding of the fracture. So this is a very typical deformity in the clavicle fracture. What are the structure at risk? It is the most important thing, neurovascular bundle. So any type of a treatment, if you do, whether you do a plating or nailing or a conservative treatment, you must respect and you must know the anatomy of the neurovascular bundle. And there is only 10 mm a safe zone below the clavicle between the neurovascular bundle and clavicle. So keep it in mind that is only 10 mm to 12 mm. So mid clavicle fracture, when to do a indication, all indications except in a compound fracture with a neurovascular bundle is an absolute indication for fixation. Rest, then whatever it may be, they are relative indications for fracture clavicle fixation. So if you ask me, if this is the fracture is given to you, whether it is to be fixed or not, it depends on the contract between the surgeon and patient. That's all. So it's a greater than 2 centimeter displacement, 2 centimeter shortening, comminution and skin compromise. Bone overlaps like a horrible picture, but you will see in our practice, this type of patients are also mostly asymptomatic after 3 months. Skin under geopardy, when there is a popping of a medial fragment underneath the skin, or maybe a small ulcer formation or a small punctured wound like kirit-somaya on the cheek. So in a comminuted fracture, so these are all indications, and you can convince the patient to increase your revenue that these are the indications for your fracture clavicle fixation. fixation indicated. So what to use, whether you to use a minimal invasive treatment or anatomical flea contour plates. Both methods give excellent result. It depends on how you prefer and do it. In conclusion with the meta-analysis, the present evidence from the meta-analysis, intramedullary nail was a more advantage method for the treatment of mid-shaft clavicle fracture. And this is a recently published paper in 2015. And now I published this paper, a new concept in the treatment of clavicle fracture with a screw intramedullary nail. And this is published in Indian Journal of Orthopedic. Accommodate three-dimensional anatomy of the clavicle, typically inserted from medial side. Based in fracture without comminution, small incision at the fracture site may be needed. This is the screw intramedullary nail. Probably now everybody is aware of it. It comes under the various length sizes, but for a clavicle fracture, 2.5 mm is the best size for the intramedullary nail. So how I do it? Place the patient with a large bump underneath the scapula, allowing injured shoulder girdle to fall posteriorly because it nullifies the forces of the muscles. Therefore, displaced fragment, they come nearer with this position, and also you see the prominence of the clavicle. A small skin incision, 1 to 2 centimeter in length, is made just lateral to the sternoclavicle joint anteriorly. Now, why only 1 to 2 centimeter? It's because the medial 1 centimeter is the only part which contains a soft bone. Rest of the clavicle bone is a cortical bone. And therefore, if we want to do beyond that 1 or 1.5 centimeter, probably will not be able to do a entry point of the nail. And therefore, this is most important, is the identification of the sternoclavicular joint. Window near the sternoclavicle joint, as I said, it is a soft bone. Owl is past the entry point is enlarged. And before you do this thing, with the K-wire, you must ascertain that you are near the sternoclavicular joint. Because if you go higher up, you will injure the neurovascular bundle. If you go lower up, you will injure the lungs, because lung, there is a first and second ribs are there. Therefore, it is a very crucial step. Reaming of the canal is most important medially. Unless you ream the canal and make it enlarge, you will not be able to pass the nail, because it is a curved S-shaped bone, and we are passing a molded low clavicle nail. Probably it may not match with the curvature of the clavicle. Upward to help reduce the lateral fragment to medial fragment by manually or by this is a towel clip manipulation. So just you put 2 towel clips percutaneously near the bone, and then to see in the C-arm AP as well as in 30-degree capillate on caudal view. That is most important, because in AP view it looks very good, but if you see caudal view, there is a translation of the fragment, and therefore your reduction must be perfect in AP as well as 30 to 35 degree of negotiation of the nail through fracture side. It's a very crucial stage. Monitor every step, because underneath there is a neurovascular bundle and lung. Link to the. So you have to see whether it is, and it is the through and pro movement of your This bone holder or a screw holder you can touch. As soon as you touch to the clavicle, you will find there are some resistance. Just manipulate here and there, lots of resistance into the canal or in. If you are not able to reduce and negotiate the nearest small incision of near about 1 centimeter, I reduce it and pass the nail. म्हणजे नाकाला जीभ लावायची नाही की मला करायचं आहे. You slightly give a incision and open it, does not matter very much. And this is the, you can see here how these are the stages of the nailing. Mostly it is a closed nailing, 3-point fixation. Even you can do in a comminuted fracture. It's because that the screw fits into the metaphysis and the tip into the flat bone. And this is how it is. And if you are not able to such a displaced fragment, it is impossible to reduce. In that case, it is better to do, and it's a mostly closed cosmetic surgery, secondary intention, minimal invasive surgery. So take home message: consistent achievement of union and low frequency of complication with screw intramedullary nail. Nail migration is prevented. It is a cost-effective, minimal invasive surgery. And why not plate? It is because it produces a very large scar, big scar. It is an ugly scar. A beautiful lady will not be able to wear the upper garment because of your scar and keloid formation. And most dreaded complication of plating, which is not described, it is a supraclavicular dystocia. It's because it gives a very typical, very bad sensation after formation of the neuroma, and therefore it is always how to do it. This is 3-minute video. You can go through it like this. This is the position and surface marking. You can see here. These are all instruments. Very few instruments are required. Small forearm reamers are required, and they are very easily available with Manman and anybody. This is the X-ray. We must assess the size of the canal. And if you are not able to negotiate in a narrow canal, don't do this surgery. Go for plating. It is a hole is created. You can see on the medial soft tissue, and then the hole is dilated with the curved owl. And you can see here the curved. Just at this stage, you forget about the reduction. Your aim is to create a hole inside the canal, medullary canal of the medial clavicle, and then you start doing a 2.5 and 3 Reaming. And this is the most crucial stage where there is a maximum curvature is there, and therefore reaming is most important. And then you can use this travel clip, align, and then you can see this alignment here, and then pass the your reamer, and then you can pass the nail. This is the only crucial step, and just give a bend to the nail so that you can negotiate it properly. Then this is the negotiation of the nail, and once it is confirmed in an oblique and capillary pictures, on doing a screwing of the nail, and it should go into the impact into the flat surface of the nail, and this is how it is. You can do it. This is the final sitting, and last sitting you can see here with the screw. Now it is going inside, and just do the screwing of the nail inside till it goes into the flat bone, and here it is in the medial part. It's a small incision. If it is open part, you need it, and this is how this structure is open. Negotiation of the nail. You can use a clamp of the forearm reduction. If it is reduced, pass a nail, and then same procedure is given in small incision. You can see here how it goes inside by screwing. This is one of the example of a displaced fracture and fixation by clavicle nerve, minimal surgery, small incision. Okay, thank you very much for your attention. And anybody wants to ask this question, you can. Clavicle brace does not reduce the fracture, nor keep it reduced. Therefore, forget about this clavicle brace. Whatever the displacement it is there, after this spasm of the muscle goes down, then and then some improvement of the displacement occur. Clavicle brace never reduces a fracture and never brings the bone together. Yes, sir.
My question is related with the implant removal. We found that at times while removing this implant, student, the screw from the nail, I mean, next to impossible to do that nail.
नवीन नेल निघालेला इट इज अ सिंगल नेल देयर इज नो कॅप लाईक दिस पहिले वेल्डिंग घ्यायचं हा हा आणि आता ते कसं आहे 2-3 सिरेशन बाहेर ठेवायचं सो दॅट वी कॅन आयडेंटिफाय इट क्लिअरली सपोज इन केस युअर स्क्रू इज नॉट पॉसिबल देन यू कॅन dig it and remove it by boning.
Sir, have you come across any complication like pneumothorax or hemothorax?
माझ्याकडे तर झालं नाही परंतु इट इज डिस्क्राइब्ड इन द लिटरेचर and anybody can get it, no problem. There is nothing special about it. It depends on the surgical technique. अब साला तुम लोग वहां घुसाएंगे लंग में तो क्या कर जाओगे? क्या सर बोलो बोलो.
We operated, my assistant professor operated, and he punctured the lung, and there was a lot of and patient was about to die. We have saved him. He took 3 months, he was admitted, and there is a dreaded complaint. One should be aware of this. Just seeing everything is done. Patient dies, he screw you.
राजेंद्र शिवाड़े सर ये गलती किसकी है डॉक्टर की है पेशेंट हाँ हाँ
Facts, this is very dangerous. I stop my unit. Don't do this procedure. It's abandoned.
Very good, very good.
I strongly supporting don't take surgery on clavicle lightly. In a Canadian registry, in about 4 years time, they had 16 cases of pneumothorax, and most of them had problems. So be very, very careful. I have overall my rate has gone down tremendously.
मुंबई वाले करत नाही
खबर काय है उनको डर लगता है
हाँ चार्जेस स्कारलेस हुआ तो ज्यादा लेने का और तो इंसिजन बैठा तो कम लेने का चलो और दिस इज ए वेरी कंट्रोवर्शियल सब्जेक्ट राजेंद्र सर दिस इज ए कंट्रोवर्शियल सब्जेक्ट and it is I said earlier you try बरोबर ठीक पण ज्यांना ज्याला करता येईल त्यांनी करावं Chalo, okay. So this is the end, but it's a very good procedure. You just try it and learn it. Thank you very much.
Thank you, sir. Now we quickly move on to the next section. That is osteoarticular infection. I now invite Dr. Akshay Marwar to take over.
As we are lagging behind the schedule, we will quickly move on to the next session, which is a very interesting session of osteoarticular infection, which is a nightmare for any orthopedic surgeon. So, our first talk is by Dr. Ayesha. I will just shortly introduce her. She is consultant, Dr. Ayesha Sunawala. She is a consultant division of infectious diseases and at PD Hinduja Hospital, Mumbai. She is visiting infectious disease specialist at Bridge Candy Hospital. She is head Fellowship of Infectious Diseases by National Board of Examinations. She is textbook co-author of Casebook of HIV Medicine. She is co-author for National Treatment Guidelines for Antimicrobials used by ICMR and a member of the Scientific Steering Committee for Indian COVID-19 Guidelines Group. Dr. Aisha, please welcome. I will Sarang sir, can you please welcome Dr. Aisha? Dr. Agashi will first have some introduction lecture. I will request the speakers of this session to be particular with the time, please. We are lagging behind the schedule. 10 minutes allotted to each speaker.
Modification in the schedule. Dr. Aisha, myself, and Dr. Aditya will take a combined session of 30 minutes. We promise that we'll finish in 30 minutes, but it would be a combined session. So to start off, okay, so this is a session, we are starting a session on osteoarticular infections. And to start off, I intend to make 5 bold statements. I call them commandments, but then some of you might feel that they're bold statements. First and foremost, there are several publications on open fracture, compound, infected non-unions, etc. Stating that intramedullary nailing versus this type of implant useful for infected non-union, external fixator as a definitive treatment for open tibial fractures, Elizaro for infected non-union. Now, all these tell the truth, but only half truth. They don't tell you the complete truth, because the truth is the treatment of infected cases or prevention of infection is debridement first, followed by fixation. People just keep on talking about hardware, beware of software. That is one.
Number two, a very new definition or new phrase coined by British Orthopaedic Association and British Association of Plastic and Reconstructive Surgeons. In the book published 2 years ago on open fractures is don't consider wound debridement. They say there's nothing like wound debridement because whatever you want to do is excise the wound after extending the wound. So wound debridement does not truly specify what you want to do. What you want to do is excise the wound, extend the wound so that you are able to take out all the contaminated tissue or infected tissue. Three is, as I have discussed in the morning, the aim of treatment of a contaminated fracture, like an open fracture or an infected fracture, is convert that into a closed, uninfected cavity as early as possible. Have a good cover and have a very, very clean cavity. That is your aim. So your debridement or your wound excision has to be followed by appropriate cover. It may be closure, it may be secondary closure, it may be negative pressure to help you in healing anything, or plastic surgery management. Therefore, it is best to partner with plastic surgeons. Therefore, remember, don't judge the limb by X-rays. It is said that don't judge the book by its cover. So don't judge the limb by X-rays. On several WhatsApp groups, you would say that you will see X-rays and just a mention that it was a compound fracture or there's a small discharging sinus. No, you judge the limb by its cover. As you can see that the cover is terrible, but the X-rays are good. So don't judge the limb by its cover, by X-rays. Lastly, team up with microbiologists and infectious disease specialists like Dr. Aisha, because earlier microbes were obedient. They would listen to you. Today they defy you. They defy you, they challenge you, because the resistance world over is increasing. Especially in our country, almost 20 to 30% cases have resistant bugs. And in fact, it is considered to be a hotspot for carbapenem resistant infections, which are terrible. Therefore, team up with these people and don't just blindly give antibiotics. So with these five bold statements or commandments, may I request Dr. Aisha to discuss the world of microbes.
Good evening, everyone. As we know, microbes can enter the musculoskeletal system from various sources. Very important source is hematogenous osteomyelitis, like we see in native cases, and you can have microbes entering from the oral cavity, the genitourinary tract, the GI, pulmonary focus, as well as skin and soft tissue infections. And these may be from seemingly minor trauma, causing transient bacteremia, or any instance of lower immunity. The infections that happen due to hematogenous spread are most often due to Staphylococcus aureus, followed by strep and gram-negative organisms. We have gut as well as genitourinary organisms, which can cause bone infections. And these most commonly are our gram-negative organisms, sometimes Enterococcus as well as Candida. What about open fractures? So we know that during an open fracture, The skin organisms, which are sort of permanent colonizing flora of the skin, get easy access into the wound. And in addition, you can also have contamination from foreign bodies and shrapnel that enter the wound. These could be soil organisms, they could be water organisms, depending on where this fracture has happened and the environment. For closed injuries and surgical site infections, it's mostly the colonizing flora of the skin that enters through breaches in the skin, either during the time of surgery or after. And these are most commonly strep, staphylococcus, coagulase negative staph species. These are the only things that we should really think of there. Environmental or soil organisms, to go a little deeper into, most importantly, anaerobes, gram-negative bacilli, sometimes non-tubercular mycobacteria, nocardia, and filamentous fungi also. And then you have water-related organisms. Again, important organisms like Pseudomonas, Aeromonas, NTM, other things. To give a quick sort of recap on surgical site infections with the concept of biofilm, I'm going to take you through this pictorial. So we know that within seconds of surgery, the surgical field is flooded with bacteria which are in planktonic form or floating or moving as single cells. Most of these bacteria are eliminated by the body's defense system as well as with antibiotics. Body forms a film over the implant, resisting the bacterial infection. However, some of the bacteria adhere to the metal surface and to each other, and they compete with the body's cells to form a film. So it's almost like a race for surface. And under favorable conditions, that is for the bacteria, some of them succeed in attaching to the implant as well as each other, and they recruit more and more planktonic bacteria. In the presence of various favorable conditions like traumatized avascular tissues, host defenses that are impaired, the bacteria secrete extracellular matrix and they get embedded. And this really is the sort of concept of the biofilm formation. We know that within the biofilm, there are various pathways for nutrients, but these cells exist in a state of lowered metabolic rate, decreased nutritional requirements, and hence even the systemic markers of inflammation and inflammatory markers actually reduce in these infections. Bacteria arrange themselves in 3 zones within the biofilm. And we understand that the ones that are in the most superficial zone are the ones that are most metabolically active, require the maximum nutrients. The ones deep below are the ones that are really in the dormant state, the persister state, and are least metabolically active. Biofilm doesn't just form on the surface of the implant. It also forms below the implant, along the holes at the fracture site, and the medullary canal, where white cells cannot penetrate. Antibiotics do not work because of this altered sense of metabolism inside. The patient really feels no pain, the inflammatory markers are normal, and importantly, the cultures may not grow. You can see here that antibiotics are virtually useless for these organisms. However, these organisms, despite their lower sort of sense of metabolism, within the biofilm, they're very effective, very proactive, and they're actually communicating with each other all the time, exchanging tips for survival, for resistance, between each other as well as between members of other bacterial communities over there. And it certainly doesn't behave as a single-celled colony anymore. It behaves as a very complex multicellular being. So these forum sensing bacteria can sense when the environment is right, they can sense growth and decide on dispersion. And that's when they actually disperse out of the biofilm and enter the bloodstream is when they can produce acute symptoms both locally and at distant sites. As I mentioned before, neither the white cells can penetrate, antibiotics don't work, and really signs and symptoms of infection may not be there. And this leads to a phenomena called frustrated phagocytosis. And this frustrated phagocytosis releases certain bacterial toxins, and with the biofilm, this can cause osteolysis. Intermittently, the films burst, as I mentioned earlier, And when they burst into the bloodstream, this is when the signs and symptoms occur. This is when the planktonic bacteria disperse into the bloodstream, causing acute, local, as well as distant infection. Osteolysis may eventually lead to implant failure with the burst biofilm. And in the case of the intramedullary nail, it may even occupy the entire medullary cavity. So if we were to recap biofilms, it's a safe abode for bacteria. It's a challenge for the surgeons, but most importantly, it's a disaster for the patient. Is that the only way that the bacteria can hide and escape from antibiotics? Well, not really. They can also form abscesses, sequestration, intracellular infections, as well as intracanalicular invasion. Unfortunately for us, most of the organisms that are capable of causing bone infections can also form very effective biofilms, and you can see them all listed over here. So my take home from this talk is that biofilms are really the primary mode of existence for the bacteria. They are the ones that contaminate the medical devices, facilitate the emergence of drug resistance, lead to chronic infections. More often than not, they fool us. They're extremely elusive in their clinical presentation, the way that they grow gradually, cause deterioration and negative cultures. Thank you.
Thank you, Dr. Aisha. Next.
So that preamble about biofilms and how infections are impacting us, the most important thing for us as surgeons is how do we diagnose? How do we know whether a patient is infected or not? Is there a criteria? Is there a definition? Is there any guideline? So this is what this talk is going to cover. So let's go through the scenario: 75-year-old female, IT fracture, diabetic, recurrent UTI, being treated for it. Unfortunately, had this fracture had to be nailed, which was done, and surgery was uneventful. And the patient came back on day 15 with this. The standard question. All of us have faced this scenario. Doctor, ये क्या है? Infection है, ये क्या है? And we have to give the answer. Correct? Let's see how we can classify this patient. I mean, there's a traditional classification which has been established many, many years ago. Unfortunately, still unpublished. We've all used this classification. The best part about this classification is the same patient can fall into one of two criteria, one of two types. Type 1 is Madha patient. Type 2 is Dusra patient. So if this is Madha patient, 100% infection I imagine. There is no infection. This is either some vicryl or Bharpur fat, that's fat necrosis. Apply a lot of betadine ointment, neomycin ointment, and take the best combination that is there. Linezolid, cefixime, metronidazole, with Linda, with Metro. Take all of this and you'll be absolutely fine. So this is Madha patient. If this is Dusra patient, and they've come to us for an opinion, then we become orthopedic surgeons. Sina Tan ke we sit over there. So jokes apart, we all face these scenarios. We will keep facing them if we continue operating. It's time we moved on from eminence-based or what I feel or what you feel or what we all feel as a collective body and move towards evidence-based orthopedics. So why do we need to define it? Well, obviously, we need to know guidelines, where to intervene, where not to intervene, and for documentation and research. So there are various bodies across the world, US, Europe, they've tried to establish their own diagnosis. And this study, interestingly, tried to assess this classification, these various classifications over 7,500 wounds. They applied these classifications, realized that there is no one classification that could define. If one classification would say this is not infected, the other would say this is infected. So there was no real consensus. So what they urged was there is a need for a single definitive criteria. We are still waiting for it. And in 2018, this expert group, like we have the periprosthetic joint expert group, this expert group of European surgeons, infectious disease specialists, microbiologists got together, came out with a consensus for fracture-related infections. Now, what they said is, whenever we have a suspicion for fracture based on the history or for infection based on history or examination, there are two confirmatory criteria for on clinical examination. One is a fistula or a sinus or an exposed bone or an exposed implant. If you can see an implant exposed, it is infected. If there is purulent discharge or frank pus, it is infected. There is no confusion over there, and that most of us know. They've also given suggestive clinical criteria like local symptoms of redness, maybe fever, radiological signs like osteolysis, loosening, periosteal reaction, which is very difficult to say. We classically know whether this is infective callus or good callus. We really don't know about it. New joint effusion, increasing trend of ESR-CRP. Now, ESR-CRP will always be raised post-op. But if it's a serial increase, then that's troublesome. Persistent wound discharge or new onset wound discharge. So all these are suggestive criteria. They've delineated these criteria, confirmatory and suggestive. But what they've said is this is not to provide guidelines for management, it's just to stimulate the orthopedic surgeons. But these are the red flags. We must now react and try and find whether there is infection, do something about it. And that doing, what they're saying is we should keep a low threshold for surgical debridement. Even if it is suggestive, we should have a very low threshold to debride that wound the minute we suspect that there is something wrong. Whether we have confirmatory criteria or suggestive, debride, send appropriate cultures, and based on this surgical debridement and cultures, they've given more criteria. Confirmatory being 2 positive bacteria on cultures, like the periprosthetic joint consensus, or on histopathology, if we get smears like fungi can be seen or certain organisms can be seen, then it is a diagnosis. Suggestive, they've said, is 1, but again, in our setup, sending multiple samples becomes difficult. So even if one sample comes positive, consider it to be infection. But by now we've already debrided. That is how we've got the sample. So you add other criteria to it, and maybe this is the diagnosis. What they've stressed on, and we would also like to stress on, is whenever you're suspecting something, debride, target, and give targeted antibiotics. Not just don't wait for confirmatory criteria. Even with suggestive, go ahead, because we've seen what these biofilms can do. Dr. Aisha has already explained that they form a surface, they form their colony, they cause osteolysis, antibiotics don't work, and by the time we wait for X-ray findings or frank pus, it may already be too late and the implant may already fail. So what we need is to do is attack early, excise that biofilm or whatever is formed, necrotic tissue, get that thing out, reduce the load of bacteria, and then whatever bacteria microscopic are left, where the antibiotics, targeted antibiotics can work, and that is how we can salvage the fixation. So that's the idea. Ultimately, the idea is to salvage fixation. Now, with this background that we need to debride, the question is when should we go in? So if it's based on that, there are 3 durations of infection. One is a very early infection within the first 2 weeks. Duration is not more than that. Second is subacute between 2 to 10 weeks. And then the patient comes very late with a long duration of infection. Looking at various papers, various studies on people who got these patients at different stages, the longer the infection, going from 4 weeks to more than 10 weeks, if we debride early and try and retain the implant in the first 4 weeks, the success rate of salvaging that fixation and fracture is almost up to 100%. And that drops down to 50% if we wait for more than 2 months. So if we continue giving empirical antibiotics and then later try and salvage that fixation after 10 weeks, 1 out of 2 or even worse results will be there. We'll end up in an infected non-union with implant failure. The goal is we've got a short window period. Suspect it and act early. Otherwise, we will end up in a disaster more often than not. So that is what we implemented in this patient. This is our own case. We accepted that this could be early infection. Now, how you counsel the patient, say wound wash karna hai, but then do an actual debridement, or tell the patient, have that dialogue, that depends on the local setup. But the idea is to bite the bullet, investigate appropriately. Here we found abnormal signals at the nail entry point and the helical blade. Did a thorough debridement, excised all the necrotic tissue, can be clearly seen over here. Now, cultures from the tissue did not grow, but the urine had E. coli. That was probably the cause of the infection, which is what we treated with 6 weeks of piperacillin tazobactam. And we could salvage this fixation. This is at 6 months. Patient has no recurrence so far. Fracture is united, and we could salvage the implant in a patient with recurrent UTI, diabetic, old age. So we must be, definitions are for theory. Yes, we can use them as guidelines, but they are very difficult to define. We must be alert, proactive, operate before waiting for confirmatory criteria, because a lysis on an X-ray means we've already missed the bus. Debride, send culture-specific antibiotics. So to summarize in a nutshell, we keep hearing about fracture-related infection. The mnemonic is FRI. We must face the facts, look at the signs and symptoms, react like surgeons. When we face our own infection, we become physicians and give antibiotics. Remember, we are orthopedic surgeons. Let's operate, and that is how we can end up with infection remission. Thank you.
Very talk better. Request again, Agashi sir.
नाही राहू दे. माईक करतो नंतर. लॅपटॉप तो लागेल. हे करू बंद. Okay, so now once you have established that there is infection, then the next step is debridement. And I just run through some slides, some videos about how to debride. As we have been saying again and again, there are different ways to skin the cat. There are different ways of debridement. You and me are not going to think same every time, but I will just present how we have been doing it. So is it only removal of pus and implant? Very often people think that removal of pus is debridement. Now friends, remember, pus is a product. It is just dead WBCs, bacteria with tissue debris and serum. It is a product of infection and not a source of infection. In debridement, you have to address the source of infection. So as Dr. Aisha and Dr. Menon have already described, there is a biofilm. You must anticipate where is going to be the biofilm, and you need to address that. Whether it is open fracture, whether it is infected non-union, or it is an osteomyelitis. So I quickly take you through osteomyelitis. We all know that biofilms can occur even in osteomyelitis, so chronic wounds. And there would be a large area of biofilm formation and pus. So if you just make a small window and let out the pus will come out, your markers will go down, but the source of infection will remain. And therefore, you need to make such a window that you are able to take out the entire suspected area of infection, like this. Now, this was a elderly patient, osteomyelitis for several years, discharging sinus for about 8 months. You can see there's a discharging sinus. The CT, X-ray, CT, MRI, clinical examination is very helpful for developing a plan. You need to plan well. So what is your plan? The assessment is like this. You have a, here you can see there is a cloaca. The tract is going inside and there are sequestra. So the planning will be excision of sinus and tract, excise the scar, add local antibiotics, take out all the biofilm, and most important, get good cover. Most important thing would be to mobilize the muscles and get good cover in this case. In femur, more often than not, you are able to mobilize the muscles, skin, and get a good cover. However, in tibia, very often you need a flap. So this would be our planning. The discussion with MRI consultants is extremely helpful. And then we decided that the lesion extends over about 9 centimeters and we need to excise make a window of approximately 9 centimeters with cloaca in the center. So this is the scar. You can see that the incision video. So first step is marking the incision by excising the scars. If there are any sinuses, if there are any drain sites, everything needs to be excised. Very often drain site may not be in the line of incision. So remember, always take out your drain along the line of incision. In case it gets infected, you can excise everything. So excise this. Next video. So don't make a superficial incision. Make a bold incision. Go right into the deep fascia. These angles need to be cut sharply, otherwise they remain inside. And in one go right up to the deep fascia. Then the deep fascia is invariably adherent to the muscles. You need to mobilize the muscles later, as I suggested. The deep fascia also needs to be separated from the muscles, as you can see here. That's the sinus tract now, which is to be separated from everything. Preferable to keep skin also. In this case, the skin got dislodged. We could not keep it, but otherwise it's best to take out the entire skin with sinus tract and go into the bone. So here you can see the sinus tract. That's the tract. And that's the wall of the sinus, which is to be dissected from surrounding areas. And then you come to the first cloaca, which is full of granulation tissue, dirty granulation tissue. Video. Sorry. Video. So that is the time when you take cultures, deep cultures. Avoid taking cultures from sinus. There's a lot of contamination and they do not represent the real culture. So collect cultures from this area, from the cloaca. Then around the cloaca, there are invariably adhesions. So release those adhesions, which will help you in making the window as well as closure. So here you can see the window is planned, marked. And use multiple drizzles to mark the window. With 5 and 10 millimeters, make a window. Scrape well, but don't leave it at that. This window would be a source of fracture or stress riser. So what one has to do is use a burr or a nibbler or any instrument which will make the window elliptical with rounded ends. There should be no stress riser. Avoid making a rectangular window. Rectangular window often leads to a pathological fracture. An elliptical window is not likely to make have a pathological fracture. Way back, almost 25 years ago, Dr. T.K.R. Raza, who was a past president of Indian Orthopaedic Association, unfortunately passed away. He had got a best paper award in Virox for making window. And that is where he had stressed the window has to be elliptical. Since then, I have been following this and extremely useful technique. So use a burr. You need not, we have used miras, but you need not use mira. Just burr anything, any burr which costs 15,000-20,000 rupees can be used for this. So this is generally done after we have scraped the cavity, because otherwise all this bone dust would go in and your cultures would be contaminated. So from here, we have made a smooth window with rounded ends. Cultures to be taken from the cloaca, from scraping of the medullary cavity. Avoid putting additives like normal saline unless the culture is very small or you're going to send it next day. The common test we will be discussing in detail tomorrow. And the sinus tract, do not forget to send material for histopathology. Whatever is cultured is to be biopsied or sent for histopathology. Never forget that. Then, after collection of samples, you can give empirical antibiotic. In this case, we give piperazine tazobactam. And then you can see in femur, it is not very difficult to mobilize the muscles and skin and get a good cover as shown in this. That was the culture. This will be discussed tomorrow. That's the antibiotics that were given by Dr. Aisha. Generally in these long-standing cases, we like to put dissolvable or resorbable antibiotic, but generally not on day one. We wait for the culture sensitivity. That gives us another chance of re-exploring and finding out whether there are any remnants of infection. So, and the bleeding is also much less. Day one, there is generally a lot of bleeding, becomes very difficult to know, especially in femur where you can't use tourniquet to know whether there are any remaining foci of infection. So this is done after 4 days with vancomycin, and this is the chart we ask patients to keep. This is a pain chart, appetite and fever. That gives us an indication whether the patient is settling or not. This is, they are supposed to WhatsApp to our resident, and this is at 2 months. This is at 5 months, very, very comfortable patient. Now, most important is anticipate where infective tissue would be located. Write down in soft tissues where it is likely to be located, in bones where it is likely to be located, and then try and address everything. Preoperative planning is vitally important in these cases. Thank you, friends. So, what happens? What happens after these windows? There's always a query that whether all this, such a big window would lead to pathological fracture. As we have been saying, rounded ends, not likely to have fracture. Clean cavity, clean bony cavity. The nature will try and prevent fracture by adding bone on all the sides. It's exactly for the door, there is a whatever it is called, that frame. The door frame is very thick. So the nature makes a frame so that there is no fracture. And over a period of time, as you can see here, at 3 months, 6 years, and 9 years, the window has practically closed. It also APM. It also, you can see, the first step is a good callus at this level. Here you can see, and in AP you can hardly see the window, and there's a thickened cortex. So don't worry about making an adequate window. Adequate is important, but avoid stress right there. Thank you, friends. We generally don't. You can. Somehow I feel that the thermal necrosis will be more, because that time we would not like to put lot of saline, because if you do that, then the culture is not likely to become positive. So initially we use drill so that there is less heat, and use osteotome and hammer. That's why I said last few months or last few years, we have been generally avoiding to put local antibiotic cement on day one. Various reasons. As you rightly said, multi-drug resistant organisms are becoming very common. It is very difficult to anticipate. So number two is day one, there is invariably a lot of bleeding and you are likely to miss foci of infection. You miss pockets, first pockets on day one. So it is better that you tell all this to the patient that I am going to do it in two phases. First is debridement. We'll wait for the culture and then we will put antibiotics. Having said this, there are two things. Number one is the concentration of these antibiotics is very, very high locally. So it is possible that bacteria which are resistant to IV antibiotics would be susceptible when you put locally. Agreed. Number two, there are situations where cultures are negative. Then, of course, we need to use empirically. Generally, we put colistin and vancomycin. That's general. Yeah. Correct. Generally, we make it a habit to meet the radiologist beforehand for various reasons. One is they actually give you a three-dimensional picture. See, it is very difficult for us to understand this. Number two, post-op we tell them what we have found, whether whatever they have told us has turned out to be right or wrong. So their expertise also has improved and our anticipating problems has also improved. Especially in femur, you need to find out whether the vascular bundle is near your, especially when you are doing on the medial side. So it is better to sit with radiologists, discuss, and then take it further. Yes. Yes. As soon as sample is collected, the anesthetist gives empirical antibiotics. And that is something Dr. Aisha and she's going to discuss tomorrow. I don't understand anything about antibiotics. When I started practicing, we used to use it extensively because very often the sinus would be, the tract would be very difficult to make out on table. Then generally we used to inject it on previous day. It would stain all the tissues, but by about 12 to 14 hours, all the other tissues will not become stained. Only the sinus tract would remain stained, and then it can be, we could trace the lesion. Today with MRI or MRI sinogram, so many times we do MRI sinogram, it is quite easy to anticipate where is the tract. We know exactly where is cloaca, exactly where is tract, and then it is possible to remove. Sorry? Conway. Yeah, one minute. Let me complete that methylene blue. So once it is stained, it stains the granulation tissue also. So that is a drawback. Since it stains the granulation tissue, on table you find it very difficult to remove. So many times you see that the consistency of pus is different, the color of pus is different, the color of granulation tissue is different. All that goes away with methylene blue. And therefore, in the last 10 or 12 years, we have not hardly ever used methylene blue. Correct. It is quite common. Are we going to discuss it in the thing? We are going to discuss that. It's a very common thing, and we have published this in Journal of International Bone and Joint Infection, and it's quite common. And how to differentiate between.
Last one question, please. Yes. Last one question.
Are we going to cover that tomorrow? How often do you send for non-commercial
Delegates can contact Akash sir afterwards for their queries.
Yes, yes. Culture there will be a full talk on culture.
Thanks a lot, Akash sir. Thanks a lot. Thanks a lot, Dr. Aisha. Just interruption in the session. Dr. Karnesh is leaving for a meeting at Delhi. So I will like to request Dr. Gade sir organizing for this MOA Pathshala. Our AOA President, Dr. Lingayat sir, AOA Secretary Dhole sir, immediate past President, Dr. Devre sir, Dr. Shinde sir. We are felicitating our Secretary, MOA Secretary, Dr. Karnesh sir, as he has to rush to Delhi on an IOA meeting. A nice memento presented by Aurangabad Orthopaedic Association to Dr. Karnesh sir.
Well, I immensely thank the association and the team led by my very dear friend, Dr. Gade sir. Okay. And I feel really very, very sorry that I have to leave the meeting because of some commitments, important commitments. But thank you everybody for the excellent hospitality and excellent support. Thank you.
Thank you, sir. Coming back to the session, next lecture is Dr. Chandak sir. Role of negative pressure wound treatment in wound management. So please 10 minutes.
Good evening, friends. After that, those excellent lectures about infection, how to debride, I'll be speaking on role of negative pressure wound therapy in wound management. This is possibly a last decade science. When such a compound fracture comes and initially wound cannot be covered completely after fixation, that is what my main worry. So patient comes, there is a wound, you try to close it by tension sutures and the wound gapes is a problem. You try to cover completely and there is permanent infection, that is a problem. And there are minor skin gaps. So how do we manage that? And when such trauma patient come, which are difficult, challenging, and this patient already had 3 debridements procedure prior, and the wound still is bad, or when wounds are badly infected, negative pressure wound therapy definitely is a useful asset. This is how patient came to the hospital. To take up this example, how the negative pressure wound therapy helps. This was 30 years old male, had initial treatment and another orthopedic facility, and had bad infection, foul smelling, wound wash, lavage, etc. given, thorough dedicated debridement, negative pressure wound pressure therapy after first NPWT. So from the first picture, the immediate scenario changes. The wound effusions or the serous, they are taken away. The bacteria down. The wound looks better from this position, and there is a positive healing response. As soon as you see a wound and it is getting worse, is your major worry. But when you see signs of healing, in better vascularity, better granulation, you feel better. This is after second VAC therapy and after adequate wound debridement. So This was just before the flap. The bone segment was excised. This is everything improved. Cross leg flap, patient did very well. And whenever we do a cross leg flap, in the gap, we would put a cement spacer with adequate width so that we can reconstruct it. This comes to a ring construct and the debridement. This is how induced membrane forms after the induced membrane formation. So this aspirator obtained bone graft. Look at those. They are packed into that cavity, and this is immediately after the procedure. The whole column forms, and this is the process of consolidation at 1 year. And since it takes longer to consolidate, you can protect with a subcutaneous lipoplate. And this is final result. What difference I found after Elizarov fragment and after the long segment graft with RIA is lesser amount of finance because there is no distraction of the synthesis. This is another case. In a Elizarov had a flap transfer but gave way. The whole segment of middle tibia was exposed, and though the X-ray looks innocuous, but the red segment of bone. Again, after debridement of this, the tissues around this thing, which is for a long, long time, are almost like a avascular tissue. The healing potential is poor, the granulation is poor, and that improves with negative pressure wound therapy. 1 or 2 sittings, and then a cross leg flap, antibiotic space. Importance of VAC in bad contaminated, mud abraded, grease applied wounds. So this was difficult to manage, very difficult initially. This is almost radiological complete pivot foot, but distal circulation was good. So the goals are you use IV antibiotics, stabilize, X-rays, debride, and then this was debrided thoroughly, lavage, etc. given, and then once the initial debridement is done, then something like a hydro debridement. So what does hydro debridement do in this situation is, it takes away the fine layer of mud which is closely impregnated on the tissue. So that comes out, and then this is how it works. So there is a jet stream of water with vacuum. So it debrides and it takes away that impregnated layer of mud. Even this can run on a vessel and nerve. You are not crushing the tissues, it is just application like a paintbrush, and it debrides. Also look at the abrasions. So it may be a combination of cases. Look at this skin abrasion, which is actually very difficult to manage. So you can debride the wound skin abrasion. So the thin layer impregnated mud comes out. So you can debride that. You don't use it on a bone because otherwise the things become bad, the device becomes bad. So it can take away the most superficial layer. And at the end of 1 or 2 debridements, the patient is good enough to go for further procedures. So this is at the end wash, lavage done, fixed, and he also had incidentally the compartment, so that was done. And once you debride such a wound, a lot of exudate is going to come. And that, if you take care of hemostasis, I would put it into a food frame. We call it fondly a samosa dressing. So anterior film, posterior film, seal, and then low pressure, 125 initially on day 1, and medium pressure on that, and then a microvascular flap was given, and that patient heel rested nicely on a foam so that there are no pressure source on the heel because that area is the nerve, and then foot shortening done for such a patient. And that 3 to 6 months down the line, he was quite fine. Another value of vacuum assisted closure. So if you take out a plate which is infected, so this was a patient, we took out the whole plate, etc., debrided completely, and then here the foam is applied as a vacuum assisted closure mode. So negative pressure wound therapy you can use for generating granulation wide open, or you can use for vacuum assisted closure. And for compound fractures where wound closure is a bit tricky, I like to use two mouthstretch sort of foam on both the angles of the corner wound. The wound is closed subcutaneously with Vicryl, and then low pressure negative pressure wound therapy. So this is how it goes. Compound fracture day one, debrided, fixed internally, then vac applied, foam applied, and on both sides of skin a thin film pasted so that skin shortening does not happen, and then vacuum assisted closure on that. This is how it completes. So once you apply foam, make a small nick, put a suction on that so that every blood etc. which is going to come out immediately comes out, and then check the seal, and this is how the procedure is completed. Connect the tubing and then negative pressure wound therapy. This is interesting. So at 125, the maximum compression of the foam is going to happen. So beyond that, pressure use is possibly not much helpful unless the wound surface area is very large. Coming to the next use of VAC, this was a side shift injury. What not to do, we would learn from this case. Case received from out of station from Nagpur, was managed by a primary replacement, and then that had a bad wound, as you would expect in such a case. That was a side strap injury, so that was debrided. So look at this wide wound, and here also stability provided by intramedullary L nail in a fashion and negative pressure wound therapy. So that healed completely without a necessity of flap. So VAC used as vacuum assisted closure, it brings tissues together, and at times you can avoid a flap. This is another compound fracture. Look at this bad dirty tissue. So all live tissue obtained, complete hemostasis, low pressure VAC, and then occlusive dressing check, apply sucking pad, and then the skin graft takes up well. Even on a skin graft, we would apply VAC so that it sticks very well, and then the patient is mobilized faster. This was another patient, had a plating procedure outside. This is how he presented around 2 to 3 months afterwards, and continued on the dressings and antibiotics. Again, debrided completely. Look at the whole compartment, anterior compartment muscles debrided, wash, lavage given. Then on the medial side, we applied a ECPO, that is extracutaneous plate application, so that patient is stabilized well, removed all plates. This is vacuum assisted closure mode. We could keep a thin foam, try to close it so that in the next vacuum dressing, you can close the wound, or you can get a flap, whatever is convenient for that patient. This was managed with XT. Good infection control, and the wound healed completely. So healing response, infection well under control, and patient healed well. This is bad infection. After initial management, this is, you can see the pus, bowl full pus coming out. He had this fixation tear, the enders nail were backing out, bowl pus. So that was it debrided. This is all complete necrotic wound. Again, vacuum assisted closure. And so inside there is a large foam, outside there is a thin strip of foam, and then try to get it closed so that a good drainage is obtained. This is another way of lacing in the back. This is how the wounds can be managed with back. This is another with a tubing and the dead bone excised in that case, only 2 slides. After removal of the first negative pressure wound dressing, this is how the whole debridement, the vascular membrane now form, and then we can do the further reconstruction. So this is final wound healing. In that bad case, bowels full of pus, good debridement, and look at the skin edges, the healing is really very good. Back is definitely a good asset. If there are 2 wounds, we can combine them by a bridge of foam onto the skin, and the skin is pasted with a film so that there is no shortening. These are very useful applications of VAC, and VAC definitely helps in such a. So he had a split thickness graft, and that amount of secretions he had. So put a VAC, large grafted area is another good indication for VAC. So VAC is definitely very useful. You staple the foam inside the edges of wound so that it heals well, and all these wounds, VAC with a bed, so would be with an intermittent VAC, so that some amount of antibiotic leaching is useful, and then it drains, and early cover with negative pressure wound therapy. Also in compartment syndrome is also another use of track which is very useful. It removes the whole messy situation, makes it comfortable for patient and for us to manage. Compound fracture is again common use where we can use if there is no much of hemorrhage. This is how we can use for compound fractures. Connecting sensor track 2-point combination can be done. Back splints is really useful bone for use in various situations. Infection control, soft tissue management, wound closures. So you can use for various things with all the precautions you need to use for back. Thank you very much.
Very excellent presentation. Before the workshop starts, one question for Chandak sir. Yeah. Sir, one lecture is there. Yeah. So no, one last question. One last.
So first day after any debridement, there is a chance of hemorrhage, and one or two patients had hemorrhage in the ward where the canister rapidly fills. You have to be watchful for that. Sisters are informed that any fall in blood pressure, hemorrhage, pulse, ghabrat, you take care of it. The first day pressure I keep at 25 with the strength of the vacuum pressure machine at minimum, medium and large vacuum pressure. So on the KCI machine, those calibrations are there. Next day, you increase to 50, 75. Suddenly, if you increase, then again some bleeding points may open up and then increase the pressure to around 125, which is most optimum for a large wound and for infected wound. Ideal recommended is 72 hours ideal. In India, we convert ideal into what is convenient to us, what is convenient to pocket of patient. Because to a patient of infected scenario, he's already drained of all his resources. They try getting more. It is really a challenge to manage their finances. But back is ultimately useful to them because from that infected scenario, daily dressing and messy situation, they now come to a situation where there is no wound, no smell. They're standing next day with all the reconstruction you do, and that is a game changer in their mind. Now they have started thinking that yes, we can be cured of infection, and that psychological boost is a tremendous advantage. Managing their finances is a big thing. Ideal 3 days, never more than 8 days, but we have used for 5 to 7 days in variable situations.
Thanks a lot, Chandak sir. Very nice presentation. One last lecture by Sangeet sir. Very important topic. When and when should not we should nail in a compound fracture? Dr. Sangeet sir. After that Sangeet sir lecture, we are going directly for the demonstration of PFN A2 by Yogeshwar Implants. Uday sir.
So my talk is on internal fixation in open fractures, when and when not. In open tibial fractures, we have two major complications, infection and non-union. The infection rate reported in the literature range between 5 to 50% and the non-union between 7 to 60%. Intramedullary nails, primary rimmed intramedullary nail appears to be a reasonable option for management of Gustilo-Anderson type 1 and type 2 open fractures, whether it is in humerus, femur or tibia. So overall, there is a consensus about nailing them in femur and tibia. The problem is when you have 3A, B or C. The question is that, so all uniformly, type 1, 2 have a uniform result if you use appropriately in an indicated case nailing. Regarding the plate fixation, when you use it in such situation, The complication, osteomyelitis is about 19%, implant failure 12%, and they are greater than the intramedullary nails. And often you have to use in a MIPO technique fashion. Now, I'm going to discuss 3 cases. सगळ्या माझ्याच, दुसऱ्यांच्या नाही. Okay. So one had a problem related to the biology, second had a mechanical problem, and third is inadequate debridement. So this is a 34-year-old individual. He had a road traffic accident in 2009. It was a 3A open wound. That was his wound. I primarily nailed him with good fixation, stable fixation on day 1. This is the wound as it appears after adequate debridement on the table. But everything was going right. But on 7th day, he developed fever, pain, fever, and redness. This is how the wound looks like. And subsequently, it changed in 2 weeks' time to this situation, where you can see a scar, pus was coming out. The wound, entry site wound is also not healthy. And subsequently, we considered debriding and VAC. This was at 4 weeks, where you can see the necrosed comminuted bone all coming out, and we had to take out on the table everything which was loose. The nail was exposed. There was a pus discharge. Even that dead piece of bone was excised. Now, was that a mistake on day 1 on my part, or is it I have not estimated the soft tissues which were damaged at that time, or I should have used a different implant or have changed the course, or I should have been more aggressive in debridement. All in the bargain was to preserve those comminuted fragments. At 8 weeks, this was the situation. After excising everything, repeated debridement, the wound was, after a VAC, it was looking healthy, but he had 14 centimeter of bone loss at the end. I consulted a plastic surgeon. The plan was to remove the implant, clean the wound, X-fix, and a flap. So that is what was done, a pre-flap with the X-fix. At 3 months, the flap had completely accepted, no infection, ESR, CRP was normal, but how do we manage this 14 centimeter bone defect? So I decided to use a segment transport over the nail. I made a custom made nail with a provision of 3 holes to dock the segment. And this is how, over a fixator, I first locked the nail, use a fixator 3-ring concept, where the central ring was used to transport that segment here. That is a corticotomy, that is a transporting segment. And the plan was, once the transport is completed, we remove the fixator and lock at the provisional holes which were made on the nail. So everything was going all right. At 4.5 months, when the transport was complete and the docking was adequate, I decided to remove the fixator, but that segment migrated by about 0.5 centimeter. I locked that segment, removed the fixator, and then allowed that to consolidate. So that is how the consolidation started, and it completed in 9 months' time. But at the docking side, there was a non-union, a small discharge in sinus, probably from the screw. So I took out this screw and grafted that area with a cancellous bone. And at 1 year, this is how it looked like. So at 4 years, this is how it looked like. And this is what is function. He's back to the same work. This is his flap and the leg. Equal limb lengths are equal. This is where we started and this is where we ended. That is after the implant removal. So all this took 4 years of his life. I am responsible for that. And he's back to his work after 4 years. He's doing everything. So what do we learn from this case? Is it my decision was wrong? Is it I did not address the biology, or I was over aggressive in nailing this situation. I could have managed by a fixator. So whenever you're deciding in principle, open tibial shaft fractures, there are multiple factors which you must consider when you are making a choice of fixation. Whether that has adequate soft tissue coverage, how much is the gross contamination, is the mechanism of injury endosteal or periosteal, how is the circulation, what are the hemodynamics status at the local site, and overall risk, his general condition, and the trauma scores. These are the points which one should consider whenever you're deciding whether to do a plating or a nailing or a fixator. Now, I hope this will be not covered in the lectures. Can I go ahead? The time of debridement. Open tibial shaft fracture should be debrided within 24 hours after the injury. Initially, it was a time limit which was trusted on us. We should debride it within 6 hours, But there is limited evidence to support the 6 hours rule. After 24 hours, the infection rate doubles. So hence, the general recommendation and the consensus is you should debride within 24 hours. 1 to 4 days, if you debride, the risk of infection remains relatively constant. Whether that means if you're debriding on day 1 or if you're debriding on day 4, the relative risk is almost same. Time of debridement, irrigation and excisional debridement, which Dr. Agashe also pointed, is a crucial part of treatment. At least one debridement must be performed. However, the timing of the first debridement is still a subject of debate, but it has to be within 6 to 8 hours or within 24 hours if everybody has a different circumstances, different situation. So whenever possible, it has to be within 24 hours if you want to achieve that result. What is the role of antibiotics? Wilkins and others, there is a considerable reduction in the infection rate when the antibiotics were administered less than 3 hours after the injury compared to given more than 3 hours from the time of injury. And that infection rate varies from 4.7% to it becomes almost double. So whenever you get the patient, first thing is you give him appropriate antibiotics. Second case I am coming to, this is 60 years old, motor vehicular accident, a 3B compound fracture. That is his wound. He came within 3 hours, open wound with a connecting skin tag anteromedially between the two wounds. That was his wound, how it looking like. And after debridement, that is how it looks like. And used a fixator after cleaning the wound, applied a whack. At 48 hours, when we checked with the help of plastic surgeon, he said you can go ahead with the definitive fixation. You remove the fixator and go ahead with the plating, and that is what was executed here. The plastic surgeon who was with us, he covered the bone with a rotation flap from the available muscles, and then a split thickness graft, which was looking like this post-op X-ray. That is his skin, how it looks like at 5 months. He started weight bearing. I hope everything is well inside, but he developed a varus deformity, and on X-ray, the plate had bent. So this was a stage at 6 months. He had a good knee range, good ankle movement, no pain. The only thing is this was not, the construct was weaker. So I improved the construct by adding more number of screws in the segment, reduced the working length, and grafted it. At 3 months, this is was follow-up. He was doing well. I don't know how dusraचा झाला का. I have lost his follow-up because of COVID. So here, probably the soft tissue was all right, unlike the first case. The mechanical problem, which was addressed like this. I quickly move to the third case. This was a segment of tibia. That was his wound. Probably some can grade it as 3As. I can grade it as 2. And I nailed him. There is a varus here, probably instability on the medial side, and at one fourth or fifth day, this is what was his wound. Probably my mistake. I didn't debride it adequately. But whenever you have a bargain of doing a good fixation and debridement, probably you tend to err more on the debridement rather than the fixation. So after a good debridement, this was covered. This is what his wound looks like, but his distal fracture was healing, the proximal fracture was not healing. The screw has loosened, the gap has increased. So I did. Delay if doubtful adequacy of initial debridement. It's difficult when you receive a patient who has polytrauma. We have to do a debridement in a hurry, or in a situation where we are not used to do regular debridement. It is difficult to evaluate muscle viability. In those situations, you repeat the debridement after about 24 to 48 hours. Closure methods can be either direct suturing if you have a clean cut wound and if you don't have a soft tissue tension. Split thickness graft, pre-flap, local muscle flap can be used along with the plastic surgeon to cover it. Location of the defect, size, and the associated injury also decide whether you want to do a primary closure or later. Conclusion, in open femoral fractures, whether it is type 1, type 2, type 3, the consensus is open femoral diaphyseal fracture, early intramedullary nail with reaming is recommended. Operating within 24 hours or later, it does not make a difference because femur is enveloped by good muscles. The blood vascularity is good, and usually the type of injury, unlike tibia, is not that bad. Several authors, even Bhandari in his meta-analysis, no difference as regards infection or non-ileal when you use unrimmed or rim nailing in 1, 2, and 3A fractures of tibia. Definitive treatment is either with a locked intramedullary nail or a plate, and it is at the discretion of the treating surgeon. And all these cases were Maje patients, not Dusraje patients, and they were lucky. I was lucky that they remained with me. They didn't go to other surgeons. So this is about how you should handle the primary wounds or the compound fractures which you would receive.
We can take one question for Sangeet sir. I think he has made pretty clear all the ideas. There may not no questions, but still one question. We directly, yeah, one question. This question is if the patient comes late, presentation, 3 days.
So, as I said, there are several factors. The local contamination, what type of injury, what type of fracture it is, whether it is transverse fracture, and you get a judgment by the soft tissue injury. What is the local condition? Now, if the surrounding tissue is precarious, there's no point in doing an intramedullary nail in those situations. You can do a X-fix, debride it, and obtain a primary culture, obtain a closure after treating with appropriate antibiotics, and then at second stage, go ahead with a definitive fixation. That would be a safer option.
Thank you, sir. So I conclude this session by thanking speakers of this session of osteoarticular infection, Dr. Aditya, Dr. Aisha, Dr. Agashi sir, Dr. Chandak sir, Sangeet sir. We'll directly go to the one workshop. So I will hand over the session to coordinator Dr. Sachin Patil. He will announce.
surface marking, patella, tibial tendon, and there are two incisions are given. Sometimes you can use from the transtendinous. That can be used. I use it near transtendinous approach, and this is how a small incision is given. Then dilate the wound with the artery forceps with the two small retractors. You just pass a guide wire, take it into the apian lateral picture, and then after a perfect analysis, you can introduce a piece inside near about 4 to 5 centimeter, and then you can also drill it also. This is the proximal reaming of this canal, and then extend the guide wire. Extend the guide wire with the regular guide wire after reduction. You can have a clamping. You can see here how I have put that the distal fragment into a proper position. You can use a clamp also. Yes, proximal reaming. Yes, distal. So distal fragment is reamed over it. Then you exchange the guide wire, and you can have a shaft reaming also with a regular flexible reamer or a static reamer, but mostly flexible reamer. And this is how it is. And see whether the canal is properly reeled. This is reaming is done or not. And then after that, you check the size of the nail, because already the proximal reaming is done with the near about 15 mm diameter. We have to put a 13 mm, 13.5 mm proximal diameter. So after that, this is how I do it, and then pass the nail through this small window, and proximal locking you can see here, and then this insertion of the nail, and don't hammer it otherwise, because when passing this nail, it may get rupture, and there may occur a fracture. Slight blows are needed, and this is the locking here in the distal locking. You can say medial lateral 2 screws, and then you have to use oblique locking. So there is a measurement device is there. Therefore, you can have a correct measurement of the medial lateral screw, and then this is the most important step in the lateral view also, because there should not be any rotational malalignment. That is very important. And then with this, you do a proximal, you can say distal locking. And with this measurement, there are two screws are passed. Generally 60 to 65 length is required, and for oblique screw, it is mostly 45 to 50 length which is required. For the medial lateral, it is near about 50, and lateral medial, it is near about 25. So this is how it has been done, the distal locking, and then you do oblique locking. This is how we have to use a jig for oblique locking. You can put two screws. One is from the lateral side to medial, and from other is from medial side to lateral. The oblique screw insertion. Because this oblique screw, there is not much dangerous to this, because popliteal, this neurovascular bundle is spared, and we are not going posteriorly, we are going obliquely from medial to lateral and from lateral to medial, and therefore there is no much you can have just in a osteoporotic point, it is better to do a oblique screw first, and then you can have a medial lateral, so that the translation of the nail can be prevented while doing. And so it is your choice. There is nothing specific. And this is another screw. This is the final position of the nail, and it's most important that it should be subchondral.
and then you do a distal locking here, proximal locking you can say, at the lesser trochanteric level. आणि ह्या दोरा बांधणं अत्यंत महत्वाचं आहे, अदरवाइज you may lose your screw inside the. So this is very important step. Otherwise, sometimes it's very difficult. And these are the two small incisions we have done a distal locking, or you can say a proximal locking, whatever you see. Proximal and distal करू आपण. So this is how it is. Another and. This is the small incision at the infrapatellar region. Minimal invasive surgery, there are small 3 incisions. You can have a 3 incision, and then you can judge the rotational alignment before you do a proximal locking. This is most important. You can use this is the arm position. This is the X-ray proximal reaming. This is the distal reaming, and then this is the locking of the screws, and distal locking near about at the lesser trochanter, and this is the final position. Thank you very much. So those who are interested, they can see the system also. So thank you very much. Anybody want to ask any question? And I am very thankful to all delegates because they are till end, they are still here. That means probably the team of Vikas Agassi sir has done a good job, I think so. And after this, Dr. Gade is there. After half an hour interval, you will have here a inaugural session followed by the dinner. So we are now, it is 7:30. We see here at 8 o'clock. Okay, we'll start the inauguration, and anybody wants to see it,
We welcome Dean Madam.
मी आता नेतर चालू देतो ना. चांगला आहे.
Thank you, everyone.
Hall. जी.
Good evening, everybody. May I please request all the gentlemen to be the inauguration ceremony. So I request all of those standing over there to kindly take a seat. In a short while, we'll be starting with the inauguration ceremony. It's a request to all of you all to please kindly be seated. Good evening, gentlemen. It gives us, it gives us immense pleasure to once again welcome you all. We had a fantastic day throughout, and we are pleased to see all of the people sitting throughout the day and giving a patient ear to all of the speakers. Indeed, they are also glad to see such a good crowd, and a full house certainly gives more enthusiasm to the speaker and the organizers. Once again, thanking all of you. I thank you with folded hands. You should also have the knowledge that since the finalization of the date and topics, the organizing team at this Pathshala has been putting intense efforts to get these things rolling on. Dr. Dhule, who is a secretary AOA, Dr. Lingayat sir, who is a professor HOD, and also President of Aurangabad Orthopaedic Association, Dr. Sant Pure, our star surgeon and an MOA executive, Dr. Pramod Shinde, who has been guiding us as Vice President of Maharashtra Orthopaedic Association and who is spearheading the MOA Day canvas throughout the state, and myself. We have been taking our share of efforts to add to the Herculean efforts of Dr. Yashwant Gade, who happens to be a past president of AOA, a past vice president of MOA, past secretary of IMA, past secretary of DAS, past president of DAS, and also a present executive of AOA. Gentlemen, please put your hand together to welcome Dr. Yashwant Gade sir over here. Thank you. We are glad and happy to have a prestigious, respected Dean Madam from GMC Medical College who have gracefully accepted our invitation to be the chief guest for today's evening function. May I please request Dr. Dhue sir to escort Dean Madam to the dais, please. Thank you, ma'am. Dr. Gadegone sir, President, Maharashtra Orthopaedic Association, may I please request to kindly take a seat. He is also a course director. Sharing the course director is also Dr. Agashe sir. May I please request Agashe sir to kindly take a chair on the dais. Dr. Pramod Shinde sir, Vice President, Maharashtra Orthopaedic Association, may please take a chair on the dais. Those standing may kindly take a seat. Thank you, gentlemen. Thank you. Traditionally, the lamp lighting ceremony or inauguration has to be at the start of the day, but we had already worked throughout the day, and in leisure hours after having evening tea, we are having this traditional inauguration ceremony, and we are glad to have our chief guest, the Dean Madam, Mrs. Kaginalkar, who also happens to be a better half of orthopedic family. Welcome to you, ma'am. I also welcome our distinguished and eminent faculty, Dr. Sangeet Gawale sir, Dr. Now, in short while, I'll also welcome Dr. Chandak sir, Dr. Gawale sir, Dr. Sunil Kulkarni sir, Dr. Menon, and Dr. Ayesha Sonawala. Shortly, now may I please request the distinguished guest to help and do the lighting the lamp and declaring the sessions as open. Kulkarni sir, please. Dr. Menon. Thank you, one and all. request all of you all to please take your respective seats. Certainly at AOA, at the organizers team, we won't let this opportunity go by without felicitating our esteemed and distinguished guest. May I please request Dr. Mrs. Anjali Gade to come forward to felicitate our today's chief guest, Dean Madam Mrs. Dr. Kaginadkar. Thank you, Dean ma'am. Thank you, Gade ma'am. May I please request Professor HOD, Orthopedics, Dr. Lingaj sir to kindly come up to felicitate our MOA President, Dr. Gadi Ganesh sir. Thank you, Gadi Ganesh sir. Thank you, Lingaj sir. Now I please request Dr. Shiv Kumar Santpure to kindly come forward to felicitate Dr. Agashe sir. Thank you, sir. Thank you, Agashe sir. Dr. Santpuri sir, thank you. Please request Associate Professor Unit Head Dr. Anil Dhule to come forward to felicitate Dr. Yashwant Gade, the organizing chairman. Thank you, Gadi sir. Thank you, Dhule sir. May I please request Dr. Abhishek is here? Yeah, to come kindly forward to felicitate Dr. Pramod Shinde, Vice President, Maharashtra Orthopaedic Association. He is a very dynamic Vice President who is spearheading our MOA week celebrations throughout the state. A thorough gentleman. Thank you, Shinde sir. Thank you, Shinde sir. Now I'll take up the opportunity to felicitate our distinguished faculty. May I please request Dr. Parag Kulkarni to come forward to felicitate Sangeet Gawale sir. Thank you, Sangeet sir. We have been traveling intensely since morning, and we are grateful again, once again, to have you with us at Aurangabad. Thank you, sir. Thank you, sir. Thank you, Dr. Parag. Now may I please request Dr. Akshay to come forward to felicitate Dr. Sunil Kulkarni, sir. Dr. Faisal, sir. Where spine meets trauma, this is how I'll describe this. Faisal, sir, felicitating Dr. Sunil Kulkarni. Thank you, Kulkarni, sir. Thanks, Dr. Faisal. Now, please request Dr. Puneet is here. Dr. Puneet is not here. Dr. Sachin, please come forward. Dr. Sachin Sir Patel would be felicitating Dr. R.M. Chandak, sir. It was wonderful presentation. You saw him in the evening today. Thank you, Chandak, sir, for coming all the way. Thank you, Chandak, sir. Once again, thank you, Sachin. Dr. Gaur, please come forward to felicitate Dr. Menon. Dr. Adit. Thank you, Dr. Menon. We have seen some phenomenal presentations from Dr. Menon since morning, and glad to see some more tomorrow. Thank you, Dr. Menon. Dr. Gaur, thank you. May I please request Dr. Shubhangi Deori to come forward to felicitate Dr. Ayesha Menon. Oh, I'm sorry, I made a mistake again. Apologies, madam. Dr. Sunawala, please come. How important the microbiologist is to an orthopedic surgeon. We got to know it today. Thanks, ma'am. Thank you, ma'am. Thanks, Shubha. Now, may I please request Dr. Kapil to come forward to felicitate Dr. Sandeep Biraris. Sandeep Biraris, arthroscopist, arthroplasty surgeon, who is also a Maharashtra executive member. Thanks, Dr. Sandeep. Thanks, Kapil. Now, may I please request Gadi Gone sir to felicitate our own faculty from your Dr. Sanpure. Could you please come up? Thank you, Gadi Gune sir. Sanpuri sir, thank you once again. Dr. Gadi Gune sir, kindly stand up to felicitate Dr. Maruti Lingayat. Dr. Dhule sir, please come over. Thank you. Appraising your work and your efforts, Dr. Gadi Gune sir, a fatherly figure for all of us. He has been helping throughout, unconditional support. Thanks, Gadi Gune sir. Sir, kindly present. Dr. Girish Gadekar, he is with us here in the evening. Dr. Girish Gadekar. Dr. Faisal sir, please come up. Sir, these are the stars of tomorrow of MOA. Dr. Muqtadir is here. Dr. Shigedar sir, past secretary, MOA, a distinguished and renowned faculty from Jalna. Yes. Yes. Thank you, Shikidar sir. Thank you so much. Dr. Nahata sir is with us here, please. Thank you, Nahata sir. Thank you, so kind of you. Old time pulse. Dr. Pradeep Ji Kotadia sir. People ready to sleep on into big boots. All the best. Thank you, sir. He's traveled all the way from Solapur. He's here with us since morning. Thank you, sir. Thank you once again.
I request our president, Dr. Gadegone sir, to felicitate organizing secretary of this course, Dr. Sarang Devre.
आणि आपले कोर्स डायरेक्टर डॉक्टर आकाशे सर, तुम्ही उभे व्हा. मॅडम तुम्ही पण उभे व्हा, तुम्ही पण उभे व्हा. आणि आपल्याला सर्वात जी महत्वाची जी जबाबदारी सांभाळलेली आहे ते आपले कोर्स चेअरमन डॉक्टर गाडे सर, यशवंतरावजी, त्यांचा सन्मान करणं हे आमचं कर्तव्य आहे. कर्तव्य नाही तर ते आमची जबाबदारी आहे आणि ती आम्हाला पार पाडलीच पाहिजे. तुम्ही समोर या सर, समोर या.
Thank you, gentlemen. Thank you for patience evening, and thank you for being sitting patiently. Now, may I please invite Dr. Yashwant Gade sir to take over. He had been working on this tirelessly, immensely since last 1 month. He has single-handedly managed to generate most of the funds for this show. These are all behind the scenes things which hardly people get to know. But sir, let me admit it over here. You please can.
Thank you, Sarang. Good evening, respected seniors, friends, colleagues, ladies and gentlemen. My president of AOA, Dr. Maruti Lingayat, secretary, Dr. Anil Dhule, president of Maharashtra Orthopaedic Association, Dr. Vasudev Gadegone, course director, Dr. Vikas Agashe, Vice President, Maharashtra Orthopaedic Association, Dr. Pramod Shinde, Organizing Secretary, Dr. Sarang Devre, respected Dean Madam, Government Medical College, Aurangabad, and part of our family because she is wife of Dr. Jagannath Kaginalkar, who is an orthopedic surgeon. Some of you might not be knowing him. He is a very famous arthroscopic surgeon in Aurangabad, very dynamic, energetic surgeon. And therefore, Dean Madam is part of orthopedic family. So welcome, Dean Madam. All the respected faculties, Dr. Sangeet Gawale, Dr. Sunil Kulkarni, Dr. R.M. Chandak, Dr. Aisha Sunawala, Dr. Aditya Menon, Executive Committee Member, Dr. Shivkumar Santapure, Dr. Sandeep Biraris, who has come just today only to grace the occasion from Mumbai. Rest of all the members of Aurangabad Orthopaedic Association, the delegates who have come from Amravati, Paratwada, and from all across Kolhapur, Sangli, Satara, Pune, Nagar, respected
Sunil Nahataji, Executive Member of Maharashtra Orthopaedic Association, past Secretary Dr. Prakash Shigedar, Senior Orthopedic Surgeon Dr. Kothadia, ladies and gentlemen. It's indeed a great pleasure to welcome you all for this unique course of nailing and infection. Friends, when our president, Dr. Vasudev Gadegone, took over as the president of Maharashtra Orthopaedic Association on 1st of January 2022, we were under tension because Gadegone sir will keep entire Maharashtra at their running feet on academics only. He is the academician. When you visit Chandrapur, his home, you will find there is a big media internet room in his home, and he prepares every day new slides, records all his surgeries, and that is a very fascinating thing to watch working Dr. Gadegone. And therefore, I was very much under stress when he assigned that work me to work as organizing chairman of this course under his leadership. Therefore, I was very much worried. Within a one month time, we have to finish this job. And above all, Dr. Vikas Agashe is the stalwart from Hinduja. We respect him so much. When he called me that, Yeshwant, you have to do in 1 month all these arrangements. So therefore, it was a big challenge. I approached Sarang, Shivkumar, Maruti, Anil, and rest of the AOA members, and I found that it is a very good team which I got luckily, and we started working together with the cooperation of and able scientific program, excellent scientific program which was designed by Dr. Vikas Agashe and Dr. Vasudev Gadegone. We could send this program to all over Maharashtra as well as India, because this course is sponsored by Indian Orthopaedic Association. I am very much thankful to Dr. Ramesh Sen and our secretary, Dr. Naveen Thakkar. And they were very much, I even went to Mohali to meet Dr. Ramesh Sen when I went for IME meeting at Panchkula 15 days back. So it was a very fascinating story. To get Dr. Sarang Devre online is very difficult. Let me tell you. If you call Sarang after 9 o'clock in the morning, he will not be available till late night at 12 o'clock. We will call you before, or you can call him before 8 o'clock or after 12 o'clock. So he's such a busy person. Dr. Shiv Kumar, another team member, always in operation theater. He is known for that. Even he goes to the Prozone Mall in OT dress, because he doesn't have time for the family also. So he doesn't have the time to change the clothes, and he takes his kids and madam to the Prozone Mall, all the restaurants, even Rama Hotel also he comes in the operation theater dress. So that is the uniqueness of Shiv Kumar. Anil Dule and Maruti Lingayat were so instrumental in designing all these academic program and finalizing it with their residents also. So I am very much thankful to the residents of Government Medical College. Also, Dr. Girish Gadekar, another professor from MGM Medical College, was also helpful for organizing this scientific program, and along with his residents, professors, Dr. Rajendra Shivale, Mangesh Panat, and Ajay Moholkar, and other team. They were very much helpful in planning this program. Friends, it is very difficult to organize the financial aspect of such a small one-day conference or course. It is very difficult. So when we approached the pharmaceutical companies, they were very kind enough to support this academic activity. And you can see that on this side of the hall, as well as on that side of the hall, we have got almost 25 stalls, and thanks to the organizing team, we have helped to arrange all these stalls, and we can raise the financial aspect of this conference. Friends, we have kept the registration fees very negligible. You can see that arranging a conference at only 2,500 rupees nominal fees at a five-star hotel is very difficult. But because of the sponsors, we were able to manage the financial aspect of this workshop. Also, the residential package is very economical, and therefore we could room almost 30 rooms in this hotel. So that is a wonderful experience to work with all the team. I'm very much thankful to all the delegates, all the faculties, the chairman, course directors, Dr. Vasudev Gadegun and Agashi sir, as well as I'm very much thankful to Devre madam, Anjali Gade madam for helping us in planning all this event. Also, I'm very much grateful to my staff of Devre Hospital, staff of Santapuri Hospital, Lingayat sir residents, all they help a lot in this arrangement of this conference. Thank you so much.
Thank you, sir. We understand we are just behind the schedule. I'll request our president of the organization, Dr. Vasudev Gadegun, to thank you.
Sarvana Namaskar. Good evening, everybody. The dignitaries on the dais, Dean Madam, Agashi Sir, Vice President Pramod Shinde, President of this, Chairman of this organization, Dr. Gade, Dr. Devre Sir, and executive members. आवर्जून आज आमचे executive members महाराष्ट्राचे इथं आहेत. नाटा सर, कोटाडिया सर, संदीप बिरारी साहेब, past president, past secretary, Dr. Sigedar आहेत. आणि the very important is the esteemed faculty from Nagpur and Mumbai, Dr. Gawale sir, Kandak sir, Aditya Menon, सर्व लोकांनी मिळून हे कार्यक्रम आपण आज साजरा करत आहोत. ऍक्च्युअली गाडेसारखा अष्टपैलू व्यक्तिमत्व मिळणं फार कठीण. when I took over the charge, मी म्हटलं की whether you are in my executive or not, you will have to perform one task for me, and that is the CME in Aurangabad region. आणि त्या माणसाने उत्तर किती वेळा द्या, त्याच वेळी इन्स्टंटली सर करत आले. मे एक्झिक्युटिव्ह मध्ये असो की नसो, विल डू इट. So that is the confidence which gives to a organizing chairman of any Maharashtra state or म्हणजे president, की अशा प्रकारचे जीवाभावाला जोडणारे आणि जीवाभावाने मदत करणारे जर प्रेसिडेंटला लोक मिळाले तर महाराष्ट्राचा कायापालट होण्यासाठी काही वेळ लागणार नाही. We have started so many events, educational events like Young Surgeon Forum, and that was the first organization was done by the Maruti Lingayat. And so much difficulty, that was the time, because the first time we are conducting the Young Surgeon Forum. Now it is regularly going on each and every Saturday, and on Sunday master class that is mostly governed by the conduct Gawale sir and so many other seniors. So that is the most important thing, that I am conducting all educational activities throughout Maharashtra, and there is a representation to each and every district. Just now I talked to Dr. Nahata sir, Jadgaon and Khandesla आपण एक chance देऊ, and we will arrange for a Young Surgeon Forum, even Swapnil Kotadia, everybody, and they are very much willing to do, because they don't get a chance. Young surgeons, they don't get a chance, and we are giving the chance to all members, those who are interested in academical activities, not in a political activity. I am not a person to learn anything from politics of the Maharashtra Orthopaedic here. I am a student to learn educational activity from the members of the Maharashtra Orthopaedic Association. Actually, आज में तो दिवस फार चांगला आहे तुम्हाला सांगतो. When I started from Pune, and then रांजणगावला डॉक्टर इथं आलेले आहेत, संतोष दुंडे आणि नानवरे. त्यांना वाटलं की डॉक्टर गाडेगुन इज गोइंग थ्रू दिस रोड, तर त्यांनी ते रिक्वेस्टेड मी फॉर टी. आणि रांजणगावला मी त्यांच्या मंदिरामध्ये त्यांनी मला नेलं, गणपतीच्या मंदिरामध्ये, आणि मी आरती अटेंड केली. तर दिस इज द फर्स्ट बिगिनिंग. म्हणजे सुरुवातीला जर गणपतीचं दर्शन जर होत असेल तुमच्या सुरुवातीच्या दिवसाला, तर किती दिवस चांगला जात असेल याच्यावरून तुम्ही कल्पना करा. म्हणजे आज दिवस हा संत समागमाचा दिवस आहे. आणि आगाशे सर तुमच्यासारखे संतच लोक आहे, तुम्ही लोकांना शिकवताय. म्हणजे संत काय करतात, ऍक्च्युली दे एज्युकेट द पीपल अ गुड थिंग, आणि वी आर डुइंग द सेम थिंग. समागम आपल्या जवळ आहे, आणि त्याबरोबर आपल्याला आज गणपतीची साथ मिळालेली आहे. असं दुग्ध सरकार योग कधीच मिळणे शक्य नाही. म्हणून मित्रांनो, प्रगती करायची असेल तर प्रोफेशन मध्ये यू शुड बी एक्सलंट इन द अकॅडमिक्स. and there are the examples where they come here and teach you. प्रत्येक गोष्ट इन कॉन्फरन्सेस आय वेंट टू द यूपी, आणि रात्री कालच आलो उत्तर प्रदेश ऑर्थोपेडिक असोसिएशन 600 लोक रजिस्टर्ड झाले होते. आणि त्या हॉलमध्ये दिस इज द मोस्ट सक्सेसफुल, आय टेल यू, आयोएकॉन मध्ये सुद्धा एवढे लोक बसलेले राहत नाही. याचा मला आनंद आहे की तुम्हाला सर्वांना आजचा प्रोग्राम कदाचित आवडला असेल असं माझा मन सांगत आहे. तर युपीकॉन मध्ये तुम्हाला सांगतो, तिथं लोक हॉलमध्ये खुर्च्या 600 आहेत आणि लोक 100 बसलेले नाही. आणि संध्याकाळी दारू पिण्यासाठी असा लोक जमले, तुम्हाला काय सांगू, म्हणजे तिथं जागा मिळत नव्हती. आणि दिस इज हाऊ द सिनेरिओ. परंतु माझ्या वन थिंग आय एम टेलिंग यू, सक्सेस इन ऑर्थोपेडिक देयर इज नो शॉर्टकट. लोकांनी आयुष्य घालवलेलं आहे शिकण्यामध्ये. रियाज, जसं रियाज, आणि बिस्मिल्लाह शेवटच्या मरणापर्यंत तो की नाही बाजू रियाज करत होता, तसं तोपर्यंत रियाज करणार नाही. Everything not showing only on the bone matter. You have to see on the cadaver. You have to perform the surgery on the living bone, and then you will go for perfection. Success will go to the practice and learning a perfect technique and from the perfect person. Don't go into the controversy. First, you good knowledge from the textbook, and then you read your tentacles for a additional thing. So, सर्वांना माझा अत्यंत मी तुमचा ऋणी आहे की तुम्ही इथे जमा झालेले आहेत. महाराष्ट्रातील दर महिन्याला मी कार्यक्रम घेत आहे. आता नांदेडला घेणार, त्याच्यानंतर मी धुळ्याला घेणार आहे, त्यानंतर मी अहमदनगरला घेणार आहे, त्याच्यानंतर मुंबईला घेणार आहे, त्याच्यानंतर सोलापूरला घेणार आहे, आणि त्यानंतर कॉन्फरन्स होणार आहे. Those who are interested to contribute in Young Surgeon Forum, please try to contact me or Dr. Tandak or Dr. Pramod Sindhe or anybody who will help you and will give a platform for your educational activity. So, मॅडम, अंजली मॅडम, तुम्ही आमच्यासाठी, आणि देवरे मॅडम, तुम्ही आमच्यासाठी हे 2 सोडले महिनाभरासाठी. मी तुमचा सुद्धा ऋणी आहे. आणि दीन मॅडम, तुमच्या व्यस्त याच्यामधून तुम्ही आले, थोडे बसले, आमचं ऐकलं, त्याबद्दल सुद्धा मी तुमचा ऋणी आहे. आणि सर्वांचा मी ऋणी आहे. धन्यवाद. धन्यवाद.
हाडांचा शिक्षक. Thanks for the kind words. We highly appreciate. Thank you for giving Aurangabad an opportunity to host this, sir. And, we wish many more limits in your career in the coming tenure. Thank you, sir. सरांनी म्हटल्याप्रमाणे अजून रिक्वेस्ट another 5 minutes of patience. तुम्हाला टीम ऐकायच्या अगोदर एक 5 मिनिटं संत विकास आगाशे यांचं आपल्याला प्रबोधन 5 मिनिटासाठी ऐकायचं. सर प्लीज.
Dean Madam, IOA and MOA, all the faculty, Dr. Mrs. Gade आणि Mrs. देवरे आणि सगळ्यांना, खरं म्हणजे आय एम रिअली ओव्हरवेल्म बाय दिस रिस्पॉन्स, दिस हॉस्पिटॅलिटी आणि दी अटेंडन्स अँड इंटरॅक्शन. I thank you very much. Thank you.
Thank you, sir. Being a course director, he has been constantly advising us and guiding us throughout the WhatsApp chat. Agashi sir and madam परवाच US मधनं आले. Just 3 days ago they were traveling. They traveled throughout the 24 hours flight. एक मुंबईत 4-5 तास थांबले असतील आणि परत पुढची फ्लाईट घेऊन औरंगाबादला आले. Sir, salute to your commitment. Thank you, sir. Thank you once again. Now we come to the concluding end, and I request our esteemed distinguished chief guest, Dean Madam, Dr. Mrs. Kaginalkar, Rote Madam, to kindly enlighten us and guide us. Thank you.
Good evening, dignitaries on the dais, all the office bearers of MOA and Aurangabad Orthopaedic Association, and the dignitaries in front of me. I must not have been invited by any other society so frequently than Orthopedic Society. Needless to say, we share a bond and we are very comfortable both ways. So thank you so much for inviting me for today's function. Dr. Gade, Dr. Devro, Dr. Linga, and Dr. Due, and everyone else. Thank you so much. It's so nice to see everyone else sitting in the hall in person after so long. And I hope those old golden days have come back. Nevertheless, the fourth wave is still pouring on our heads, but I shall say it will never come. It shall never come. And may our meetings go on the way the meeting today. Corona has taught us many things, and this is one. There are many trivial things we used to feel, and those are, and now we remember or recognize them to be the most important things. And one of this is meeting in person, sharing our thoughts and sharing our thoughts and feelings with each other. So I wish a very big success to the conference and all the best to you all. And since academics is the core of our profession, and the academics is being celebrated here on this forum, Aurangabad Orthopaedic Society is a very active society with so many active members. I wish them all the best, and thank you so much for inviting me here. Thanks.
Thank you, ma'am. Thank you for those kind words. Dean ma'am has been extraordinarily supportive to all the academic events of whatever faculties they come across, but orthopedics have certainly enjoyed her patronage and above also rest of the faculties. Thank you, ma'am, once again. Before I conclude, I once again with folded hand thank each one of you here for traveling all this while.
तर एक थोडीशी सर्वांना नम्र विनंती आहे. उद्या आपलं एमओए डे सेलिब्रेशन फाउंडेशन डेचा आहे. लंच नंतर 3 वाजता थोडंसं अर्ध्या तासासाठी थांबा. कलेक्टिव्हली विल सेलिब्रेट द फाउंडेशन डे ऑफ महाराष्ट्र ऑर्थोपेडिक असोसिएशन टुमारो इन द सेम हॉल ॲट 3. 2 वाजता जेवण आहे आणि 2:30 ते 3च्या दरम्यान आपण हे करू. 4 वाजता तुम्हाला रिलीव्ह करू आम्ही. तर सर्वांनी जॉईन व्हावं अशी माझी नम्र विनंती आहे. आणि दुसरी एक विनंती आहे की महाराष्ट्र ऑर्थोपेडिक असोसिएशनची कॉन्फरन्स गोव्याला होत आहे 6, 7, 8, 9 ऑक्टोबरला. त्याला रजिस्टर व्हा. आणि इथं ज्या हॉलमध्ये काही लोक जे आहेत ज्यांनी महाराष्ट्र ऑर्थोपेडिक असोसिएशनची मेंबरशिप घेतलेली नाही आहे त्यांनी कृपा करून या महाराष्ट्र ऑर्थोपेडिक असोसिएशनचे मेंबर बनावं. बस अशा 3 विनंती करून मी डॉक्टर देवरे.
Thank you. In short while we'll be dispersing, I invite all of you all to join us for the banquet in the evening. We'll be starting our sessions tomorrow morning sharp at 8:30. So humble request to all of y'all to kindly pull up your socks. Don't delay. In the morning 8:30, we'll be eagerly awaiting all of y'all over here. And special thanks to our faculties, Dr. Sangeet sir, Dr. Sunil sir, Dr. Chandak sir, Dr. Aisha madam, and Dr. Adit. Thank you once again. Thank you, gentlemen. We disperse for the evening. In short time, we'll gather here for banquet. We do expect inputs. We'll certainly love to have inputs from all of you all. Inputs will certainly help us improve. Yeah. Before we disperse, may I please request everybody to stand for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा हिमाचल यमुना गंगा उच्चल जगति तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य